working well, but has not matured. Fistula failure is still, it is to the tune of 20 to 30%, even in the best hands. So, if fistula has been made, it has matured, and you started using it. You started using it, but now you are facing the complications of juxta-anastomotic anastomosis, juxta-anastomosis stenosis there, and we have got trained nephrologists, vascular surgeons, and urologists who can take care of these complications. They can do angioplasty of the fistula, and they can do angioplasty. So this conference was designed to focus on these issues, that if there is a complication of aneurysm or thrombosis or stenosis, how should we manage these complications? And the aim is to manage this complication and make the fistula survive for longer time. But despite doing and taking care of all these things, what I have seen or what literature says, that fistula, there is some problem somewhere. It is not a true story that if you go like this, the fistula will be matured and it will remain functioning for 5 to 10 years or more than 10 years. So Dr. Mahendra and Dr. Himanshu designed a scientific program so that how can we make the there is some genetic predisposition also for the development and good functioning of the fistula. We have got topics related to genetics, how for long time, and at the same time we have got talk on related to AI, which is going to focus on AV fistula and how we can improve with the knowledge of AI in making fistula a permanent one. It is a permanent solution, but permanent, now we will have to define and redefine it, that any fistula which works more than 10 years will be a five international speakers who will join us on Zoom. This I am just giving you a glimpse so that everybody takes interest and gets enlightened with the knowledge which the conference is going to impart, and the hard work which the organizing team has done to make you enlightened and knowledgeable after the conference. We should go with something take home from this conference, and that is going to uplift the management of CKD patients who are on dialysis. And I hope you will all enjoy the hospitality of Lucknow and those who are going to participate, and the culture itself of Lucknow is good. And if you go for a blend of Varanasi and Lucknowi Tehzeeb, it really makes it एक और एक 11 हो जाता है. So maybe I expect that we will be able to offer the hospitality of Varanasi, Kashi and Lucknow, and we'll have more things in the coming few hours to get these things by the distinguished speakers. And with these words, I welcome you all once again, and I would like to stop here, and I would like to hand over the mic to Sima so that she starts the scientific program.
Thank you, sir, for your very motivating words. And with this, we are starting with our scientific program. I would like to share a few housekeeping instructions before we start with the scientific program. Would request everyone to please switch your mobile in a silent mode to avoid any disruptions during the conference. A quick reminder to our pharma colleagues at the back to please maintain complete silence during the conference. To ensure we cover all the topics and give each speaker ample amount of time, would request the cooperation that we keep the talks within the stipulated time frame. We have the privilege of hosting some speakers from various time zones across the world. So would request, in case if there is a delay in the sessions, we would be giving priority to our virtual speakers joining us from different time zones. And our speakers who are physically present with us, we appreciate your flexibility in allowing us to adjust the order if required. So with this, I start with the first session, which is on the theme of Access Essentials, Planning and Pitfalls. And I welcome and invite our chairpersons on the dais. Can I please request and welcome Dr. Apurva Srivastava, Consultant Vascular and Endovascular Surgeon at Sir Gangaram Hospital, New Delhi. Dr. Sant Pandey, HOD and Director, Chandan Institute of Renal Sciences and Kidney Transplant, Lucknow. Dr. D.K. Sinha, Senior Consultant Nephrologist at Heritage Hospitals, Varanasi. Dr. Ajay Pal Singh, Director, Nephrology and Kidney Transplant at Apex Hospital, Jaipur. Dr. A.K. Singh, Senior Consultant Nephrologist at Midland Healthcare, Lucknow.
Good morning all. Our first speaker is Dr. Ashutosh Kumar Pandey, Chief Consultant and Head, Vascular and Endovascular Surgery, Tandon Palm Hospital, Lucknow. He covers the AV access planning and management that should never be missed. Dr. Ashutosh Kumar Pandey, come please.
So, good morning everyone, and very warm welcome to all of the outstation delegates to Lucknow. We'll be talking about subtle signs which are not to be missed during the course of an AV fistula to prevent dysfunction. So, recognizing a fault within a fistula before creation or during working is the most important thing to prevent failures. I have nothing to disclose, no intellectual property violations have been done. So these are the basic signs which always predict that something is not good with the fistula, and something which we learned from the nephrologist that we should also have a look on the dialysis machine. We should be knowing what are the pressures there, how it goes, because that's a major part of recognizing dysfunction. So as everybody knows, it's the reliable access, and once we recognize these signs early, we can prevent dysfunction. And most important thing, if we detect early, is we get a happy patient. We see a patient with failed fistula, if we discuss with him the kind of psychological burden it creates, there are many patients who never go again for permanent access once they have a bad dysfunction or a bad history of fistula. So that is why we should recognize it at an early stage, so that with less number of interventions, we can give them a healthy access. So as we always tell about complications, most of the fistulas have not failed suddenly, we noticed late. Except for some cases here. There are cases where sudden hypotension happen, acute thrombosis, but if there is some chronic problem, something was missed either in the creation or during the follow-up. So when to observe? It starts from pre-operative. The signs of failure can be seen from pre-operative, immediate perioperative, post-operative, and during use. We'll briefly cover those points. The most important factor pre-operative is consent of the patient. So it should not be like if somebody has been referred to us for a fistula, we just plan it. We have to talk to him. We have to let him know how it affects their livelihood. Will they be able to continue their work? And then their commitment to do physiotherapy. The second point is frailty. So this patient in the picture, even if she has good veins, we will be looking whether she has good hand power, she has good hand pulses, that even the best access can survive or not. And then seeing if any other interventions were done in the index hand. So these are the factors which are very important, which we see in the counseling time. So these are the pre-op signs. If a patient walks in the OPD, so it's not always hand examination. If we have dilated veins in the chest wall, and surprisingly they can be there even in the absence of previous catheter. There are etiologies like thoracic outlet syndrome with subclavian vein thrombosis, and we see a lot of patients. So these are nightmares to happen, especially in patients who are not started on dialysis and then we end up giving them arm edema. Then the second patient, very nice veins in hand. Now these are the most dicey patients. If we do a nice Doppler, none of these veins will be continuous with the central system. So very nice veins are sometimes not nice. Any sign of distal ischemia needs to be evaluated, and any sign of thrombophlebitis. So whenever we do a Doppler, a basic point of care Doppler, these are the two things we have to see. The first waveform is a triphasic waveform. That's what we want. If the patient is having a biphasic or a monophasic flow in the arteries, you have to evaluate if there is any proximal obstruction. This is not going to give a very good result with the fistula. When we do a venous ultrasound, if we see any clot inside or non-compressibility of the vein at any point, the cephalic vein system, now these are the veins which we have not to consider for fistula. So intraoperatively, what are the factors which predict that this fistula is not going to last well? So this mostly comes from experience. If we see the artery going, especially in radiocephalic fistula, if we notice that the artery is going into a spasm or there was poor flow, it improved. These are the fistulas which end up with in a low flow state, or you end up with a juxtaanastomotic stenosis resulting from the thrombus burden. If there is a pulse in AVF, so this is a very important point. If we are creating a fistula and the thrill is not felt, it's heard by stethoscope, believe me, it is not going to work. It is going to require a secondary intervention. So by policy, it has to be that if we have created a fistula, if we want to tell the patient that this is going to work, there should be a thrill in the fistula. So a hum heard by stethoscope means very rare chances it's going to mature. A poor back bleed in the artery, especially in radiocephalic fistulas, most of the time the ulnar blood flow also contributes. So poor back bleed in the artery is also one of the predictors where thrombosis can happen. Now these are very readily available vein probes. So either you can use these vein probes, they are very atraumatic. Otherwise, infant feeding tubes are used very commonly in all the centers, but sometimes infant feeding tubes, especially in phlebitic veins, can cause trauma. So they are not very costly, and we can just pass a vein probe in the vein. If it is continuously going for a length and there is a smooth passes, this is one of the predictors. Because everybody doesn't have an access to Doppler, so at least this will give us an idea that the vein is continuous. So if these are there, the fistula can succeed. Now, there are two things. There is a bleeding AVF immediate post-op. So we have to find, usually there is some bleeding from the skin edges in some fistula. But if there is a significant bleed which happened from the anastomotic side, even if we correct it surgically, we have to be wary that there is some proximal obstruction in the vein. So what exactly happened? The moment the flow increased in the fistula, the proximal obstruction played its role, and there was some bleeding from the anastomosis, and usually sometimes a branch which was tied gives off. So whenever there is significant bleeding or any patient who underwent intervention, we have to be cautious in these patients to rule out any proximal obstruction. Eventually, most of them will need some sort of intervention for the proximal lesion. A severe pain immediately after fistula is one of the warning signs, and these are the patients whom you have to watch for steel. Then there is a category where there was very good thrill or okay thrill, and after 1 or 2
venogram or invasive venogram, and whether pre-op or post-operative intervention. These are my references. Thank you.
I now invite the next speaker, Dr. Ujjwal Kumar Pathak, who is an assistant professor in the Department of Urology, Banaras Hindu University, Varanasi.
Good morning. At the outset, I would like to thank the organizers for giving me the opportunity once again to share my experience. And I am going to talk about AV fistula access, the BHU experience from the Department of Urology. I learned AV fistula making AV fistulas after my residency. After completing my MCH residency, I learned AV fistulas during my assistant professorship at IKDRC Ahmedabad. And when I joined BHU, AV fistulas were being made in the Department of Plastic Surgery and CTVS there. So this topic is quite close to me because I thought that I should continue making fistulas, and I started the AV fistula program in Department of Urology there. And now we are making a good number of fistulas with the resident training also going on in it. To introduce these, as we all know that an AV fistula is a surgical connection that is made between an artery and a vein, typically in the arm, to facilitate hemodialysis, and its importance is that it is a gold standard for vascular access in patients requiring long-term hemodialysis due to the longevity and lower complication rates. It has a role in hemodialysis, and the advantages are that it has lower infection rates and fewer complications, and it provides a better blood flow rate as compared to grafts. These are the NFK guidelines that has already been discussed, that the creatinine more than 4 milligram per deciliter or creatinine clearance less than 25. And if the patient is anticipated to undergo dialysis in the next 1 year, AV fistula should be made. Individualized approach should be the role, and the principles of fistula creation are very simple, as these are: AV fistulas must be accessible with the patient in comfortable sitting position. The non-dominant arm and forearm should be the first choice, and fistula should initially be done as discreetly as possible, and one should avoid vein punctures on the desired side in which the patient has been planned for AV fistulas for 3 months prior to fistula creation, and the AV fistula should be 5 to 6 mm from the skin surface. Now, what I have learned from the vascular surgeons and my post-residency days, that the 3 basic things that we need to be equipped and know for AV fistulas are that the use of surgical loops, AV fistula mapping, and a proper ESRD life plan to be discussed with the nephrologist. What we expect when a patient comes for a vascular access, we expect this kind of a vein. But what we get actually in our real-time practice is this. Generally, the patients don't have the veins that we are able to basically even visualize and get an assessment of what we are going to do with the patient. So the vascular tips and tricks that I would like to share from my side are that a good vascular instrument, proper designated set of instruments. Because I am from the Department of Urology, we have other various loads of surgeries to be done. So getting a proper different set of instruments for vascular access is the key. And what I generally use, as Dr. Ashutosh has said, that he uses a vein probe. But since we don't have the access to it, I generally cannulate the vein with a 5-French infant feeding tube, and I flush it with heparin saline. And the other things that I would like to share is that minimal intimal handling, and for RC fistulas, I generally do a side-to-side anastomosis with tying the distal end after the anastomosis is complete. And for BC fistulas, I do an end-to-side anastomosis. And the suturing should traverse all the 3 layers of the vessels, and the suturing should have the eversion of edges of anastomosis with proper branch ligation. The second point that I would like to emphasize is AV fistula mapping the before surgery. Ideally, it should be done by a surgeon, but since in our department we are trying to procure for a Doppler probe, right now it is being done by the Department of Radiology in our center, and there are a few consultants and few residents whom I am in regular touch, and generally I prefer them to do my fistula mapping, and I want them to give a picture as I have shown in this one for the location of the vessels, the diameter of the vessels, the patency, and the elasticity. The rule of 6 that I would like to share, everyone knows that an ideal fistula should have a flow of 600 ml per minute with a vein diameter of 6 mm depth from the surface, and generally, ideally, the maturation time should be 6 weeks, but we all know that it's always not the same, and at least we should have a 6 centimeter straight segment of the vessel for cannulation, and 6 monthly follow-up of using an AV Doppler needs to be done. These are the various AV fistulas of the forearm, because of the AV fistulas of the cephalic vein that can be done in the snuff box, or the discal relief RC fistulas, or the proximal RC fistulas, AV fistulas of the basilic vein, discal basilic, proximal basilic. And as I have already said, that for radiocephalic or forearm fistulas, I do a side-to-side anastomosis with ligation of the discal segment of the vein. the AV fistulas of the cubital fossa and upper arm, the anatomy of the, and all applied experts have already been discussed, and we all know the principles of AV access in the cubital fossa is generally the anastomosis is always an end to side, and only the vein that is better suited for puncture should be used. Either it's a cephalic or a basilic, depending upon the pre-op Doppler that we have done. And if neither is suitable for puncture, both should be arterialized. If both unsuitable or occluded, D veins may be arterialized with transposition, of which I am going to learn in future. These are the principles of selecting the vascular access in general for AV fistula in CKD patients. Generally, the CVCs are used initially, arterialization of subcutaneous vein. AV fistula as the most critical are the preferred ones. This is the order of preference that I generally follow. And generally, I would like to place the AV fistula first of all in the non-dominant forearm cephalic vein. And if the vein is poor or if somehow the fistula fails, then I would like to do the forearm fistula of the dominant hand. Then I go upwards of the non-dominant upper brachiocephalic or brachiobasilic, followed by dominant brachiobasilic and brachiocephalic vein. Now I would like to share a few pictures of my technique that I generally use for my anastomosis. In RC fistulas that I have already discussed, that I generally do a side-to-side anastomosis with tying of the distal vein after the anastomosis is complete and before releasing of the clamp. So this is the RC fistula in which the artery and vein are held side by side, and I do a continuous anastomosis, and then I tie the distal branch. This is what the picture at the end of the row. And regarding BC fistulas, the incision is given in the in the arm, lower part of the arm, just above the cubital fossa, and the brachial artery is mobilized for about 4 to 5 centimeters. The cephalic vein is elevated, mobilized, and generally we ligate it. I put an infant fluid into 5 French with heparin saline in it, with intermittent flushing of the heparin vein, and then I do an end-to-side anastomosis using a Prolene 60 or 70 suture, depending on the vein caliber that I feel comfortable. And this is the way I go. I continue from the proximal to the distal end, and then again I take the second layer from the proximal to the distal end. I flush the vein, and I close the AVF. This is the care of AV fistula that I generally advise to my patients, keeping the fistula arm raised on the pillow to reduce swelling, and isometric arm exercises as soon as the surgical pain subsides. Even in fact, I ask my patients to start the isometric handball exercise immediately after the patient he comes out of the operation theater, because most of the fistulas are made under local anesthesia. And I advise the patient not to allow any BP measurement, blood drawing, IV injections on the fistula arm. Another thing that I say, that the patient should avoid sleeping on the arm on which the fistula has been made, and the patient is advised about regularly examine for thrill and adopt an hygienic and proper cannulation technique is what I advise my dialysis technicians in the Department of Nephrology. This is a short data that I would like to share from the Department of Urology. Since I joined in August 2021 to December 2023, that is a year back, I have made about 308 AV fistulas, of which the radiocephalic were 227 and brachiocephalic were about 81. And the average age was 56 years, male were 239. The average radial artery diameter that I got in my cases were 2.2 plus minus 0.3 mm, and the cephalic vein diameter at forearm was 2.1. The brachial artery diameter that I got was 3.5. And the cephalic vein diameter at elbow that I got was 3.1 plus minus 0.5 mm. The total AVF of 308, intraoperative thrill was present in about 297% of the patients, and on follow-up, about 294 patients at 4 weeks had thrill. But moving down the line, when I followed my patients for the next 6 months, there was about 32 patients dropped out and were lost to follow-up. The total AVF was 262, out of which functioning AVF were only 234. And at a follow-up of 12 months, the total AVF after the loss of 17 patients to either lost to follow-up or in 3 of the patients needed AV fistula aneurysm ligation. The total fistulas that I followed were 217 and total functioning fistulas of 197. So at 12 months, the patency rate in my experience for the past 2.5 years, that is up to December 2023, was about 76% with patients, after excluding the patients that were lost to follow-up and whom I couldn't follow for. The complications that I have, basically I have encountered as the aneurysm in nine patients, in which one was brachiocephalic fistula, 8 were radiocephalic, and these 8 radiocephalic fistulas, 3 came after bursting of the aneurysm, and all of them required ligation of the fistula. Upper limb edema, another common problem which I have been encountering in my brachiocephalic patients, I saw in 5. Since at our center we don't have the IR, interventional radiology, or the cardiology department intervening with endovascular dilatation of the central veins. So these patients are very difficult to manage, and I need help of my vascular surgeons. Generally, I refer to them for dilatation and stenting for these upper limb edema patients for central venous obstruction. And one patient of BC fistula had the scale phenomenon, and eventually I lost the patient to follow-up. She didn't come after 3 months, the first time when she showed to me. These are some of the fistulas, and these are the patients that I, generally the patients whom I make fistulas, I want their first or second cannulation should be under my presence, so that I also get an assessment of how my fistulas are working and what is the status of the flow that my patients are getting in the patients. Recently, after attending the last 2 RRT updates at Delhi, I would like to thank my vascular colleagues and the organizers that I was able to do a vasculobasilic transposition in one stage with one of my CTVS colleagues. Because of the OT issues, I went in there and we did a brachiobasilic transposition. This is done 3 months back, and on follow-up, the patient is having a good thrill. So my future plans for that, I plan to basically improve my skills and give a better patient care in AV fistula, is that I have already ordered for a Doppler probe for self-assessment of vessels, which right now is being done by the Department of Radiology, as I have discussed. So to have a proper AVF mapping to be done by myself. I plan to start AV grafts in future, and I'm having a talk with few of my new cardiology colleagues who have joined in the Department of Cardiology at BHU to start central venography and dilatation of the central veins, because some of the BC fistulas we see, as we all know, we have been discussing, the central venous narrowing leads to massive edema, in fact elephantiasis of the upper limb. So these patients can be taken care of. Thank you.
Thank you, Dr. Pathak. A very impressive and lucid talk, and your experience and your results of AV fistula is good. Just a question from you: how many of fistulas from you made are the redo or after the primary failure?
So this data doesn't contain the patients in whom I made a secondary fistula after failure. This is of the patients whom I have made a primary fistula. Definitely there are patients who have failed and in whom I have made a distal RC, I had to make a contralateral RC or upper BC. That data I have not included because the data was not compiled by me.
What's your experience in these patients in whom you made the second fistula?
Sir, in my experience, generally after I have made a RC fistula in the non-dominant hand, and since I follow the protocol that if the non-dominant hand RC doesn't work, I go on to the contralateral side. So generally I have found that the dominant hand veins are better developed as compared to the non-dominant hand, and making a fistula on the dominant hand if the patient is not being using it for IV cannulation, obviously, because that I generally to all my patients to whom I plan or whom I give a date for AV fistulas, I ensure that blood sampling is done by, generally I advise either you have a CVC, you use it, or you have to use the veins distal to the wrist in the right hand. So generally I have my right so-called dominant hand upper veins preserved. It's not a 100% rule, but generally I found that the contralateral RC fistula is doing quite well because I avoid going to the upper part of the arm, because again the issue of if some kind of a complication arises, we have some problem with getting the immediate OT and OR rooms in the emergency. So I generally follow a contralateral RC followed by a BC. And generally a BC fistula has good result, that we all know, because the veins, artery, all are good. But for basically my practice is to make ensure that I go on for RC fistulas first, as far as possible, then I shift to the proximal parts.
Sorry to interrupt. I'm Dr. Himanshu. I'm a vascular surgeon, and I'll be the one who will be keeping eye on the timings. We are running short. We are going to take 2 more questions. Answers has to be precise, and because our speakers from the US are online and they've been waiting, it's almost near to midnight for them. So, quick questions.
Yeah, my question is to Dr. Ashutosh. So, Dr. Ashutosh, if in your practice, if we ask you, what is the most commonest sign that has been missed while creating an AV fistula? So this is regarding your presentation. So what is the most important aspect that you have to check before creating an AV fistula?
If I talk about data, the most common thing which I see getting missed is the assessment of the proximal system. So either it's in the form of assessment of the central veins or the assessment of the proximal vasculature. That's something which has got missed many a time, especially when we do large volume cases, especially in Gorakhpur. We miss out on those aspects. So missing the continuity of the vein.
Right. So in our practice also, that is the most important sign that is missed most of the times. Okay. So a good Doppler should also include and always include an assessment of the central veins and physicity of the central veins also, not only the arm veins. So that is very important for planning.
So over the past 2 years that I have made sure at least one major vein in the arm, and I check for respiratory physicity, especially in patient with history of interventions, and then some signs are there. So we're trying to look for that. Still we miss out on some patients.
Okay. And my second question is to Dr. Neelam for catheters in the central veins. So whenever patient presents to you with the signs of venous hypertension, so as a routine you advise them a CT venography, or in some cases you may skip a CT venography also and proceed directly with the procedure.
So actually it depends, because most patients, ideally I would prefer personally to do a CT venogram first, because in that way I can explain and properly plan what to do next. But if there are centers, of course, who do have the facility to do a on-table venography and address the central vein stenosis at that time itself, then yes, that would be a better option.
So right, so if we skip a CT venography, we save a lot of contrast and patient's money. Okay, so our preference is, we do very rarely CT venography. See, the patient has come to you with symptoms of venous hypertension and you have to do some treatment. So the better bet is, if you have the facility, directly plan for a on-table venography, and whatever needs to be done, do a plasty or a stenting at the same time. So that saves a lot of money of the patient.
Okay.
I think I totally agree. The point is that doing CT versus venography has been a question of debate across the world. The point is, a lot of time it comes, okay, we don't have a setting. But the required bit of venography you can even do in your operation theater with the C-arm. Okay, and once you do it, we believe we are going to stop doing CT venography, because you see the dynamics, you see the blood flow going, you see the collaterals forming, and then you also see the feasibility. Will I be able to do, if required, will I be able to tackle it endovascularly? And if yes, how is it going to be? You know? So, I think thanks a lot for everybody. I would like to call speakers also, and Dr. Amit Gupta sir to come up and felicitate all the speakers as well as chairpersons, and we can come on the center for the group photo also. The next session is very exciting, and we have two interesting speakers from the other part of globe. And there's one interesting story which I only got to know last night. We'll be sharing about that. Uh,
going to talk about the
uh,
story that
Doc, Professor Anil, we are right now. I think you cannot see probably. It's a bit glitch. We are in process of felicitating. We are getting to the previous session, but it was surprisingly wonderful to hear that the Emmy was your vascular access nurse. And this was, revealed only when I shared the final program yesterday, probably.
yes, you're right. So I was very fortunate to have Amy as my nurse manager for the whole dialysis unit at the time. And I didn't realize that we were going to speak at the same time in the same session, one after the other.
That is some coincidence.
Yeah. Yes, it is. Just let me know whenever you are ready.
Yeah. So thank you, everyone. Professor Amit Gupta, sir, you can please actually stay back. You are one of the chairpersons for the next session. I would like to call Dr. Sakshi Zain, Ms. Chandrakanta, and Dr. Shahzad Alam also to join on the chair as a chairperson. So this is, when I was kind of designing the program, few things are extremely important, which when it comes to access, it's about planning, and surveillance. So the next speaker is Professor Anil K. Agrawal. He has got a deep roots connected to Lucknow. So welcome to Lucknow, sir. He's a nephrologist and interventional nephrology at Fresco VA Medical Center, California, USA. Sir, over to you.
Thank you very much. Good morning, ladies and gentlemen. It's really my pleasure to be here, and I would like to thank Dr. Professor Rai, Professor Verma, and all the organizers for inviting me to talk about vascular access monitoring. So, I wanted to say that I would rather be here personally. Lucknow is my birthplace, and been there a couple of times, but recently to talk about something. But then it was my pleasure to be able to talk to you tonight. So, first of all, as an interventional nephrologist, it is really close to my heart that vascular access be monitored very well. These are my disclosures here, some consultancy, editorial roles, and organizational roles, including ASDIN and ISN. What I'm going to do very quickly is define what is monitoring and what is surveillance. I know that this audience doesn't need much of that, but just to refresh the memories. And I'll discuss monitoring of dysfunctional vascular access and implementation of vascular access program. So as you all know, in fistula in graft are considered superior to capsular access. Now, having said that, ideal vascular access still remains a fantasy because these fistula and graft are not without problem. Obviously, they're better than the catheters, but then they have significant shortcomings. So what are the common issues with AV access? Number one, the guideline 13.1 and 13.2 recommended that one should do regular physical examination. It should be done by an experienced practitioner. And 13.3 also focused on the training of nephrology trainees and practitioners in examination of dialysis access. Now, Fistula First, if you remember Fistula First back in around 2002, 2003, I was part of that. They suggested that monitoring and maintenance, something like endoscopy, should be done to ensure adequate access function, and the post-operative physical evaluation of new fistula should be started in 4 weeks. So I will not go over all the guidelines because every guideline pretty much has very similar recommendation. So what are the advantages? Why do we want to do monitoring? So one is it will detect stenosis, manage it. It will keep the access patient, reduce the number of catheters. That's a big issue. You are seeing all these central venous stenosis and issues related to infection. Those could be reduced with reduced catheters. It also avoids under dialysis because with the stenosis you don't get good UR or KUOD. And it reduces missed treatments. Very important for the dialysis provider because now that chair goes empty and they lose revenue, at least in the United States, that is very important for them. And it improves the quality of life. At least in the United States, and you can tell you, patients show up at 6 o'clock or sometimes 5:30 in the morning, and if the access is flooded, the first thing is that they pick up the phone and they call me, Dr. All the access is flooded, what should we do? Now this was not only the nurse's quality of life, my quality of life, and also the patient. For patient, it is really much bigger than just that. There are a number of things that they were going to do that morning, but now they did not do that. So it really is essential for improve quality of life to maintain access function. And monitoring is really easy and economical. So KOD does not even say that we should do surveillance. They just say, okay, we should do monitoring. So when should you start? Begin at the 4 weeks after creation of evaluation of fistula replacement. I generally do not even wait until 4 weeks. I'll start looking at it 2 or 3 weeks. If you really, with the experience, you can tell which fistula is going to mature, which one is not. So you don't spend enough time, a lot of time with the catheters. And rule of sixes of harder than towards one and those can give you an idea of which access is going to mature or is mature. And you should begin monitoring the first week. So it's now coming to what should you do in terms of a monitoring program. So I trained in India, and the physical examination, history and physical examination, those were the most essential things anytime you saw a patient, doesn't matter what it belonged to, vascular access or something else. So it is very important to know if there were prior central venous catheters. If you don't do that, we were just talking about central venous stenosis. This is what happens. You can see on here, pacemaker, AICD. I have seen really bad outcomes. A young person going out ended up having a graft placed, and they had prior central stenosis on catheter. I'm just swelled up. And there were a lot of complications, and long story short, the patient actually died within the next 3 to 4 months, not exactly due to that, but a lot of things related to that, so it didn't have anybody. So pacemaker is the ICD, history of prolonged bleeding, extravasation, infiltration, clotting, all look in the second skin, make sure there's no redness, swelling, drainage, there are no bulges. You can see that aneurysm here is shiny, bulging aneurysm. If there's a little bit of clot on top of it or the skin is peeling, that may be an emergency. I've had one patient, and you would remember this person was calling somebody and had his phone in the hand and his fistula started bleeding. So this is something that is emergent. Then when you listen, you basically put a stethoscope on it. On the right hand side, you can see a hidden access, and you have systolic diastolic loopage, nice glory that you can hear. And if it is systolic and high pitched and loud, you can see that there is a stenosis there. On this website, if you go there, you can actually listen to the sound also. There is a recording there. And in field, what you feel for is a pulse and flow. And if the pulse is hypopulsical and it's not much pulsical, I don't mean that there is impulsiveness. If it is hyperpulsical, that may indicate presence of a stenosis. Same thing with the trill. If it's out of the trill, you can have similar trill across the entire vascular axis from the arterial anastomosis to mid part of the venous, and you can be assured that there is good flow that you can use for to dilate really up to 450 on per minute. And a couple trill in axilla usually indicates that there is 500 ml per minute of flow. So once you have done the notice and feel, it takes literally 30 to 40 seconds to do those actions. Then you quarterly raise the arm above the head. When you elevate the arm, you can see here is the arm which is, I don't know if you can see the other, I will move this picture here. So on the left hand side, this is the engorged fistula, and when you raise it in front of your eye, it starts collapsing. If it doesn't collapse, that might mean that there is an outflow stenosis. So then you also want to look for a intestinal anastomosis stenosis, which is very common, up to 30% or 40% even sometimes. What you get is on the left side picture, you can see at the point B, the vein is good, but then there is a intestinal anastomosis stenosis. So initially, you can feel a really good thrill and feel rather discontinuous glory. And then as you go up there, the flow is much less because there is a poor flow because this is stenosis, and that indicates that it's just an anastomosis stenosis. I've shown the picture that one of my patients had when I gave him that. You also want to look for axillary veins, and you do the sequential compression test. If your finger is at point A and you compress that, you get a strong pulse here because you are getting all the flow from the anastomosis. It becomes pulsatile. But if you push at the point B and there is an accessory vein in the middle, all the blood goes through there and you don't get an augmentation, and that will indicate that you have an excellent vein. These are easy things to do, and you can find those things very quickly. The other method of clinical monitoring might be a decrease in KVOD or a low arterial, negative arterial pressure or high venous pressure. Those can tell you that there is inflow or outflow stenosis. You could measure recirculation in some cases, but usually at a first rate, and it's not useful for AV graft because by that time it is almost rotting. And it is more expensive than the physical examination. If you want to compare monitoring versus surveillance, monitoring detects stenosis pretty well. High positive predictive value, as I mentioned earlier, more than 70%. Yes, you can get a little better positive predictive value with steady pressure monitoring or flow monitoring, but those require so many more resources. And if you are doing a training of the physical examination, when it is done by experts on a routine basis, monitoring itself may be just sufficient, and nobody wants to do a surveillance for that reason. So the advantage is if you detect the stenosis early, you could intervene and salvage the AV access. You could do angioplasty, stenting. You could ligate the axillary veins if needed, and you could do surgical revision. But
we have to remember that the access care is multidisciplinary from day one. When you are placing it, it's important for the primary care physicians to refer to nephrologists, and they refer it to the surgeons or interventional nephrologist, and then access coordinator is going to be central there, and there has to be a coordination between dialysis access staff, hospital, and the patient, and patient has to be central there, and that is extremely important. But when you want to establish a vascular access team, there are certain components. The most important of that is vascular access coordinator. And I know that you're going to listen from Amy. I was very fortunate to have her. And the vascular access coordinator essentially coordinates the whole access creation and maintenance. They maintain a database. They create database, they update the database, they review with the nephrologist, and dialysis unit staff works as an access champion, monitors access, educate patients and families. Nephrologist and interventionalist obviously have to be available the whole time. They develop the criteria and drive the bus. Their hospital and medical center have to be on board to have the protocols about vein access and vein preservation, not to use PICC lines, involve the nephrologist, and patient and family are again absolutely essential. We are working for the patient, so if we are going to have patient-centric approach, they are the most important, and family has to be involved for appropriate context and support. So right access for right patient at right time, those are the important things. So to summarize, AV access stenosis is the most common cause of access dysfunction, and if untreated can lead to access thrombosis. Clinical monitoring with physical examination allows early detection of dysfunction and stenosis. It is inexpensive, accurate, and provides opportunity to intervene early, and multidisciplinary team approach is essential to develop a vascular access program, especially having a vascular access coordinator and nephrologist work with the rest of the team. So with that, thank you very much. And I would like to invite Ms. Amy Durbin. I know that Dr. Verma is going to invite her as well, but before she goes to sleep in Ohio, I will try. Thank you very much for your attention, and maybe we can take the questions at the end or whatever the panel decides. Thank you so much.
Thank you, Professor Agrawal. So we'll be taking questions right now. So for all the Zoom sessions, we are going to have questions and answers immediately after the talk. So sir, please, you can.
Any questions from the audience? Yes, Professor Sharma.
Dr. Anil, is it that today, as per the KNOK guidelines, just the physical examination is recommended? Because I remember when we were in training, all these things were not available, and even we learned fistula making in cases where our chief of surgery, who was a transplant surgeon, had failed, because these are failed patients with failed fistula, so we were allowed to start making fistula and learning. I'm talking of late 70s. And then came a period where I was in SCPGI. We also bought an equipment for the surveillance, which we rarely used. And we used to go to these conferences where there was a lot of hype of these. Is it because today, whenever you clinically suspect any problem in the fistula, which is being emphasized, you immediately, either yourself, if you are an interventional nephrologist, or you refer to an IR person, and he immediately goes in with ultrasound-based evaluation and then goes in intervention. Is this the reason that the surveillance is not being emphasized? Or do you really feel that if you do a randomized study and try to compare, surveillance could still be useful?
Thank you, Dr. Sharma, and I can't see you, but I recognize your voice. Thank you so much. Pleasure to hear you. So your question is, why do we not really recommend surveillance, even though it could be useful? So if you look at most of the trials of surveillance, they did not show significant benefit over the control arm in preventing loss of AV access. So the reason most likely was that these centers were already doing monitoring, and when you added surveillance on that, it was only a small amount of increase. I think there is value to surveillance, though. The value to surveillance is in those cases where you don't have a good person who can do a good examination, a trained person. There you can actually fall back on the surveillance, and then it will be useful. But if you have good, very well trained person examining the AV fistula, your incremental benefit is not as much, and it is more expensive and time consuming, and the personnel deficit that we have, it is usually not that beneficial. But you're right. I mean, it's not that there is no use of surveillance. There are some automated ways of like VASC alert, if you have heard of VASC alert. This is a methodology that utilizes the same data points that the dialysis collects, and based on those data points, it can actually alert you. So somebody else just monitors the database. They are not even the dialysis unit, but they can alert the team that this trend is going in the wrong way. And most of the times they are actually correct. So VASC alert could be used. There are newer methods, but they are more expensive, and not everybody can utilize those.
I think, sir, perfectly said that in medical sciences, there is no substitute to a good clinical examinations. For what you are talking about, we have a very interesting talk coming today also, which is role of AI in vascular access surgery from Mount Sinai. I think we have a very limited time. One last question, and then we can move to next talk.
Thank you, sir, for a very basic and wonderful talk. One thing I would like to clarify from your experience, that what is the importance of hand grip or compression exercises, both pre-surgery and post-surgery of AV fistula, whether it is of some use or not. And second thing, we often face such a situation that we all know that our CKD patients are morbid, they have multiple problems. So we have some patients with heavy paresis that they have encountered a stroke at some or other point of their life. And can we expect to make an AV fistula in a partially paralyzed hand?
So both very interesting questions. I would try to keep it short. So you must have heard of the FIST assist. The trial was done in India. One of my friends here in California did that. And so they showed that if you exercise FIST during the initial part of the vascular AV fistula creation, and even before that, that might improve the vein size. Although prior to that, there was really not much data. So based on one study, there might be some benefit. And the second thing is about the hemiplegic arm. Yeah, you can utilize that to create an access. Usually the veins are good and dilated, and people don't put IVs in there, so those are well preserved arms. You could potentially use that. So yeah, thank you.
Thank you. Thank you, Professor Agrawal. I would like, if you can, I know it's pretty late, if you can stay back for the next talk, because I'm going to call Amy Durbin, who is a registered nurse practitioner and vascular access coordinator at Ohio State University Hospital, USA. And so this concept, which we don't have much, we have surgeon coordinators, we have nephrologist coordinators, we do not have access coordinators in majority of the places. So let's see what she has to tell us about. Amy, all over to you.
You can share your screen.
Ma'am, share your
Hi,
screen.
everyone.
Yeah, we can see you. Just share the screen.
Amy,
There
you
is a
can
green
share
button.
screen. That will be easier for you. Otherwise, we can run your slides. Yeah.
You can click the green button at the
Just
bottom.
green. Just put on the green button.
Green button.
Share. On a green.
At the bottom.
And do we have a talk?
Yes.
Yeah,
Is it not
in
working? It was
bottom,
working earlier.
the green button in the bottom, yeah.
Yes.
We have a talk?
Got it.
Perfect.
Okay. Well, I just wanted to say good morning to everyone and to welcome and to just give my thanks for the opportunity to present here. So again, I'm Amy. I'm the nurse coordinator for the Vascular Access Department at Ohio State. And I'm just going to talk to you about how you can optimize the vascular access coordinator role for the outcome of the patients. So to start, let's just talk about the benefits of a vascular access coordinator. One of the benefits is that to have an advocate for your patients. The patients have that person they can reach out to that is with them, that walks them through the whole process from education to getting that access and just moving forward on with it. They can answer questions for the patient and kind of just be that middle person between the nephrologists, the surgeons, and any other medical providers. Another benefit is just follow up across the providers. I like to think of this easily as just think, if you think vascular access as a medical provider, just think vascular access coordinator. That's the person that you can reach out to, as Dr. Agrawal kind of mentioned, that central person who, knows all the team players, all the team members, and knows where to reach and where to direct everybody. And then another benefit is education, to be able to start that education with the patients and the dialysis staff and to always keep it ongoing. That's also another benefit. Yeah. While I was preparing for this presentation, I came across this magazine in my office and I thought it was very interesting because this is dated January of 1995 and says vascular access, the Achilles heel of dialysis. And we are here almost 20 years later, and it's still considered by many of us the Achilles heel of dialysis. Why? I think it's because we have multiple medical teams involved in that dialysis access. To place an access, it's not a simple surgery where you place it, it's fixed, it's done, it's working, and nothing else is needed. You've got to monitor it, you've got to reach out to other members of the healthcare team, and everybody's just got to work together to make sure the access is working, it's matured, and that we keep that access going. So part of the other reason is the continuous education. You got to keep educating the patients. You got to also let them know from the very beginning, there's going to be steps along this process as well. And just to let them know you have that support, the education for the dialysis staff, to teach them those physical exams, to teach them the other monitoring tools to be able to quickly get that intervention. So those are two big steps that I think cause a lot of the Achilles heel. I just wanted to briefly mention our healthcare system in the United States. We have a private commercial insurance, which this is usually eligible if you are working and your employer will offer the insurance, although there is a cost to you as the patient for any type of medical treatment you will get. You will pay something. We also have government funded with Medicare and Medicaid. Certain eligibilities are required for both of them. And there is a big umbrella over different providers that you can choose from with that. There's also we have a lot of patients that have no insurance coverage, and this can be for either they're ineligible for a lifetime or maybe they're in between jobs and careers, and they just have that moment where they're ineligible. This will hold up certain surgeries and procedures during that time. And we also have some that just simply they will opt out of that insurance coverage, even though it's available to them because of that out-of-pocket expense they may acquire. So. Now, a couple advantages to our healthcare system is that here we are able to do that proactive versus a reactive approach to the vascular access. So we can start planning for that vascular access, placing the vascular access, and just making sure it's mature and ready to go when the patient starts that very first dialysis treatment, in hopes that we can skip the whole dialysis catheter and use that dialysis access, the AVF or AVG first. We also have a managed care effort. We team up with insurance providers. I often receive phone calls from different insurance providers, just to talk about the plan of care for the patient and to address any issues that either one of us have come across talking to the patients. A lot of times it's a support person to get them to appointments, it's transportation issues, and those are things that we can work together with the insurance companies to overcome those obstacles for the patient. A few benefits of having a vascular access coordinator. You've got that single point of contact for everybody involved, for the patient, for the patient's family. You're able to build that trust and you're able to provide some relaxation to the patient to knowing that they have that person. You also, again, for the medical providers and teams, they can also reach out and just talk, to one person that will kind of be the middle person and direct everybody with what needs done. Access performance, when they're doing the monitoring of the dialysis access and they notice those changes that Dr. Agarwal described, or they're even doing some of the surveillance with the access flows, they notice a change in the physical exam, the cannulation technique, that they're able to reach out quickly to the nephrologist and then to me to make sure that we can timely get those interventions done to preserve the access function. Now, I've been able to reduce hospitalization since I've been in my role. A couple ways I've done that is just with the communication and the team that I've built. I'm able to reach out to my nephrologists, my surgeons and radiologists, and ask them, can I get this done today? Can we do this tomorrow? How soon can we get this patient in? How soon can we get this intervention, this surgery done? Another thing that I've been able to incorporate with my surgeons and nephrologists is if a patient does end up in the ED, if I am aware, I can reach out to the surgeons and the nephrologists. They'll see the patients in the ED, do the consult now. Sometimes we can prevent that admission. If we can't prevent the admissions, the surgeons are able to move them quickly into the hospital and use their surgery to delay some of the hospitalization days. So the role of a vascular access coordinator, these are some of the primary roles that I do. I do a lot of education. I do a lot of time with the patients if they're on dialysis and as far as CKD patients before they start dialysis. I also do any education for anybody else that would benefit from it. The patient's medical history, I will look at the patient's medical history when I get a referral. The medical history is very important to me to know what to do with that patient, to maybe know some of those signs that they might need some pre-op testing. I can then coordinate with my surgeons to maybe get some of that pre-op testing done before they actually see the surgical consult or shortly after they have that appointment. So I can try to work on 2 appointments at the same time for the patient. Following the vascular access. Once I have a patient, I follow them, through the whole process. I follow their access to make sure that it's working. I follow it until we get that catheter removed, if there is a catheter in there. And then I'll follow it beyond just by coordinating with everyone. So here's kind of a day in my life. And then I'll do shortly, like maybe a month in the life of the bigger things I look at. So again, once I receive that surgical or that consult, I'll go ahead and I'll review that access history. My interventional nephrologists, they like to have that summary of knowing, how often have they had procedures done on them? Did they have to stent the access? Have they had frequent thrombectomies? Is this, have they had multiple accesses? Based on that, and sometimes if I need to, I'll coordinate to see if they need to see the surgeon instead of maybe the interventional nephrologist. And I will do the same with the surgeons. I'll give them that access history and just kind of, a little bit of a background to know where we are with the access. So kind of that history, that database we have. I help with scheduling all of those procedures and surgeries, and I reach out to communicate that so that the patients are aware and the dialysis staff are also aware, to kind of be a backup to remind the patients of their appointments. I also will try weekly to take a look at anybody that's maybe missed their appointments and reach out to the patients to find out why and if there's anything I can do to help get them rescheduled. On a monthly basis, I'll participate in the chart rounds that the dialysis units do that involved, the nephrologist, the nurse manager, and the dietitian and social worker. And we'll also do monthly quality insurance meetings, and we'll just look at a clinic in a whole and see if there's some way we can help with an overall better performance of a lower catheter rate. And then I'll also individually go to the dialysis units and meet with the dialysis technicians and staff to just review reports and images. So this is a study from Louisville that just shows the impact that a vascular access manager can make and how they were able to drastically cut their CVC catheter rate. This slide here, it's a nice workflow chart for a vascular access coordinator or any type of dialysis staff. It will just kind of quickly walk them through the steps to take for an access. Is it working okay? Is it not okay? And things to look at and where to go next with that information. So as you guys can see, a vascular access coordinator is a very busy person and they have a lot of things to do underneath their umbrella. So early vein preservation, that's one thing I haven't talked a lot about yet. It's one thing to think about definitely when you get that first access place or you're going to have it eventually, to just talk to the patient about that, preserving that non-dominant arm, preserving those veins, to know how many central lines they've had placed. CVCs, we want to get those CVCs out or prevent them altogether if possible. And patient education, dialysis education, can't stress that enough, the importance of education. And then we want that surgeon, consult there with us. Some challenges I've faced as far as my vascular access role. I've talked a lot about education, but yet it's still a challenge for me to get that education, especially over to some of the dialysis clinics. Dialysis has a high turnover rate with dialysis staff, and it's hard to provide that education and to have experts on finding those early intervention signs and being able to reach out quickly so that we can take care of those things. Surgeon commitment. I work with 2 surgeon practices at Ohio State. I have a very strong relationship with one of the surgeon groups, and I have a specific surgeon that is actually fully invested in dialysis accesses, and we communicate almost daily on patients. The other surgeon group is more of a challenge for me that I'm working through. There are more surgeons in that group, and they don't necessarily have the same goal as we do to get that catheter out in 90 days and an access functioning. So a issue the surgeons have is their OR time. They do not have unlimited OR time to do dialysis access surgery. So they also have to kind of prioritize, and sometimes there can be a wait list to get those surgeries in. Communication between the medical teams. There's a lot of medical personnel involved in that care of that access. So just to make sure everybody is aware and on the same page can take a lot of time and commitment. One thing that you guys have that we don't have that patient education, that workshop that you guys have in India where you can bring the patients together and provide that hands-on education for their physical exam. So some of the outcomes of a dialysis access manager is you can develop those impactful relationships and you can really make advancements in taking care of the vascular access for the patient. You know, you're able to prioritize, you're able to reach out to those surgeons and say, hey, can you do this? Any chance I can get this done? You know, I really need this patient to be seen. You have that. The patients and the staff, they're more knowledgeable and they're aware and they take advantage of that. And they're also reaching out to, you know, my nephrologists and letting them know when they see something that is not right so that we can take care of it. So, and most importantly, I try to make sure the patients are not overlooked. Oftentimes, you know, Dr. Agarwal kind of mentioned that it is still a whole team, even though you have a vascular access coordinator. And I try to make sure that all the steps are followed through with the other team members. You know, it's a big communication train and sometimes it'll get lost. But you got to just make sure that they have their appointment with the surgeon and what the surgeon wants to do or what the interventional nephrologist wants to do, that the next step is done for the patient. So in summary, I just want to leave you guys with this, that the most important role of the vascular access coordinator is not the ability to create an access, but the organization and coordination of timely interventions to provide and maintain a functioning vascular access, not to misprovide adequate education to prevent any complications. So again, it is the organization and the coordination. Thank you.
Any questions, sir?
No, that was an excellent talk by you, Amy. I just wanted to know from you that with having a vascular access coordinator, have you been able to increase the number of patients who start their renal replacement therapy with an AV fistula?
I've been able to definitely increase the patients that have started at least in the process. They may not be all the way through the process because that's kind of figuring out the right time to get that access place, but most of the patients are definitely in the process of getting an access if they do not have one.
Because this is a problem in India that majority of our patients are not getting their fistulas made in time, so most often we have to start with a tunnel catheter or a non-tunnel catheter, and that can create problems for them in future.
So I am fortunate to have the one surgeon that I spoke about that I work very closely with. I'm fortunate to have him that he will make adjustments if I need to. And he also has said, you know, he knows in 2 weeks if that access is going to mature or not. So he does not wait the 6 weeks for maturation to know.
Hello, Amy. Thank you for sharing your expertise. I want to ask one question. How do you coordinate with the dialysis technician? Do they really reach out to you directly for any AV access concern if they find out in the dialysis center?
Do they directly reach out to you?
So they will reach out to the nephrologist covering that dialysis clinic, and then I have a referral sheet that they will send to me, and it has the information on there, what type of access they have, you know, any allergies, what their dialysis days are, just the information I need to kind of get the process started. So they reach out directly to me after they have spoken to the nephrologist.
Thank you very much for your nice coverage. Just one thing, you mentioned number of functions, 7 or 8 functions of a vascular access coordinator. In India, some of the functions is shared by nephrologists, some by surgeons, some by technician, like that. Do you have any specialized course for vascular access coordinator in your country? Number one. And if that course, what is the requirement for getting that course, that training? So the course for vascular access coordinator. Just like transplant coordinator, we have got a course, particular program. Do you have any course or program for being a vascular?
There is not a course or a program for a vascular access coordinator. For me, a little bit of my background, I actually worked in the dialysis clinic for 30 years. So, and I now am a vascular access coordinator for the same dialysis clinics that I worked at for 30 years, but there is not like a program for a dialysis coordinator.
Yeah, that is an excellent question. I will just like to say that we were very fortunate with Amy's background. She knew everything and she had personal connections with people, which really worked out for us. But at the same time, your idea is very interesting. I think it will be worthwhile to create a short program and train people for this work so that they know what to do, what are the steps in the access creation and maintenance, and how they should work. I think that's a great idea, though. Thank you.
Thank you very much.
Any more questions? So we'll be ending this session, but thanks a lot for these two wonderful talks. You know, in India, anywhere, we know that, you know, the next possible solutions, the transplant numbers are too less, and the artificial kidney are still quite a number of years ahead. So the only thing which you have got, if we can keep that fistula done in time, and if we can keep it running. And for that, we have to evolve from having a coordinator from which advocates doctor, okay, you will get appointment this time, okay, you will get appointment then, to actually a coordinator which is advocating the patient. So that's the biggest difference of having a coordinator from a doctor's clinic versus having a vascular access coordinator. So thanks a lot. I thank both of you. You have been past midnight.
Can I make a point?
Yeah,
here?
please, sir.
I think the most important takeaway message from both the talks is that we need to constantly evaluate our fistulas to prevent their failures, because more often than not, most of us as nephrologists or in the dialysis unit hardly ever examine the fistulas, and it's only when you have a problem that you start getting worried about it. So what the message, I think the point that has been made by Professor Agarwal is that you should constantly look at your fistulas at least once a week, if not more often.
I think I would also like to request, so Chandrakanta, she is our vascular access coordinator. By the way, we have been trained. I've been doing access. We as a vascular surgeon, we belong to the clan. We breathe, eat, and sleep AV access. So I've been training her, and with the help of some other colleagues. So I would like your take. How do you do, and how do you look at vascular access coordinator in Indian scenario? How it is different? You can be there. So she has prepared for this answer.
Hello. Thank you, everyone. It's an honor to chair this session, and I must start by sharing that this is my first time chairing the session. So please bear with me as I read out my response. I prepared this based on prior discussion with Amy while she was working on her talk. Amy's presentation on the role of AV access coordinator highlights the importance of early planning, patient education, and team working, improving dialysis outcome. Her insights are inspiring, especially when we compare them to the challenging we faces actually in our India. Here, many patients start dialysis with temporary catheter due to late referrals and lack of awareness about AV fistulas. Surgery usually done by the non-specialist doctors, leading to complication, poor communication between surgeons and technicians, sometimes result in premature use of immature fistula, causing issues like bleeding, thrombosis. As a vascular access coordinator at Fortis Hospital, Gurgaon, I know how crucial it is to improve patient counseling and provide structured training for dialysis technicians to address these challenges. Amy Talks offers valuable ideas when we can adapt to our system in our country, in our dialysis center, and other hospitals as well, especially in planning and teamwork. Thank you, Amy, for sharing your expertise. I hope my perspective perspective adds to this important conversation. Thank you so much for everyone. Thank you.
Thank you.
So as we end the session, we would like to call up Dr. Sharma sir, please come up for the felicitation of our chairpersons. We are in process of actually developing a course for vascular access coordinator. That is the Achilles heel of any good access program. So hopefully we'll have some announcement in the evening.
Wonderful.
After this, we'll be taking a break for, tea break for 15 minutes. And then we are moving to totally different standards. We have a person from Germany, Dr. Robert Shavardian, who is I call him the godfather of endovascular AV fistula. So it's going to be a very interesting talk. I think he's already there online, joined, right?
Is there? Yeah.
So thank you, Emmy. Thank you, Professor Anil. It was great session. We'll be ending this one right now. Okay. Thank you.
Good night. Thank you.
Thank you. Good night. Hello.
So let's take a break for 15 minutes and reassemble it in exactly 15 minutes. So we will be, Dr. Robert, talking about endovascular AV fistula. All that cuts are gone, and is how it is done. Is it possible? It's feasible. Is every patient is a candidate? How much it costs, at least in US and in Germany. So see you around.
Can I please request everyone to be seated? We will be starting the session now. Can I please request everyone to be seated? We are starting the session.
चाय खत्म हो गई. So I would request all the guest faculties, delegates, we are ready for the next session. And we have a very interesting something. In my knowledge, I'm not sure that it has been presented before, but not a common AV access talk in India. One of the patients asked me a few years back कि क्या सर फिस्टुला बनाने के लिए बिना चीरा के हो सकता है क्या? So this is answer to that. Endovascular AV fistula, for us who don't know it, it's a reality. It's not just any beginning of or any experimental science right now. It's been done on a regular basis. Dr. Robert is one of the surgeons who have been doing it for a really long time. Dr. Robert Shavardyan is head of Vascular Access Center at, and correct me if I'm wrong, Askeplois Clinic, Barmbek, Hamburg, Germany. Welcome, Rob. Rob is the name as we all know you.
Good afternoon, everyone.
Yeah. So we'll be talking and discussing about advances in AVF formation, and Rob is going to cover a lot of topics, but specifically it's the endovascular AV fistula and vascular discussion. For the same, I would like to call for the chairperson, Dr. Vinay Nazarat, Dr. M.R. Behra, Dr. Tribhuvan Gupta, and Dr. Dhairi Prajapati. So please come on stage as the chairpersons. I'll be, as I said, I'll be here at your other end of mic, Rob. So Rob, good to go. You can start. Thank you.
Okay, thank you. Thank you for the kind invitation and the kind introduction. I hope I will be able to cover a lot of things without making it too boring for you. And with that, this is my slide of my disclosures. And I would like to start with my practice, which started in Hamburg over 7 years ago, just dedicated to dialysis access. And during that time, I've been able to do over 4,000 procedures by myself, which is probably in Germany not the numbers that you can anticipate in India, but still this is considered high volume center dedicated only to dialysis access. We have done over 1,000 vascular access creations, which is around 90% AV fistulas and 10% AV grafts. I'm doing all types of broad, innovative, and all classic procedures in our patient population, which you can see on the right side, which might also differ for you. We aim to create the vascular access in pre-dialysis patients more and more. So around half of our patients get the fistula or graft before they reach their dialysis, and we have an incidence of 45.8% of patients who are getting dialysis access with a catheter. So this is something which I'm kind of proud of, which it can, of course, it can be better, but there are things you can do by yourself which are limited. And during those years, I've learned a couple of things which are important. One is the ultrasound. Many things, most of the things I perform using the ultrasound. The axillary block is something that I introduced early on, and it has shown its advantages also in the literature. And also, we follow strict, aggressive clinical and ultrasound surveillance of our patients for several reasons: to initiate early cannulations, not waiting for weeks, to initiate intervention if the fistula is not mature, initiate catheter removal flow, early enough, etc. So during that time, when the innovations such as endovascular AV fistula or the vascular device were developed or introduced, we came up spontaneously with this kind of algorithm where we would prefer to create the fistula as distal as possible. Of course, individually based, it will be different. So it's not a strict black and white algorithm, but then we would start with the distal as possible access and proceed towards the proximal. So we aim to a forearm fistula with snuffbox fistula or radiocephalic fistula, then with the endovascular AV fistulas at proximal forearm, before we go to the proximal forearm surgical fistula, which would be the so-called Gratz fistula, and then the upper arm axis is more rare and rare and rare. So creating an anastomosis over the elbow crease is very rare in our practice. So I will start the distal one, the vascular device, and proceed to the endovascular AV fistula. So the vascular device is this small 2.5 centimeter long device, which is used during the creation of AV anastomosis for radiocephalic or brachiocephalic AV fistulas. And since my practice is mostly radiocephalic, this is my experience with the device with the radiocephalic fistulas. And when you create your anastomosis, basically before you create it, you measure the vein and the artery with this selection tool, choose the size of the device, which has 6 different sizes, place it around the vein, and then create your anastomosis with an angle of 40 to 60 degrees, preferably. We know that 46.8 degrees is the best optimal angle according to computational fluid dynamic analysis. So the device supports 40 to 50 degrees angle, and then you create the anastomosis, place the device around the artery and connect it. So it doesn't change your practice much. It adds a couple of minutes, and with experience less and less. And you can instantly see the vascular device in the ultrasound when you perform the procedure and later on. So initially, there was a small randomized controlled trial with a vascular device on brachiocephalic fistulas, and this was the trigger which led to the fact that I said, let's try the device, see how it looks like, because in this small randomized controlled trial, it showed benefits for the patients. So we implemented it in radiocephalic fistulas back in 2018 when it came out, and then started to use it and looked into the flows during the procedure. So we saw that on the upper image, when the fistula is being created and the clamps are removed, the turbulent flow, and then when we placed the device into position, it looked like the flow changed with an ultrasound with this B flow. So it kind of supported that flow support of the device with an ultrasound. Of course, additionally, we have looked into the data, what we were able to produce, and this is what we were doing during those years since I started in Hamburg. The forearm endo-AVF and surgical proximal forearm fistulas, how it changed during the praxis and how we tried to publish all our experience with those different types of procedures, innovative and also the old ones, to be able to see how it works out over the time. And when we started the radiocephalic fistulas back then and the snuffbox fistulas as part of radiocephalic fistulas, when the vascular device came in, we started to use it, and you see that the ones without the vascular device basically started to disappear except of the snuffbox fistulas. And in the early experience, we decided to look into the early radiocephalic experience and saw that there was a reduction in primary failure and an increase of primary patency at this early stage of 6 months. So the vascular became a standard of care. We started to use it in every patient to exclude the selection bias of the patient, to exclude the cherry picking, to say if we create a fistula, then it includes the vascular device. So if the results are better, we're not choosing them for the better results. And that's why we looked into the outcomes over 3 years then later on, and then 150 patients, 3 years, we looked into the secondary and assisted patency rates. So the secondary pates at 3 years were over 85% for radiocephalic fistulas, which were pretty high comparing to the literature. So then further on, now we're at basically 6 years, and then we looked into the comparator or possible more distal options, snuffbox fistulas, and this is a publication in press, but the secondary patency rates looking up to 5 years now, because at 6 years the number of patients at risk are pretty low. Most of them, of course, at 6 years are also dying with high incidence, disappearing, occluding, whatever. So when we matched those two groups, there was a significant difference in patency rates. So we don't say you should use the vascular device instead of doing a snuff box fistula. We say that if you have good candidate for snuff box fistula, start with the snuff box fistula first. And if it fails, you can proximalize it to the radiocephalic fistula with vascular device, because in this patients group of 38 patients, I think we had 100% of maturation rates. And we also said, let's look into the age distribution. Do we see any age disadvantage? Because literature says elderly patients have worse outcomes in radiocephalic fistulas. But when we look into the maturation rates at 4 weeks, the maturation rates in general and the unassisted maturation rates, with breaking it down into the ages over 65 and below 65, we see no difference in all three groups. Interestingly, we see even higher unassisted maturation rates in the elderly patients. Can't say what the reason is, maybe because the younger, when we select them, we're more aggressive with smaller vessels, etc. So it seems to not differ regarding the age. And there is a lot of literature on the vascular device already, not only coming from Hamburg. All of those publications and studies and reports across the globe demonstrate similar functional success of those fistulas as compared to the literature with bigger numbers of patients such as HFM or DAC study, etc. So there was also a US study with the IDE study which compared it with their outcomes. But also one thing that I would like to touch ground on is the interventions or problems, which is, it is not a magic tool, so it doesn't exclude the risk of juxta-anastomotic stenosis 100%. We still see around 32% of juxta-anastomotic stenosis in those patients which we treat. And if you compare it to literature, radiocephalic fistulas with juxta-anastomotic stenosis rate up to 60% even. So even if you get a stenosis in this area, you can perform an angioplasty. Either you choose the vein or you choose a transradial access, such as shown on this picture in this paper, and you can access both radial artery and the vein and do an angioplasty. You just need to know that there is an external support across the vein, so you will not be able to use a big balloon and then get a result, because the stricture, the constriction of the vessel with the device is external, but it is enough to perform this angioplasty to get the decent flow through the vein, such as shown on this image. Now with that, I would go slightly more proximal, and then we have these two devices for endovascular AV fistula creation available on the market in different countries, including Germany. We call it the first generation because the next generation devices are already in development. And one device is the Veincon device, and the other one is the Ellipsis device. Both have one common thing. The common thing is that they utilize the proximal forearm perforating vein, the deep communicating vein, where the anastomosis is being created, and the flows goes through that perforating vein into the upper arm superficial cephalic and or basilic veins. So this is the similarity also to the surgical fistula, the Graz fistula, which I already talked about because it was described by Graz. We call it Graz fistula here. This is the perforating vein anastomosed to proximal radial artery or antecubital brachial artery. And you can modify this fistula as, you know, use a branch, use the ulnar artery, etc. So this is the closest to the endovascular fistula that you can come up with, but still there are differences regarding the flow, because in perfect world, your endovascular fistulas would look like this if they get the flow in your outflow vein, in your target vein. And how the catheters, both systems work, is that with the Veincon catheter, you have two 4 French catheters shown on the X-ray on the right side, and you introduce those using ultrasound and X-ray and position them at the proximal forearm. And then with using the radio frequency energy, you couple them and you create a slice through the artery and the vein at the proximal radial and ulnar artery and vein region close to the perforating vein, so the flow goes through the artery into the vein. The curl corresponds to the coil embolization of one of our brachial veins if there is a significant flow going into the brachial vein, to increase the resistance in the deep venous system but not completely obliterate it, to increase the resistance and lead the flow, because the flow wants to go where the resistance is lower. And the catheters can be introduced by several accesses. Typically, it's brachial artery veins, radial artery veins, and ulnar artery veins, depending on the location of the anastomosis, radial or ulnar. So you can use both catheters for a radial anastomosis from the wrist, or you can use one catheter from the wrist and one from the brachial artery or the vein, depending how the anatomy there is, if there is a connection between this area, and if the vessel size allows you to puncture it and introduce the catheter into your designated location. And the flow will go through this close by to the perforating vein anastomosis, either into the basilic or into the cephalic, or if you have a dual outflow into two veins, but there is also a possibility of losing enough flow into the deep veins. With the ellipsis system, this is a 1 catheter, 6 French catheter, not a 4 French catheter system, which has a tip which is open. And with that tip, you capture the proximal radial artery, as shown here on the left side, with a perforating vein, slightly higher than you would create the anastomosis with a Veincon system usually. And by capturing it here using ultrasound guidance only, you use thermal energy and burn a hole in this region, and possibly, this is what at least the manufacturer says, fuse that with the heat together. And then because of that heat damage you create, initial reports and results show that if you perform an angioplasty using a 5 millimeter balloon at the end of the procedure, the risk that the anastomosis will occlude is lower, because initially they were occluding in high rate after that. So you would just dilate the anastomosis for 2 minutes and then reduce the risk of stenosis and especially early occlusion. A schematic view of how this is created at this proximal radial artery to perforator junction. This is basically where the perforating vein is joining the deep venous system. Again, here you can see typically this is the location where the anastomosis would be, but the anatomy of every patient is different, so it might differ. Especially one important thing is the distance between those vessels. In the wavelength, you need to have a very close distance to lower than 1 millimeter because it's not fusing it. In the ellipsis, the IFU says 1.5 millimeters. Otherwise, you might have extravasation and pseudoaneurysm. And the vessel sizes are typically, you should remember, 2 millimeters of vessel sizes for both vessels regarding the anastomotic area of the artery, the vein, the perforating vein, and the upper arm vessels typically should be above 2.5 millimeters, but I use the same sizes as for the surgical fistula, which would be again 2 millimeters using tourniquet. But you can see the complexity of the anatomy of this region. We are, as vascular surgeons and interventionalists, interventional nephrologists in some areas, we're not familiar with this area much, especially with the ulnar area, especially with the ulnar venous area. We were doing Grad's fistula, we knew this anatomy here, but still not the venous. So this gives you a lot of learning curve necessary to understand the anatomy, which patient would be possibly suitable for this procedure, but you cannot replicate the procedure, especially the Veincon procedure. So you're never sure whether you will 100% be able to bring the catheter to the exact location you anticipate to bring, in the ulnar region especially, and then whether the catheters were actually coupled at least 2/3 of the length, so the magnets hit each other and the electrode is in the ceramic saddle. So this is the next step of the endovascular fistula, and the closest surgical Grad's fistula, radial artery to the perforating vein, which would be in our algorithm the next one. The literature on the endovascular AV fistulas is not, considering it's been out for 6-7 years, one can say it's enough, another can say it's definitely not enough. And I can confirm that it's not enough. I know more people were doing it or are doing it than publishing it. I know there are studies which are replicating the patients because it's the same group reporting a study maybe after 2 years instead of 6 months, maybe after 3, where there is nothing over 2 years now except of one study on ellipsis. So 1,900 patients are not exactly 1,900 patients. Most of them are also overlapping. But what has been shown in general is there is no difference in procedural success between the surgical and endovascular fistulas, which is okay, fine, you can create it. But the question is, can you create it just to look on it, or can you create it to use it? Because it is not intended to create just to say, hey, I'm the god of endovascular fistula, like you called me. But if they're not working, they cannot be used. So this is another question. And we started using the systems back in end of 2017, did the first case, and then mid of 2018, started also using ellipsis. So you see the green line is the endo-AV fistula going up, and this is basically what we tried to also publish. And this is up to now the only publication which actually included both of the systems in a group published. Most of the publications, or all of them, are including either one system or another system. So we did 100 cases here and showed the advantages of the devices, and then we started to look into the comparator, the surgical fistula, and published it back then using the ellipsis because it was the closest one to too complicated to use both systems. And we saw that although the success rates regarding many things is similar, the interventions are higher in the vascular AV fistulas rather than in the surgical fistulas. Up until today, I know only 5 publications which included a comparator of surgical fistula, and it is difficult to compare it. All of them are retrospective studies. All of them are using different fistulas. This one is using radiocephalic fistulas with waveling, totally different fistulas. This one is using tons of surgical fistulas everywhere and an ellipsis fistula. We consider the closest one because it's ellipsis and Gratz where they're closest anatomically. This one is comparing to brachiocephalic fistulas. And the last one is using the old system, which is not even available, the 6 French Everlink system, and comparing it to historical 300 patients. So these comparator things are also lacking. That's why we are now publishing, and I hope it will be out soon enough, up to 6 years of experience with both systems and the surgical fistula. And we see that the clinical maturation rates and also times to catheter removal rates are pretty similar with the surgical one, the Gratz one, and the ellipsis system. The wavelength fistulas tend to lack a lot of things, especially we were losing more of them. So during the time we learned to do less of them and cherry pick most of them because we realized that the problems which were appearing if you just choose the patient because he has the sizes in the anatomy is not correct. And in those studies, we also include all of the patients. The primary patency rates, they are not necessarily significantly, but lower for the endovascular AV fistulas because, like I told you, the intervention rates is higher. And the secondary patency rates, especially with the ellipsis system, the surgical one, if you look up to 5 years, over 80%, which is also pretty good if you look into the literature. So we looked into the maturation rates. We looked into the complication rates, we looked into the intervention rates, and you see there are differences in some things and differences in other things, but 90% of maturation rates for ellipsis system similar to the surgical one, and pretty much similar number of interventions per patient year. So you might need an early intervention for endovascular AV fistula, but you don't tend to do it repeatedly, and repeatedly it's not significantly higher. There are high rates of juxta-anastomotic stenosis. This is something you need to know. Over half of the patients have juxta-anastomotic stenosis, probably because you burn it, because you use a radio frequency energy, and you damage it differently. Whereas there is lower rate of cephalic arch stenosis because of the lower outflow, which is basically how it goes. The flow is distributing from the anastomosis into different directions. So some tend to call it low flow fistula, but it is not necessarily a low flow fistula because the total flow can reach up to 2 or 3 liters also. But the target vein flow is lower than the surgical fistula because all of your 1,000 liters, milliliters, or 1.5 is not going into that vein. It's spreading, which leads to cannulation difficulties in many centers and high reintervention rates to make those fistulas cannulable. And hence, a lot of fluoride directing procedures are necessarily embolizations, ligations, balloon angioplasties, even stent grafts, and the same with the juxta-anastomotic stenosis, which leads to high reintervention rates, and probably that combination of energy you use an angioplasty and turbulent flows in juxta-anastomotic region leads to aggressive angioplasticity necessities in these areas. And we try to look into the costs. It is difficult to tell you the cost because the devices cost in each country are really ranging depending on many factors. So in Germany, the cost is different than in the United States. So in this analysis, we didn't actually use the initial costs for the procedure, but you need to consider that it might be 5,000 or 7,000 or 8,000 euros more than creating a surgical fistula. But we looked into how those reinterventions led to follow-up costs. And we saw that, especially for the Veincon, you have slightly higher follow-up costs if you look into the 5 years. But for the surgical and the ellipsis, they're comparable, but still it doesn't include the initial procedure of the creation. So we need cheaper devices in the future to make the index procedure cheaper, and we need less interventions after NDAVF creation to reduce the follow-up costs. Of course, additionally, the fast and technically successful device is also an advantage. Costs for the procedure, doing the procedure in outpatient clinic, etc., which is the aim of the future devices, with the hope that it will close the gap, such as this, the Velocity device, which has the small implant, the fenestrated and tapered stent graft at this area. So the intention is to occlude all the deep veins at the anastomotic area so that the flow goes through the anastomosis into the perforating vein, and to reduce the trauma created by the heat and the energy, because this is a self-expandable stent, and close the gap between the reintervention rates and reintervention costs. Thank you very much.
Thanks, Rob. That was a great talk. Questions from audience?
Dr. Rob, that's a brilliant talk, and thank you from Lucknow. We have been guided on Twitter constantly by our access inputs. So I have a couple of questions for you. Question number one is, how do we select the patient? Is it the patient asking for endovascular AVF? If not so, which patients will be counseled for endovascular first in your practice setup? And then question number two, what is the rejection rate? Say 100 patients coming for an endovascular AVF, how many do you reject based on the anatomy?
So can you repeat the second question? How many I
on the basis of
reject. Okay, yeah. Yeah, thanks for your question. So back then when I started using it, I was one of the first ones, especially I was the first one who used both devices. So it was not really possible to ask like you did now somebody, how should I select it? So we said, okay, the manufacturer says your vessel size should be like this, the anatomical criteria should be like that. So if the patients would fit the anatomical criteria, we would consider them suitable for endovascular AV fistula creation. But at the time, we were still trying to figure out where can we put it into our vascular access algorithm, and the manufacturers back then promised you a fistula which you would create with less problems. So that juxta-anastomotic stenosis, which you would create or you would induce by doing a surgical fistula, would disappear, or at least would be really low. So it was sold out as a replacement for a surgical fistula back then, based on just 2 studies in each device, which were controlled, selected, the NEAT study and the pivotal study for the one for the Everlink device, this old device, and one for the Ellipsis device. So we said, okay, we're trying to implement it, and we implemented it and came out with this algorithm that I showed you with the arm. So we're starting distal to proximal, and when we cannot do radiocephalic fistula, we would do the endovascular AV fistula. First it would be the Veincon, then it would be the Ellipsis, and then it would be surgical fistula. Because of the location of the anastomosis, we saw that if it fails, and mostly it fails at the anastomotic area, you could proximalize it if the Veincon fails to an Ellipsis, and if an Ellipsis fails to the Gratz fistula. And if the Gratz fails, you can do your upper arm brachiocephalic or brachiobasilic or graft, AV graft. So this was the strategy which we used. But after years of experience and seeing the results that I showed you now, we realized that that cannot work for all the patients. So it brought to reduction of cases being created by endovascular fistula. On one side, we have excellent experience with the vascular fistulas, the radiocephalic fistulas. They are better than the upper arm fistulas if you look into the results. So we're doing a lot of forearm radiocephalic fistulas, which of course reduces the number of proximal forearm endovascular fistulas. And then If we move to the proximal forearm, because radiocephalic is not possible or it fails, then we see whether the anatomy is really good enough that there is no big deep vein which will steal your flow into the deep vein. There is not tortuousness in your perforating vein. There is no scarring in the cephalic vein to everything which increases resistance, even in a low state, which will not be the case for a surgical fistula, would just divert your flow into the other veins, deep veins typically, which have lower resistance. So this is how we now select perfect candidates, not just candidates. And the rejection rate became higher. We saw that around 60% of our patient population can get at least one of those types of fistulas, anatomically, selectively. If I would be scanning the patients and saying, okay, 60% of patients, I would be able to do the endovascular fistula with 54% or 52% of cases ellipsis, I think around 32% of wavelength, and some patients overlapping having the two possibility. But at this time, we're having, in general, we're having a rate of endo-AV fistula of around 25% from all the creations. So from 1,880 something AV access creations, we have around 260 endo-AV fistulas, but during the last 2 years, it was much lower than in the first 2 years when I started doing it. So it's not patient preferred. This is very rare that patients come to us and say, I want this endovascular fistula. It is happening. They say, I've heard you're doing it. And my answer is, let's check whether you're suitable. Yeah, let's check whether you're suitable for a better distal fistula, radiocephalic. And then I explain to them the advantages and disadvantages of both possibilities and guide them to decide. And most of them listen to me and say, okay, if you say you're doing a radiocephalic fistula, do it. If you're saying you're doing a Gratz fistula, do it. Very rare that the patient will insist on getting an endovascular fistula, despite the possibility of having radiocephalic option.
Thank you, Doc. We really look forward because there have been very few advancements in the field of IVF creation, and it really brings sparkle to our eyes when we see your work. So let's hope we have a system soon in our country, and maybe 10 years down the line when we as seniors will be talking that, yes, those were the days we were discussing about these things and this became a practice. So good luck, sir, and we look forward to the advances. Thank you.
Thank you.
Well, Rob, so you have a huge fan following in among interventionists as well as vascular surgeons, especially young vascular surgeons. So me, Ashu, and a lot of other vascular surgeons have been following your work. Great work, great talk, and I think more insights about endovascular fistulas and vascular devices will keep on coming with years. One thing which I think is a key message to take: the endovascular fistula is not just not putting the cut. It's a lot more. You are creating much better physiology. The system is much better. And as Rob rightly said, that in this scenario, it may be a costly procedure on the beginning, but then you land up avoiding multiple re-interventions. Whereas right now, when patient says, sir, the first surgery was the cheapest one, then your balloon plasty is costlier, then your drug-eluting balloon is even costlier, then your covered stent is even more costlier. So, that's one other way to look around it. Thanks, Rob. It was great having you. And while we end this session with you here, we will continue with our physical session in here. Thanks.
Thank you very much. Thank you, everyone.
Our next session is a hybrid procedure in vascular access salvage. This will be, the talk will be given by Dr. Santosh. He is our third intervention nephrology fellow, and this area is totally his contribution to our SGPJ.
Good morning, everyone. I am Dr. Santosh Kumar, currently pursuing my postdoctoral fellowship in interventional nephrology at SCPJ Lucknow. And today I'll be discussing about hybrid procedures in vascular access. Why I given this talk as nephronomics, I'll be explaining it at the end of my session. Going to the talk. So coming to a hybrid vascular access procedures, they're actually a combination of open surgery and endovascular techniques to treat vascular diseases. These procedures are usually performed during a single operation, meaning a single setting. And a little bit of history, the first hybrid procedure dates back to 1973, when dilatation of pelvic arteries were performed along with femofemoral bypass for the limb salvage. Started off with peripheral, then central, then it's come back to vascular access. So it's been almost 60 years since Dr. Scribner started and he revolutionized the field of vascular access surgery in nephrology by creating the first AV shunt in human beings for the first time. And this is just a representative image of how a Scribner shunt is. And the first patient whom he inserted, surprisingly, actually survived for almost 11 years with the shunt on maintenance hemodialysis. And all we know that it was made of Teflon cannulas, percutaneous procedure from the artery, radial artery and cephalic vein. Then came the fistula that we commonly know, the RCAVF fistulas, BC, vesicoseminal fistula, which replaced Scribner's shunt in 1965. This shunt actually marked the beginning of the open era in vascular access medicine, and since that time, surgically created fistulas, either native or prosthetic, have been considered the gold standard type of vascular access in patients with maintenance hemodialysis. As knowledge advanced, our knowledge advanced, technology advanced, further hybrid procedures we are able to do. We started using hero grafts, which is actually a hemodialysis reliable outflow graft. This is again an hybrid procedure for central venous lesions, central venous angioplasty. If you're not able to do that, then we can do an hero graft implantation where we suspect a central venous lesion which could be there. Previous speaker, Dr. Sheridan, had detailed description here. There was a talk on endovascular AVF creations, the ellipsis system, the wavelength system which was there, based on what thermoablation techniques, whereby we can actually create endovascular without minimal surgical involvement. The next stage is where endo-Rudy procedure started happening, whereby we all know the Rudy procedure, which is used for dialysis-associated steal syndrome, and endovascular revision of the Rudy procedure became the endo-Rudy procedure, where it allows the creation of small flow anastomosis using the radial, and subsequently brachial vein will be used as a conduit. We can see it there. This is the conduit which is used. So this is basically an endovascular modification of a Rudy procedure. Yes. So now I'm going into my actual talk. Just wanted to start off with history on how we have progressed. Is that why do we need hybrid procedures in vascular access? When we have access, we have in radiologists, interventional vascular surgeons, nephrologists also doing procedures. So what is the concept of hybrid? Why do we need to do it? How do we select the patients? How will be their outcomes? Obviously, we are in India, so cost matter a lot. Feasibility and technical expertise. So I'll go through certain case reports, case viginities of us, which have done over the past 6 months at our institute in STPGI, so that our knowledge, we can discuss about the case, and then we'll probably get solutions for these questions. So the first patient, you can see his image here. So he's a 38-year-old male on maintenance dialysis for 4 years, with the current access being a right BCAVF with multiple access failures on the left side. He came with history of recurrent dialysis clotting, venous hypertension, basically features suggestive of outflow stenosis. Clinically itself, we can see that there are multiple collaterals here, which is directed towards the forearm, meaning away from the fistula. So naturally, that means that there is an occlusion somewhere upstream. So probably there must be a mid-arm stenosis clinically. We could see the dilator and tortuous venous collaterals over the entire forearm. So went ahead with an angiogram. It showed us 2 lesions. One, he had past history of catheterization. He's been on dialysis for 4 years. So there was one at the junction of the IGV and the BCV. But the more significant one was a mid-arm stenosis. You can see that there is pre-stenotic dilatation, aneurysmal dilatation is there. Collateral is also happening. And probably this is the lesion why they were collateral which was also going into the forearm. So what are the challenges that we could face here? Obviously, we had to do plasty because he has a central lesion. if not now, on a later date, even if you're able to correct the mid-arm lesion, this is going to cause a problem. But the significant one was a tight stenosis in mid-arm, and it was very tight. So we had that, supposing we are going to go ahead and proceed with it, there is a distinct possibility that there might be a vein rupture because stenosis is tight. So if we are going to proceed only with surgical correction, going for a graft, without an endovascular procedure or a central venous angioplasty, that is going to be an incomplete procedure. And we had to be, this was a precious access for us because patient did not have any transplant prospects, and this was the last working access. So we had the honors of responsibility to salvage this fistula. And if you're going to go for a non-autologous graft, then there is a possibility naturally, one financial constraint, second thing, a possibility of thrombus and infections, which is a distinct possibility. So actually, we had this idea that instead of going for a non-autologous graft, luckily by nature, this patient has multiple venous collaterals here, which can be used as an autologous graft. Because once you are going to correct the stenotic lesion, these collaterals are actually going to disappear. So they are going to be redundant. So we thought, instead of why don't we go ahead with an autologous graft, use its own collaterals and create a bypass. See, this is our, we have a cath lab and an OT setup, adjacent to us in our DSS suite. So we thought that this was a stenotic lesion here. So we had this idea that instead of trying to go ahead and do a balloon angioplasty and try to open this lesion and take the risk of rupture, why don't we try using a bypass here of this collateral, use this collateral to create a bypass that becomes an autologous graft. So I labeled it as SGPJ technique. Officially, I'm not giving it any name. So we thought, why don't we try doing that? Definitely, we need to go ahead with the central angioplasty also. So that was done in the first setting. We opened the central lesion with a 10 mm balloon. In the second setting, we tried to create this. So we could see here, you could actually see beautifully the post-stenotic thrill here. This is the first time that I could see it live. Clinically, we feel the post-stenotic thrill here. This was a steno segment. The plan was to create a bypass from here. We removed the autologous graft, and then we anastomosed the autologous graft from the pre-stenotic segment till the post-stenotic area. So this was the final outcome. This was the pre-procedure. The final procedure, using the autologous graft, we have bypassed it. So this is the pre-procedure images. Post-procedure, we can see the disappearance of all the collaterals, and these are the representative images. We had a pre and a post angiogram also. This is a pre-procedure angio showing the steno segment. Post-procedure, we can beautifully see the uptake here. Yes, the stenotic segment is still there, but since the bypass graft has been created, the flow could be established here. We have already started dialysis in that, and the patient is doing well. So this is the second procedure. The one we had was a BC AVF. This was an RC AVF. So we could see here this entire cephalic vein segment is actually stenosed, completely stenosed. So the problem was that this patient was getting dialyzed. The vintage is almost a year, but he had features suggestive of venous hypertension. You can see that his skin hyperpigmentation also happening here. Recirculation was happening. Patient had hyperkalemia, uremic symptoms, anorexia. So we tried to intervene. First setting, we tried to pass a guide wire, but it was a tight stenotic segment. Guide wire could not be passed. Or we had to go, we tried a retrograde access, could not be done, tight segment, almost a year old. So again, we thought that why don't we use these collaterals to create a bypass from here to here, because from here the entire segment was patent. So patient had complete, this was his angiogram. You could see that beyond this point, most of the circulation via the collaterals, which could not actually take the entire blood, so he was getting recirculation there. So we thought that outflows via multiple collaterals to underdialase. So we thought that why don't we do angioplasty? Angioplasty could not be done because it was a complete stenosis. So what was a conundrum in this case? Challenges we faced. Either we redo angioplasty and try to attempt again, or refer to intervention radiologist, or create a new BC AVF and abandon this fistula. Or we had another option that, similar to the previous case, where we could use the forearm, the distal forearm collaterals, which have dilated distinctly now because of this stenosis and blood flow going towards the distal aspect. So we thought, why don't we do it again? We'll attempt it. So this is the surgical where we first isolated the collateral vein, the autologous graft. We can see it here. We have ligated it here, transfixed and ligated it here, removed it. Good dilatation was there. We created a tunnel. Via the tunnel, we took the vein and anastomosed with the post-steno segment part. So this was a pre-procedure, multiple collaterals, post-procedure, all the collaterals have disappeared because flow has been established. One huge advantage we could have here is that it has also given us a segment where the cannulation can be done. A patent good segment where the artery and venous cannulation could be done. So this is the third case. You can see here we had a RCAVF with thrombus fistula. You can see erythema here, collateral happening here. So there was two sites of stenosis, one at the juxtaosmotic, and then there was also in the intercannulating segment because of cannulation. Patient had 1 year history of vintage of hemodialysis. He had this entire segment of thrombus. We can in fact see the erythema also here, and the accessory vein which were developed here because of upstream stenosis. This vein had also developed. So that vein had also got thrombus, this had also got thrombus. So again we had this option. The thrombus load was huge. So either we go ahead with angioplasty followed by thrombectomy, but then the outcome might not be that good because the thrombus, it was a long-standing thrombosis. So we thought that why don't we do a surgical correction, try to surgically remove the thrombus load, reduce the thrombus burden, and the same setting go ahead with an ultrasound-guided endovascular angioplasty. So again, a hybrid procedure where we can do a surgical thrombectomy, which will help us to reduce the thrombus load, followed by USG-guided angioplasty. So this was a surgical correction. You could see that it was a huge thrombus load. This was the final outcome of how much you could actually remove surgically. Some remnants were there, which post-procedure we are able to do balloon maceration. So it was pretty painful procedure because the thrombus load was huge. And this is the same setting. In the same setting, once we had removed the thrombus, we went ahead in that same incision, we passed a balloon using an ultrasound guided technique. We are able to isolate the steno segment because previously in ultrasound, pre-procedure ultrasound, we were able to see the steno segment. Because once you remove the thrombus, there's a possibility then it is going to get thrombosed again until we correct the precipitating lesion. The precipitating lesion is a severe stenosis there. So that stenosis was corrected. So this is the post-thrombectomy. You can see that the erythema is reduced. The accessory collateral was still thrombus, but we didn't intervene there because we didn't need to do that because we established the flow via this. One downside of this aspect is that patient also had this, you can see here a pre-stenotic dilatation here. So he also had a juxtaosmotic stenosis. But then the post-procedure when we followed up the patient, his good flow was there, and this stenosis here was not actually causing any clinically significant reduction in the flow. So at this point of time, we didn't intervene here and we just tried to correct the outflow alone, and good outflow was there and patient is continuing dialysis for past 2 to 3 months now. So this is the fourth case where we had a 50-year-old female on maintenance hemolysis for 3 months. She actually had a pseudoaneurysm. She was getting cannulated from outside, which probably as a result of cannulation injury, the pseudoaneurysm was there. And apart from that, patient also had pain and swelling of the forearm and reduced flow in the fistula. This was a working fistula with a pseudoaneurysm. Two issues were there when we did an angiogram. One, we can see that pseudoaneurysm here, but the other lesion was that it was a very pulsatile fistula. So one reason why it was pulsatile was because of this stenosis which was here at the elbow side of the cephalic vein, and probably because of that there were difficulty in cannulation happening here, and probably that might be one reason why she must have developed a pseudoaneurysm, because if this stenosis was not there, even if a cannulation injury had happened here, the flow, if established, it should heal on its own, but it was not. So the issue was that, first thing was that naturally we went ahead with a angioplasty. We tried to correct the stenos segment as well as try to do an internal tamponade to see if the pseudoaneurysm was able to be closed. But unfortunately, the rent in the pseudoaneurysm was big and that was not closing. The difficulty was that, one, it was pulsatile, creating pain, chances of infection and rupture. Second thing was that it's exactly at the site where cannulation has to happen. So if you are going to ignore this, so the patient is going to land up in soup. So we thought, why don't we go ahead with our technique again? So this was a balloon angioplasty which did for the steno segment at the elbow site, followed by surgical correction of the closure. We could identify the rent, and once we have opened up the outflow in the same setting, we went ahead and repaired the pseudoaneurysm. So this was post angioplasty which was done after repair. You could see that the pseudoaneurysm, there is no flow there, and the outflow segment also had improved. This was an ultrasound image where we could see the pseudoaneurysm here post closure. Flow is established here. Since you have ligated this, there is no flow here. So the questions that we had initially, why do we need to do hybrid procedures at all? One, not all lesions are amenable to endovascular procedures. whom, that's the most important question, which kind of patients we need to select. So preferable to avoid in patients with peripheral disease calcified vessels because it's going to be difficult for us to do anastomosis. The vessels will be friable and outcomes might not be good. Outcomes again, it's a short sample size, so it's to target better outcomes. We have to start doing more cases. Our experience is limited. We are trying to expand. Cost, significantly, again, the surgical cost is entirely up to the surgeon because the material going to be used is going to be either silk or ethylene to close the sutures. And again, depending on the angioplasty, what kind of balloon you are going to use, whether patient also has a downstream or upstream stenosis and a balloon. But on average, definitely it's much better than doing 2 procedures at the same time. Feasibility, yes, obviously it's a daycare procedure with minimal complication. The worst case scenario that can happen is that the fistula gets thrombosed. We can go ahead and create a new fistula, BCAVF. Technical expertise, see that it's a new field, it's an expanding field, it's a multi-targeted field. So naturally every journey begins with the first step. So we are starting with baby steps. So hopefully our expertise will improve more. We'll be able to do more procedures. I'll finish off with this slide. I wanted to keep this as last because when Scribner created the first Scribner shunt, the patient whom I mentioned, Mr. Clyde Shields, his fistula went for the shunt was active for almost 11 years. So he told that successful treatment of Clyde Shields represents one of the few instances in medicine where single success was required to validate a new therapy. So all it needed was one good outcome of one good procedure in a patient. So we have had 4 to 5 cases we are doing. So hopefully it will help us to expand further. Thank you again. Thank you organizers for giving this opportunity, and also like to thank our professors and faculty SGPJ for this opportunity. Thank you.
Santosh, really it is a very good procedure. Combined
questions will take later.
Okay. It is combined individual procedures plus surgical. It will reduce the cost and it will increase the patency also. And the most important thing is that it will take more time to mature than angioplasty, for less time than kidney fistula. I did nice presentation. We'll take questions later on.
We'll take questions in the end. We are running almost half an hour late. We have online presentations also. So next talk, I would like to call Dr. Apurva Srivastava. He's a consultant vascular surgeon at Sir Gangaram Hospital, and he's my very old batchmate. We entered the MBBS same time, and I'm so happy after 23 years we are sitting here on same podium as a vascular surgeon. So Apurva, and he's going to give actually answers for all those cuts can actually be avoided if you do a good angioplasty. That means really good angioplasty with advances. You can actually keep the same fistula running. Dr. Apurva.
Good morning, everyone. Thank you, Dr. Himanshu, for giving such a nice introduction. And thank you, organizers, Dr. Himanshu, Dr. Mahendra, for inviting me for this presentation. And Dr. Mahendra is one of my illustrious seniors from BHU. And it is a privilege presenting about my talk over here in front of everyone. So my talk is a bit different, what all we have been talking up till now. So my talk is regarding role of cutting balloon and drug-coated balloon in AVF angioplasty. So as we know, technology keeps on advancing. So coming to the endovascular interventions, numerous endovascular interventions are coming in practice nowadays. And one was the endo-AVF that has been talked in detail by Dr. Robert already. So I'll start my talk, nothing to disclose. So AV fistula stenosis. So all of us who are sitting here practically in our day-to-day life, this is the most common problem that we encounter in CKD patients. And it is very troublesome for the surgeon who has operated, for the nephrologist, and even for the patient also. They keep on spending lots and lots of money. So one proper solution is needed for all these problems. So the most common site of an AV fistula stenosis is juxta-anastomotic, because the reason being that is the area where the flow is most turbulent. So these are the signs of AV axis dysfunction. So we have seen in previous presentations. So a decreased thrill, increased pulsatility, development of collateral veins, upper limb swelling, difficulty in cannulation, prolonged bleeding, abnormal recirculation, low flow in the fistula. So all these should lead us to the suspect that there is a problem with the AV fistula. So we've seen about the surgical options, we've seen about hybrid procedure. Me being a vascular surgeon, we also do a lot of surgeries and hybrid procedures. But since my talk is on endovascular options, so there are multiple options to tackle this kind of a stenosis, and you can see in the image, it is a typical anastomotic stenosis, and plus there are multiple stenosis in the vein also. So we have plain old balloon angioplasty, then we have the cutting balloons, we have scoring balloons, stents. Most of the people have started putting in vasculomimetic stents into the failed fistulas. We have the drug-coated balloon, drug-eluting stents, even covered stents. So numerous endovascular options are available for treating all these stenosis. So why there is a need for newer devices? So venous stenosis is most common cause of dysfunction, and compared with the arterial lesions, venous stenosis are lesser responsive to balloon dilatation. So most common type is juxta-anastomotic stenosis, and there are studies which have reported that 34% of the AVFs will develop a hemodynamically significant juxta-anastomotic stenosis within 3 months of AVF creation. So this is a point to be noted, and most of us do not think about these things. So the current first line therapy for treatment was percutaneous transvaginal angioplasty with a plain balloon. Recurrent stenosis have been common with rates of less than 24% patency at 3 years after angioplasty and 23% within 6 months of angioplasty. So alternate strategies are needed, and they include the drug-eluting balloon, cutting balloon, high-pressure balloon. We have a 6-month primary assisted patency rates of approximately 96% with the drug-eluting balloons. So now I'll divide my talk into 2 parts. First, the cutting balloons, and then the drug-coated balloons. So this is how a cutting balloon looks like. It has got 3 or 4 cutting blades or atherotomes which are incorporated into an angioplasty balloon, and these atherotomes are exposed when the cutting balloon is inflated. They disrupt the fibroelastic continuity of the ring of neointimal hyperplasia. So theoretically, it could provide more long-standing primary patency because it creates microsurgical incisions before dilatation, which facilitates dilatation with control and localized damage. So we can see in the images, there are atherotomes and cutting blades. So these are controlled and direct incisions made to the vessel wall, and they dilate the stenosis, and they reduce the neointimal hyperplastic response, which is the main cause for an AV fistula getting stenosed. So this is the mechanics of a cutting balloon. We can see we usually don't overinflate it. We inflate it to the nominal pressure because that is sufficient for cutting in through the stenosis. So these are various devices which are available. This is by Boston Scientific, the flexotome device, and we can see the size of the blade is almost equivalent to the diameter of 2 human hairs placed on top of each other. So now coming to the literature, the first report described for a cutting balloon was by Warwick et al. In a case report. So this was published in Cardiovascular Interventional Radiology Journal. 71-year-old patient with a brachiocephalic fistula, high pressure balloon dilatation failed to open the stenosis. So they used a 3.5 mm coronary cutting balloon, which helped in dilating this stenosis. So you can see in the images the cutting balloon that was used. Then coming to the literature, the various randomized trials that have been done. So this was one of the study. Around 35 patients were randomized to balloon angioplasty and cutting balloon angioplasty, and various parameters were noted. So balloon size used was 5, 6, 7, 8. There were different types of stenosis, different types of fistulas. So what the study concluded was that the primary patency as well as the access primary patency was significantly different in the cutting balloon group. So we can see in this analysis, cutting balloons performed better as compared to the normal balloons for primary patency. So there were significant differences seen in this study, and it seemed to have a better 6 months patency. Then there was a randomized clinical trial of cutting balloon angioplasty versus high pressure balloon angioplasty. This study was done in Singapore, and again a prospective trial, randomized trials. Around 71 patients were randomized to 36 to cutting balloon and 36 to the high pressure balloons, and the 6 months secondary target lesion patency was significantly higher in the cutting balloon group, as we can see in the charts. So cutting balloon again performed better in these studies. Again, the third study, the comparison of cutting balloon with plain balloons in AV fistula stenosis. So this was a meta-analysis of 2-3 studies. So all these data was analyzed, and there were 3 studies which were selected for this study. And again, this meta-analysis of RCTs demonstrated superior clinical efficacy of cutting balloon in maintaining patency of AV fistula at 6 months. Again, another systematic review and meta-analysis. This was a Chinese study. So we can see 3 studies were included, and these were the 3 studies which were included, and the technical success rate was equivalent in both the groups. The clinical success rate was equivalent in both the groups. So cutting balloons, as far as success and clinical technical success is concerned, it is similar to the plain old balloon angioplasty. But when we come to the primary lesion patency rates at 6 months, so we can see in the forest plot that in this study it favored a cutting balloon angioplasty when the patency rates were confirmed. So now coming to the drug-coated balloons. So the basic of a drug-coated balloon is it releases an anti-proliferative agent into the diseased vessel wall. So this drug can deposit, and it has got a minimal systemic release. Paclitaxel is well suited and used most of the cutting balloons, and it also inhibits smooth muscle proliferation and thus prevents neointimal hyperplasia. So this is basically a mechanism of action of a cutting balloon. It has got paclitaxel drug, it has got a urea as a carrier so that it is uniformly distributed throughout the lesion. So this was latest report which was published in a NEGM, and this is one of the standard journals all over the world, published in 2020, and it was a prospective single-blinded 1:1 randomized trial. Around 330 patients. Patients with new or restenotic lesions were eligible, and after high pressure percutaneous transluminal angioplasty, the participants were randomly assigned to receive a DCB or receive a standard balloon, and then primary patency, target lesion revascularization, they were assessed. And here also we can see in the charts that the effectiveness and safety endpoints within 6 months were significantly better in the drug-eluting balloon group, as well as the secondary endpoints such as target lesion revascularization and reinterventions, they were also lesser in the drug-eluting balloon group. So we can see in the charts, again, the drug-coated balloons performed better when compared to the standard balloon angioplasty. So it was found in this study that drug-coated balloon angioplasty was superior to the standard angioplasty for the treatment of stenotic lesions in AV fistulas in 6 months and 12 months patency rate. Again, this was a systematic, so there are numerous studies. So better is to focus on a systematic review and meta-analysis of all the studies and what they say. So I have tried to include the systemic meta-analysis and the reviews. So this was also another study published in the Journal of Vascular Surgery. 3 studies, 141 patients, DEB compared with the normal balloon angioplasty. And this also concluded that DEB angioplasty was a more effective treatment for AVF stenosis at the juxta-anastomotic site compared with the transluminal angioplasty. So these were the 3 studies which were included, and we can see from the forest plot that all these analysis, the meta-analysis was more in favor of the drug-eluting balloon group as compared to the plain balloons. Again, this was a comparison, another systemic review and meta-analysis. So this was a Chinese study and investigate the safety and efficacy of DCBs and common balloons, and lot of literature was analyzed. So this was a pooled analysis of around 14 studies, and it concluded that compared to the cutting balloons, DCBs as a new endovascular treatment have a higher primary patency rate of target lesions and can delay the occurrence of restenosis. There is no evidence that DCB can increase the mortality of patients. So it has got a good safety profile it can use for AV fistula patients. So this study was a very extensive study which included multiple regions of the world, and one more conclusion of this study was there were regional variations also in the AV fistula dynamics and patency rates when the angioplasty was done. So this is the last trial that I will discuss. So this was published in Journal of Vascular Access in the year 2019, and it was a multi-center randomized blinded control trial of DB versus standard in recurrent native dialysis fistula stenosis. The primary endpoint of this study was late lumen loss in trial area of ultrasound at 6 weeks, 3, 6 and 12 months. So again, we can see from the charts that the late lumen loss was lesser in the drug-coated balloon group and more in the normal balloon group. And when we come to the freedom from reintervention, so freedom from reintervention was also better in the drug-coated balloon group as compared to the normal balloon group. So all this extensive research, meta-analysis and studies have indicated that compared to the plain old balloon angioplasty, the newer techniques that are available, I agree that availability is still limited in our country, but drug-coated balloons and cutting balloons, they have performed better in most of the studies. Not all studies, but most of the studies. So this is a short video that I wanted to include. So this was one of our cases recently presented with a failing AV fistula. So see, access is surgeon dependent. It depends on you what access you want to take choice. It may be the brachial artery, maybe radial artery. You can puncture the fistula. You can puncture the femoral vein and come through the groin. So for a central vein stenosis, we usually puncture the basilic vein. So this was the pre-op picture, tight anastomotic stenosis. Distally, everything was good. The cephalic vein was good. And you can see a good cephalic arch draining into the subclavian vein. So initially, we did a plasty with a plain balloon, 560 mm balloon. Plastied the anastomotic side and the fistula. So good result, but to prolong the patency of this fistula, if we go according to literature, so I decided to use a drug-coated balloon. So it was a 5 into 150 mm drug-coated balloon, and we can see a good result after the post-DCB venoplasty. So I expect that the patency that I will see in this fistula, maybe after 6 months or 12 months, will be much better if I had done only a plain balloon angioplasty. So this was the same patient. We can see a pre-op Doppler and the post-op Doppler. So pre-op Doppler, you can see on the top. So good vein here, but after this branch tributary joins, you can see the vein is completely closed off. So this was the same patient that we discussed. So this was the post-op Doppler of the same patient. And you can see after the tributary that has joined. So there is some perivenous hematoma, but patency is still there. The vein is functioning, there is a good thrill. So post-operative, there was a good thrill in this patient. And we have our own cath lab, and we get the ultrasound prepared in all our cases. So I'll end my talk with a take-home message that gold standard treatment with most of us still remains the use of balloon angioplasty. High pressure balloon is preferred. So compared with the plain balloon angioplasty, newer devices, including the cutting balloons and drug-coated balloons, have higher primary patency rates of target lesions at 6 months and 12 months. And they can delay the occurrence of restenosis in these patients. So they can prolong the life of the AV fistula in these patients. However, the availability of devices is limited, and there are certain cost issues in our country, and still more extensive research and long duration follow-up studies are needed, including head-to-head comparison to form a consensus. So you have to choose the option very wisely for your patient, because your patient is going to come back to you throughout his life. So you have to choose very wisely while doing your intervention. So this is our hospital, and this is our hybrid vascular cath lab, and recently we've got a new cath lab added to our inventory. And this is our team of vascular surgeons at Sir Gangaram Hospital. And I'll end my talk here. Thank you.
Thanks, Apur. I must say, you've got Mercedes of cath labs. So
thank you.
We'll continue with the session. There's a little change, and we'll have discussions at the end. The last, the talk by the Dr. Shiva Rai, which is online, is going to be next because he's waiting. And the talk by Dr. Banerjee will be switching to next session as the first talk. So can we have a Zoom link online, please? We are running around 30 minutes late, 25 minutes late. So Dr. Shiva Rai, he's, so we have heard from vascular surgeons, we have heard from nephrologists, intervention nephrology, and now we are going to hear from the intervention radiologist in India, who has got probably one of the biggest experience of the endovascular interventions in AV access, probably in Asia. He's going to present his AV fistula angioplasty experience of 650 cases. And if I'm not wrong, Dr. Roy, this is only about the one significant kind of angioplasty you're talking about? Because I know your experience is much bigger than that.
So can you hear me?
Yeah, we can hear you loud and clear.
Oh, very nice. I can hear you very nicely. And that's, I just heard Apurv's talk. Thank you very much for this very kind invite. Yes, you're right. So this is actually a presentation from this year, which we looked into our data over the last 10 years for only the perianastomotic stenosis and occlusions. I think very similar to what Apurv was describing, the perianastomotic area. So this is not cannulation zone angioplasty, and this is not cephalic arch. So yes, there are cannulation zone or cephalic arch in this series, but they all have perianastomotic plus. So if there is a central vein that needs to be treated, of course that has been treated, but the primary problem in all of these patients are a non-functioning AV fistula because of a perianastomotic problem. So this actually is a study. So this is not really a lecture because you're also running late. So if you wanted, then there was a couple of cases I can also show, but here this is just like a normal presentation of a study. So can you see my screen?
Yes.
Okay. So the study was actually to look at that we have two main techniques that we have to treat the perianastomotic stenosis. And we wanted to look whether there was a difference in the results of using the two techniques. And I personally believe there is. It didn't turn out to be the case, as you will see. So the purpose of this study is, as you have heard, Apurv, and throughout the day you have been listening about, the principle of fistula first. I think whoever does this or whichever way we do it, there is no doubt about the basic principle that fistula first it's a lifeline for the patient, and it's really important that we keep the fistula going and keep it open. So fistuloplasty, that is where fistuloplasty comes in. And although access failure can be due to problem anywhere within the circuit, inflow, anastomosis, outflow, arch, central vein, the perianastomotic region within the first 3 centimeters, most people describe it as, some people talk 2, some people say 5, but let's say 3 centimeters of anastomosis is a critical area of the fistula. The way I explain to patients is that you have taken a girl to her sasural, and it is not going to be as happy as it was in the father's house. I'm just joking. So, but the point is that that is an area that it's never necessarily a fault of the surgical creation. It is just an artificial way that the fistula has been made. So it is a normal place where a stenosis can happen. Now, traditionally, a perianastomotic failure, particularly from the surgical group, was treated by proximalization. If you look at the papers from the sort of the noughties and the early or the late 90s and the noughties, they showed that angioplasty performed worse when compared to proximalization. A proximalization or redoing of the fistula was the standard of care. So, but this is not my practice in the United Kingdom. In United Kingdom, the practice is proximalization. It is still proximalization. When we came back to India, it was not so easy. It was not so easily accessible. The fistulas that were there, the vessels were poorer. So we started this as an alternative. Then it turned out that this was actually good. Then we, of course, over the period of 10 years, we have refined our technique, and this is what we wanted to talk about. So the principle of treating a fistula, which I feel is the crux of this study, is that the anastomosis must always be treated. So how can the anastomosis be treated? It can be treated in this U configuration, whereby you have got an occluded fistula, as you can see, with a tiny little stump. So most people will consider this to be non-revascularizable. So you can either do it like in U, so coming from the brachial artery, or from the vein, and you can do a U with a balloon like this. Or you can do sequentially, you can do it like a V. So you put a balloon like this and you put a balloon like this. So both of these are actually treating the anastomosis. And I believed that the U would be physiologically better because it is in line with the flow as opposed to the V. Okay, so that was the hypothesis. So what we did was the 640 fistuloplasties were performed in 590 patients over a 10-year period. This is up to February 2024. And as I said, the anastomosis was always treated. I've already told you what V and U meant. And the inclusion criteria were all native AVFs. There were some immature AVFs which were included in this group. A subset analysis is being done for that immature group. So they were stenosed or occluded. So grafts were excluded, hybrid procedures were excluded, and of course, patients that were lost to follow-up were also excluded. So how did we do? We decided on what access to take and which way to do on pre-procedure Doppler. So all of them had pre-procedure Doppler velocities documented. Then technical success was defined as the ability to establish a good flow, TIMI 2-3 flow after the procedure was done. And a clinical success was defined as establishment of dialysis, at least one successful dialysis after the angioplasty. Primary and assisted patency were assessed by Kaplan-Meier statistic, and censoring of patients who had died or transplanted with a working AVF was done as a standard practice. And the assessment of complication was done as per the SIR classification. So nothing new in this. So access, like we were describing, antegrade brachial was sort of the majority, retrograde radial to go for a V, or a retrograde venous. So these were the three different types of access used. Always done on ultrasound guidance, heparin, ACT maintained, POVA, essentially POVA. Very few of these are drug-eluting balloons, mainly because of economic considerations. I understand what the literature is, but I will also give you my theory why we couldn't use drug-eluting. Because to be honest with you, if you look at the patency results, the results were better than the established drug-eluting results. We did transform from 035 to 018 platform, and even in some cases an 014 platform in difficult cases. So plasty was done either as a U or V. Now you could argue that what made us choose. So as I said, the anastomosis was always treated. My default configuration was to do a U. But sometimes if we felt that the brachial artery access was risky, we felt that crossing the vein can be quite difficult coming back, or if we felt on ultrasound and on venogram that the artery and the anastomosis was definitely okay. Now, what I've learned over time is that even if it looks absolutely okay on ultrasound, if you put a balloon, you will see a waste. So that is why I feel that the anastomosis should always be treated. In long segment thrombotic occlusion, particularly if it was expansile thrombus, thrombosis or mechanical thrombectomy was done using TPA, urokinase, percutaneous. If you look at the baseline characteristic in 431, V plasty in 209 cases, mean age of 67 years, slightly more males, lot of comorbidities as you would describe, and this is the mean number of previous access these patients had before they came to us with a non-functioning fistula, and the total period they were having dialysis before they had the fistuloplasty was 18 and 20. Majority of these were radiocephalic fistula. The second most common was brachiocephalic, few brachiobasilic or brachiocubital. The index lesion was stenosed in 51% cases and occluded in 49%. So 50% of them were occluded fistulas. And this is again something we want to stress, is that occluded fistulas do very well too. And of course, there were more than one stenosis in most cases. Even if there was a no stump, and that was in 41% of cases we had, of the occlusions, that is, we had no stump. So if you look at the technical success, very, very high. I mean, both for stenosed and for occluded. Of course, occlusions had slightly less technical success, slightly, but still in the very high 90s. And clinical success mirrored technical success largely with a very high 90s overall success. And as I said to you, the platform high pressure balloons were used in 50% of cases, and about a third of the occluded fistulas required some sort of thrombus management. Now, thrombus management is not being discussed in this particular paper, but in a third of cases, we use various forms of thrombus management. And we needed a stable elective condition, and also because of their underlying clinical problems. And oftentimes they would come from outside, so they would have one or two dialysis after they finish the procedure. So if you look at the Kaplan-Meier, and these are the results. So V technique, the mean primary patency was 17 months, and the U technique, the mean primary patency. If you look at your 50%, that's what we talked about. But even at 5 annual re-interventions were less with the U angioplasty. So I do believe that this is a better technique. However, I have not been able to prove that this is a better technique. And if you compare it with the literature, I think, to be honest, the results compare very favorably. I mean, of course, there are some papers that have superior results too, but we have the results generally compare very favorably, and this is not using drug-eluting balloon. So 100 cases underwent a procedure in addition to the fistuloplasty in the same sitting. Post-procedure blood thinning, and this is very controversial, and I know that surgeons and physicians and cardiologists, all of you believe that there is no role for antiplatelet in venous disease. I strongly disagree. I haven't been able to prove it, but I must say that during this practice, the patients were on aspirin or clopidogrel and lately on a 2.5 apixaban plus aspirin, depending upon the load of thrombus, etc. So it was not a set antiplatelet, and that's a major limitation of the study, that it was variable and we don't have a standard of care. Complications were seen in 20 cases, which were mostly minor. Serious complications, including deaths. There were 2 deaths related to intracranial bleed, which we believe is related to the thrombolysis that we use in the cases. So yes, there were some intracranial bleeds too. Very rare. So I'm just going to finish with a few quick cases. So if you look at a standard case, like there is an occlusion and of the perianastomotic region, and the wire is already through, and then you just put a balloon across, and then you do the angioplasty. So we do a 5 to 6 millimeter for the vein, and we do a 3 to 4 millimeter for the anastomosis and the artery, and this is the fistula result. Okay, so this is a pretty standard. This is what I was saying. So the pretty standard angioplasty we do. So here, I don't know who did this, must be my, so I would actually bring back my balloon to a little bit further back. This should be wider than this. When it comes to thrombus management, of course, percutaneous urokinase, which is now not available. Percutaneous streptokinase is the one that gave us the intracranial bleed. Now we use TPA. We do use this followed by angioplasty. Sometimes we will do a retrograde radial access to cross, and then like this, and then we will come in from the vein and then do a U like this. So the various sorts, and I'm not going to talk a lot about technique, but basically there are many ways of doing the U. We can come from the basilic across a cephalic arch or a brachiocephalic fistula and come around and do the U, and then if you treat the anastomosis, then the results are much better. So typically, if you look here, the brachial artery axis, we have done a brachial artery axis. This is not crossable, I think. So we have done the perianastomotic. Oops. Okay, so this is a standard brachial artery axis. Now there is, as you can see, that there is a competing vein coming out. So again, there are a lot of little technical things. So this is a competing vein, which as surgeons, you would probably, when you made the fistula, you would have ligated this. So what we do nowadays is we do an ultrasound guided percutaneous laser closure of this, and because of venous diversion. So here you can see the the needle into the collateral vein, and then a laser tumescent anesthesia followed by a laser into the vein, and then immediately afterwards you can see that the PSV has increased from 65 to 125. So these are all adjunct procedures that we do after the fistuloplasty. And here you can see that the laser occluded vein is now not taking, and there is more flow through the fistula. For the lack of time, I'm not going to talk about various other techniques going up and down. I don't know whether there's this. Okay. So my point is that you need to treat the veins to an adequate, the tricks of the trade, and if you do that, then the results are good. So in cases where we have calcium or a persistent failure, in cases where we have the anastomosis not staying open, even with a high pressure balloon, in very rare cases, we will put a supera. There are problems because of size mismatch, but we have done about 14 cases so far, prospective data keeping, to see whether we can reduce the number of interventions. It's really important that you don't encroach onto the cannulation zone with the supera. I don't know, you guys will probably know better whether it is okay to cannulate a fistula through the supera, but we have been trying to avoid that. provisionally, I can tell you the results are probably better than keeping on doing POVA. But there is also the downside of the occluded supera is a much more difficult ball game than without. So in conclusion, as I said, principles of treatment is that all wastes must go. Treating the anastomosis and the perianastomotic region with adequately sized balloons and establishing an outflow which can be either a conventional or collateral is key in increasing the dialysis access. And use of ultrasound to judge the size of the artery and vein for adequate sized POVA. And although you and we appeared equivalent in this particular study, in the first half of the study, it was better. It's only after we increased our numbers, it became like this. Can I call you back in 2 minutes? So yep, thank you very much.
Should we take the remaining?
I'm sorry, I'm in a meeting. Can you please go? Sorry, yeah, go on.
Personally, being a surgeon, what would be your criteria for choosing or rejecting a patient for fistula salvage when he has an occluded fistula? This is my first question. And my second question, I understand if I were not to ligate, branch vein, I just keep that aside. What would be my laser settings when I am ablating the branch vein with the laser? Is it the same for a truncal or do I change it? So these two questions.
Great questions. Absolutely great questions. So the answer to your first question is that I don't believe there is a non-salvageable AV fistula. I know that this is a very rich statement to make, and I'm not being boastful when I say it. So, but yes, of course, what does it mean that I treat every occluded fistula that if I don't have an adequate artery, then I will not go overboard with my salvage. What do I mean by that? If I'm going to be bad, then I'm unlikely that I'm going to get a long-term outcome out of that fistula. Now, if the radial artery has got a solitary treatable stenosis, then fine. But if you know what I mean, that, sometimes you have a 1.8 millimeter artery with multiple calcification in the wall, that fistula is doomed to fail. We have tried. It is not that we have never tried them, but that is one criteria that I would say that I will not touch. The degree of occlusion, and I again, these are things that I should write rather than just speak. We have opened, patients have come to us with an occluded fistula and we have failed. We have opened the other fistula that was occluded 2 years ago. Occluded. So we have actually opened the fistula that the patient did not come to us to be opened. So this concept that you cannot open what we were taught, right, that you cannot open a fistula which is more than 4 weeks or 3 weeks occluded, is again not right. There are so many techniques coming up and down, puncturing the, needling the occluded area. There are many techniques. And as I said, because this was an overview, I did not go into the techniques, but there are ways by which you can actually recannulate a fistula. And you will be surprised that a long occluded thrombosed fistula, it is similar to the DVT, maybe between 40 to 50 or even less if it's close to the skin. What?
Great. So always an admiration listening to you, and I think we would have all loved you to be here, and if Dr. Himanshu has a few words for you.
Thank you very much. Thank you.
I will agree with you that there is no fistula that cannot be opened. But
yeah,
the point is, if you have a case where radiocephalic, which has got, maybe replasty 3 times last year, and has got a 5 nice cephalic vein at elbow, and you can create a really good fistula, and then teach him importance of the surveillance. Now, that is the place where actually I'll give up in terms of salvaging that radiocephalic fistula, rather put in a catheter, pump cath, create a good brachiocephalic fistula, teach him about the importance of surveillance and good puncture techniques. And so it's not about what you
could
can
not
do, it's about what
could
you
not
are able
agree
to do.
more. No, we have this threshold, Himanshu. You're absolutely right. We have this threshold that we have a threshold. It's not just about the Kedoki. It is not just about the principles of fistula first. We live in a country where money is also very, very important. Fistuloplasty is expensive. Okay. It is more expensive than you creating a very nice fistula. So therefore, that has to be taken into account all the time. So we have a principle. We will not do a fistuloplasty more than twice a year.
Yeah, that's I think what we wanted to hear.
Yeah. No. That we won't. Yeah. Hmm. Hi, Digvijay.
The U configuration you highlighted well, it is well taken, and for everybody, it is not only important when you make that fistuloplasty, it is very important when you make the primary fistula itself.
Just absolutely.
Second, if I had a series as big as yours, maybe I will be putting in more stents upfront to keep it open. Then your 5-year patency, maybe cost is an issue. And for everybody, it is not the thin segment that you see that is disease, it is the whole U. That is called the anastomosis, 2 centimeter of the proximal artery, anastomosis, and 4 centimeters onto the vein. That is your target area that has to be dealt with to get any good results with a just anastomotic fistuloplasty.
So, Digvijay, can I just say this, that what you have just said right now is contrary to the entire vascular surgery and the endovascular, IR literature, because they have all stressed upon giving a drug-eluting balloon to the cannulation zone. Whereas, as you said, that actually the disease is in the anastomosis and the perianastomotic region. And yes, about the stent, the only problem I have, I think if we in India discover a stent which is tapered, it will be great. Because one thing that I have found is that that from 2.5 millimeter to the 6 millimeter transition, even if you put whichever stent you put, it is not an ideal device. So I think we should form a group and try to devise a stent that is, like tapered with low in the artery and big in the vein. I think that should come. But treating the perianastomotic is more important than using drug or POBA.
And I will repeat, the perianastomotic is 4 centimeters onto the vein and 2 centimeters into the artery, including the anastomosis. So, sirf Veincon mat dekho udhar. You are going to not do good job there.
Thank you. Thank you. Great question and a great thought. It's a as you just said, that because of the radial inflow problem, it is the ulnar collateral, and from the distal radial, the flow is coming into the fistula. So therefore, you should treat the distal radial. The contrary to that thought is that it's a steel. If you treat that, then it's a steel. So I don't know. It's a great thought. I would look at it in terms of when we do our cases. But what is your thought? You think that should be routinely done? The point I think that I will say against that point is that because if there is a stenosis in the distal radial, that is improving my fistula flow. If I open that up, that is going to steal my fistula.
So unlike the other patients, the CKD patients, the arterial disease is also an issue. So when we treat the distal radial artery also, so there is a possibility that the flow to the fistula will increase. So that should.
I get you. So I think the answer should be that when we do an angiogram, the brachial angiogram, we should see is the flow coming via the ulnar and the distal radial rather than down the radial. If it is coming like this, then we should also treat the distal radial. I think that is what you're trying to say. Yeah. Good thought, boss. Good thought.
So good afternoon, sir. This is Dr. Santosh here, sir. I have a small doubt, sir. So regarding the U and V configuration, basically we are referring to the antegrade and retrograde approach. Antegrade going via the distal artery, retrograde coming via the outflow cephalic vein. Recently, we had
No.
a study, and it's about to be published by one of our seniors, Dr. Hemant, on why, comparing antegrade and retrograde access approaches for RCAVF. What we found out was that one, feasibility and operational feasibility, it's easier if you're going to go via the antegrade approach, sir. It's quicker. We have to just cannulate the distal artery, sheath, send in the wire. Other advantage is that going via retrograde, especially in a thrombus fistula, is going to be difficult. One, to pass a guide wire. Second, we need to use the angiocatheter. Third, every time we have to keep using the angiocatheter for the angiogram purposes also. So its time constraint is also going to be there. More radiation exposure also going to be there, which is also a significant point. And third thing is, supposing we have a thrombus fistula and there is a downstream stenosis in the mid arm or in the central venous. Many a time, patient comes with thrombus RCAVF. Once you're done thrombectomy, then we look at the central system, we see that there is a stenosis sitting there. That being the case, if we have an antegrade approach, same sitting, we can pass a guide wire, go to the center and try to open it, or if there are multiple site stenosis anywhere in the intervening segment can be done. If you're going to go via the U configuration, what I feel is that, sir, then either we need to flip the sheath or we need to take another access to treat the multiple site lesions. So just my observation, sir, and your thoughts about
So
that.
it's great that you have published, and I mean, like a stupid guy like me, I've done so many cases and not published. So congratulations on that. But I just wanted to say to agree with you and also to disagree with you on a few points. So, for example, the first point that you made about the antegrade access from the brachial coming downwards, crossing easier, quicker, less radiation dose. Could not agree more. The downside, though, is that brachial sheath, even a 4, 5, 6 brachial sheath, is much more difficult to control than a venous sheath coming downwards, right? So that is the first point, because the brachial artery is more prone to complications. The most complicated artery to cause whole hemostasis. So that is the first point. But the fact that to cross is easier antegrade brachial, there is no doubt, mainly because of two reasons. You've said already the reason. In addition, is that it is in line with the blood flow, no? So you are going along the blood flow, so your catheter, your wire is easier to cross as opposed to coming retrogradely. Second is that when you are coming retrogradely from the vein, you are going to go into all these tributaries, and that is where you are not able to reach the anastomosis in the case of a thrombus. So yes, coming from the artery is technically easier, although more risk at the elbow for hemorrhage. The brachial antegrade sheath, however, theoretically it is good that you can then cross into the central vein, but you have to understand that the sheath in the brachial can only go up to a certain size, right? I don't put more than a 5 French for a fistula. So then if you have to treat the central vein, you have to come from the groin, because you want bigger balloons, you want bigger sheaths. But the principle that you can treat multiple stenosis using one access from the antegrade brachial, I completely agree, and that is what we try to say as well. Thank you. Thank you, Himanshu. So it looks a great meeting.
The anastomotic and proximal artery concept was started by Swinen, and he was very clear how to approach it. You would make a small cut down onto the shoulder at the vein, and then first do the proximal part, and then go down vein. I agree with you. Brachial access as an entry point for fistula may sound good, but we could have significant 30% issues with the access itself when you finish the job. Not very good position to be in a sick patient. So,
we have developed a technique of closing the brachial. We have a technique, so that is since we have started using that, we have not had brachial artery complications. So yes, so basically you're right. The brachial artery sounds good, but you have to deal with the artery very carefully.
Dr. Roy, this has been wonderful. We are running almost quite significantly late.
Yes.
So thanks a lot for finding out time, even despite from busy schedule. I know you're at Mumbai and heading for another talk. So we end this session. I would like
Thank you very much.
I would like all the speakers and chairpersons to come on stage. And Dr. Aman Singh, sir, please come and felicitate our chairpersons and the speakers. Dr. Santosh, Dr. Apur, since we have to cover almost half an hour, I would request for speakers to, if they can cut down and in maybe few minutes, if they can spare from every talk, so that we'll have more time for their discussion. Also, all of you will have this kind of paper in front of you. Before we have a talk about AI in vascular surgery and vascular access, this is a use of AI about getting your photographs. So all the photographs which photographs have been clicking, if you scan, it will take you through and only your photographs will be available to you. So please use it.
Thank you, faculty, for that very wonderful session. So with this, we are moving ahead with our next session, which is Perspectives in AV Access. And I would like to invite and welcome our chairpersons on the dais. I welcome Dr. Apurva Srivastava, Consultant Vascular and Endovascular Surgeon at Sir Gangaram Hospital, New Delhi. Dr. Neelam Sun, Assistant Professor at Vascular Surgery at Shillong. Dr. Manzoor Ahmed Pare, Assistant Professor of Nephrology at SKIMS, Srinagar. Dr. Deepak Diwan, Director, Department of Renal Sciences, Regency Super Speciality Hospital, Lucknow. Dr. Divashish Saha, Senior Consultant Nephrologist at Veincon Polyclinic, Lucknow. So we have the follow-up of the last session, Dr. Subrata Banerjee's talk.
Dr. Subrata Banerjee. Yeah, sir. Dr. Subrata will be speaking.
Hello. So the next speaker is from the previous session, that is Dr. Subrata Banerjee, and he'll be talking about AV fistula salvage options, a vascular surgeon's perspective. So let's welcome Dr. Subrata Banerjee, sir.
Good afternoon, everyone. Thank you, organizers, for this wonderful opportunity to speak on AV fistula salvage. And a personal thanks to Dr. Himanshu Verma. It's been a wonderful journey with him. He's been the person who has, literally held hands and taught us what AV fistula is. Now, the problem with my presentation is, sorry. Okay, so sorry for that. The problem with my presentation is AV fistula and vascular surgery in India is like an orthodox arranged marriage in India. Whether you like it or you don't like it, you have to do it. Initially, you don't know what you are doing. you start knowing what you are doing, and just about you start knowing what you are doing, you realize that what is beyond you is really extensive, and it incorporates a lot of things. Slide इधर से कैसे जाएगा? Slide आगे roll कैसे होगा? Slide. Okay. So, and on that note, I think rather than a perspective, it's my experience as a vascular surgeon that I would share. So, you know, after the elaborate talks by Dr. Santosh, Dr. Shubro, Dr. Apurv, this is when I am practically called. Yes, Doppler, surveillance, everything is fine, but the alarm bell comes, you know, clearance is bad. It's recirculating. You know, it's a big fat arm, I cannot cannulate. It's now so bad that the patient comes back and says that, you know, these guys are pressing on my fistula for hours for hemostasis. And worse come worse, sometimes, I'll show you a case, it's a pseudoaneurysm or a bleeding. Now, when you start off doing AV fistula, the first thing that is taught is that doing a fistula, but the challenge actually is in maintaining it. Okay. So, you know, when you come across these problems, then, you know, you have to have a roadmap in your mind. So, as we discussed, it can be in the inflow, that is the artery. It can be juxtaanastomotic, a font zone. It can be in the upstream vein. It can be in the cephalic arch. It can be in the central vein. It can be with or without a thrombus. Now, to tackle this, you have, yes, plasty, stents, if you require, thrombolytics, thrombectomy devices, venoplasties with stent in the central zone, being a surgeon, a revision, a rerouting, or a transposition. But what is important, you know, just taking a leaf out from the last discussion is, you plan well. And an access, you know, is not really mandatory a retrograde or an antegrade. You can find an access, usually my favorite access for an outflow vein, not a juxtaanastomotic, is the numerous outflow branches that you get. You get lots of collaterals in an outflow stream when you can get into the collateral, target your area, and do a plasty. You can go in through the brachial artery, you can go in through the radial artery as well. Keep your balloons ready, whatever you require, be it the cutting ones, the high pressure ones. And if you do require a metal, keep that ready as well. Now, I would like to know from the house, probably from Dr. Apur, Dr. Himanshu, you know, what are the thoughts of putting in probably an IVUS or an OCT in this zone, like we're doing for the peripheral segment? Because see, once you know that the anastomosis is fine, once you know that there is nothing in the anastomosis, clinically, ultrasound and on a fistulogram, you can take care of the outflow vein in a simple outflow vein plasty. You can do the same at the forearm level, you can do the same at the arm level, but yes, please be mindful of lesions like we were discussing here. If it is a true juxtaanastomotic, you have to have your U configuration, you have to have the artery plasted, you have to have the anastomosis done, and then the outflow vein. So that needs to be taken care of. And if you go back and if you note, the access in each of the one is different. So I choose a radial here because I know I can straight go in, do a plasty, come back. I choose a distal radial artery here because I know I do not touch the anastomosis. I have chosen the outflow vein, branched vein here, which is not shown. It is on a branched vein in the outflow vein, coming down, doing a U into the brachial artery. I would rather, you know, just put in a butterfly in the brachial artery for a shoot, or even put a maybe 20 gauge Veincon for a shoot, because I would not want a robust access on a brachial artery until and unless it is absolutely required. Now, when you come to the distal end, you can do a balloon, you can leave it alone. You can do a patch. If it is a patch, it is a long patch. Please forgive me for putting in that white structure. I would ideally have put in a vein, but I would go from the artery onto the outflow. Now, would you put in a stent there? I don't know, people have put in a stent. Ideally, no. I would rather do a plasty. If it works on a balloon, fine, but I would rather do a plasty then. Now, if you go higher up, it can be the cephalic arch, and this is a notorious area. I think the last discussion with a tapered stent would be ideal, but as of now, the best thing that you can do is do a plain old plasty. DEB's dubious role, you may not, but if you get a good flow at the end of it, that's good enough. Do keep a cover stent if required. And very seldom I have required a Covera, but yes, I have required. Central vein, the only learning curve that I have got as a vascular surgeon is patience rules. If you are not brute, if you are not using brute force, you would hardly rupture a central vein. If you are trying all the access, that is the fistula or the graft, whatever you have in hand, and if you are coming also from the groin, using catheter wire combinations with proper support using a long sheath, sometimes the back end of the wire judiciously, eventually you will get through. More often than not, without causing a rupture which will make the patient unstable, because these veins are mostly fibrotic. So until and unless you are brute and blind, you would rarely rupture, but yes, keep that in mind. So these would be tight lesions, and this was one of those ladies that I did. This was her last option with a fistula in the hand, tight central vein stenosis. I had a good inflow from the fistula, long segment lesion, significant recoil on the table, put in a wall stent, almost like looking like a permacath going right into the SVCRA junction. No major thrombus, working well. She's 3 months on dialysis. No issues with the fistula as of now. This is right out from my learning manual when I was a vascular trainee. We used to get a few over-the-wire embolectomies then. I do not get it at the place where I work now. If it is there, you can take care of the thrombus with an over-the-wire embolectomy. Of course, these days you have thromboaspiration and thrombectomy device, but I'd come later as to why and when I can use and use them not. Now, this was an interesting gentleman, elderly gentleman, on dialysis for 8 years. The last fistula, right cubital fistula, came with hemorrhage from those pseudoaneurysm sites. I literally had no other options for him. He was a cardiopath, he was on dialysis, he had history of stroke, and we had episodes of bleeding from these thinned out skin. So the only option I had was to put in a covered stent. I had to educate the patient and the technician about cannulating across the stent, not into the stent. We can cannulate into the stent if required, but you can see that we had area of cannulating across the stent. And surprisingly, when we were discussing whether we would put in a prosthetic graft or not, and I just voted for a stent, and the patient 2 weeks down the line landed up with a stroke. He was hemodynamically unstable, but the fistula kept running. And he lived for 6 months, and he outlived the fistula actually. So yes, I'm not a big fan of putting in metals in this zone, but when and as required, I would. Being a surgeon, I would always look for shortcuts, and this is a beautiful shortcut for me. Having a fistula in the cubital zone with a poor outflow, but having a good basilic vein, the fistula has been running for long. Just hitch up the basilic vein up to this existing fistula. It's not a standard basilic transposition, but yes, it is a transposition of sorts. You can use a prosthetic if you do not have a basilic vein as well. It's just about connecting the dots, the healthy proximal to the healthy distal. So when I'm doing an angiogram, I'm not only looking at if I'm opening a lesion or not, but I'm also looking at if I have a shortcut being a surgeon and if I can enjoy using my scalpel as well. And this is right out from my learning days with Dr. Himanshu, and I thank him for this. Please do not forget, it's not about the flow of dialysis, it is also about the limb. Now if you have an ischemic limb in a proximal fistula, this is a beautiful procedure. You just have to take a tweak of the long saphenous vein, hitch it to the distal artery where it is patent, the fistula keeps running, and the hand more often than not gets saved. And as much as I will thank Dr. Himanshu for this procedure and for this, I cannot forget from my residency days, this was a gentleman on whom I did my first cubital fistula in my first year of residency. Come second year of residency, this basilic fistula on the other hand. And come third year of residency, we did a drill on him. And, it teaches you that you can probably salvage an access and keep it running. But having talked about my experience, yes, there are challenges, not everywhere we work in an elite setup like the NH hospitals or Sir Gangaram or Medanta. I'm running about the city, so yes, lots of fistula work happens in a nursing home. It has to be a CIAM-based facility. In a corporate hospital, you're always asked, come at the end of the slot after the cardiologist and the neurologist are out. What remuneration will you give for that? Hardwares, when I started off in the city, it was all coronary. So getting the catheters and the balloons, and even sometimes the size of the balloons was a big challenge. This all has been discussed. In my own head, I will always have a challenge where to put in my scalpel, where to use my wire and balloon. But believe me, if you use the proper hardwares, and if you are not really using more of ETO hardware, scalpels are very rarely required. Honestly, head-to-head comparisons are very less, but then there are some areas like the axillary, a good basilic vein. I would always prefer a surgical access. We did a few cephalic arch turn down as well, so that also gives a strong competition to the cephalic arch plasty. But then in India you cannot get away with this. If you do not have a patient with scheme support who is paying out of their pocket, he will count that I can get a 5 fistula done in the cost of a fistuloplasty. And repeated procedures, same patient, you call me every 3 months, you charge quite high, who are you? So that question has to be there. And I cannot be out of the society, science is fine, but we live in the society. We started this off as residents 10 years back, and it's wonderful to see that each and every presentation now talks of correlating the fistuloplasty with an ultrasound. If time permits, I can run this video, if at all it is running, because this is one of the fistuloplasties in which ultrasound saved my day. If you can see, I can see nothing upstream. I always have my ultrasound by the side. On that ultrasound, you can see, a very thin vein through which after multiple trials, I could see an 014 guide wire go through, nothing on the fluoro, but I could see it on the ultrasound, it is going through the same vein. I had the joy that it had passed the vein when I took this shoot. Did a plasty, put in a DEB, tight lesions, yes, no cutting balloons, high pressure balloons, just graduating the sizes, and it's run for around now, I think it was done in the month of July, so it's running for around 4 or 5 months. I would love to have a surveillance if the patient and the technician recalls for me. But yes, I do make it a point that when the patient goes back after a plasty, they become really fidgety about their thrill, and they themselves start, examining the thrill. So probably they are the best person to come back early. So if this video runs, there is nothing new in this video apart from the fact that when I had that ultrasound, I knew that my wire was going through that occluded vein, and it really opened up. So that's all. Thank you everyone once again. Since Dr. Himanshu is the mentor, if you have anything positive in the presentation, it's mine. If it's bad, it's my mentor's. Thank you.
Thank you. Thank you for that talk, wonderful talk, Dr. Shubhabrata. And I think we'll have the discussion at the end of the session. So I'll invite the next speaker, Dr. G. Girish Reddy from Institute of Nephrurology, Bangalore. So his talk is on managing central venous obstruction.
At the outset, I would like to thank the organizers for such a wonderful concept. It's great that all the stakeholders of vascular access care are meeting in one roof, and I'm sure it's going to do wonders. So the only request is I would request Himanshu sir that, the topic is so vast, maybe I'll bump in few extra seconds. Okay, so let me straight away go. Before I talk, I would like to acknowledge Team INU, because it's because of them I'm having this luxury of delivering a talk here. So it's a teamwork basically. So why are we having this talk on central venous occlusions? It's a very, very important topic. If you are a transplant nephrologist, this is a topic of your interest. If you're a glomerular nephrologist, whatever it is, this is a topic of interest because it's a vicious cycle with far-reaching consequences. We all know it's a vicious cycle, obstruction causing a dilated proximal venous system, causing increased capacitance and precipitating the obstruction again. But what is the clinical impact of this occlusion? So basically it leads to patients with under dialysis survival, poor clearances, recurrent infections, failed accesses, which ultimately leads to mortality and morbidity. So even if you take these patients for transplants, their vessels are poor because of poor clearances. So the allograft outcomes are also not good. So it is very, very important that if you have to have good transplant outcomes, you also need to have a good program which addresses the access in a holistic way. So CVO is a well-described sequel. So we all know that hemodialysis catheters are here to stay. So when we have an ipsilateral AV fistula, it leads to venous dilation, arm edema, and recurrent infections. What are the dreaded complications, which include compromised blood flow, inadequate dialysis delivery, and finally, access thrombosed. In spite of us advancing in the knowledge of CVO etiology and enormity of its consequences, it's a recurrent problem. We don't have effective therapeutic options as of now, so prevention is better than cure. So I'm going to touch upon more on the preventive strategies. So just to illustrate what I said, there is an ipsilateral catheter with central venous occlusion. There is a contralateral catheter, brachiocephalic fistula here. It's not healing, there is a wound gaping. And once the central venous lesion was addressed, the wound has healed well. So I'll run through a very, very typical case of central venous occlusion. A young chap, 25-year-old, initiated on maintenance hemodialysis, had a tunnel catheter in situ, then left a brachiocephalic fistula was created without the surveillance of the central venous system. So this is what has happened, came with typical features of central venous occlusion. So we took him up for angiogram. So there was a femoral access taken as well as axillary access taken. We're trying to cross across the lesion, but still there is a resistant occlusion which is not giving up. Then we punctured at the confluence of the subclavian, and brachiocephalic. Hate to use this device, but was compelled to use a TIPS device. So I'm doing a sharp recanalization in the second video. So there is a marker here. This is a very, very dangerous technique, but without option we had to do this. Here my catheter is using as a marker. So I'm trying to reach by doing a sharp recanalization. Finally we crossed. So finally we crossed and did a balloon plasty. So this is the plasty. So this is the end result. We had to stent. The patient, and you can see within few weeks, patient was absolutely normal. Went back with a good functional access. Lost for follow-up in spite of repeated phone calls. Didn't come back. Now after 6 months he comes. Now same lesion has repeated again. This time we are not able to cross the lesion again. Just at the edge of the stent, patient has developed the occlusion again. So this just emphasizes it's a recurrent problem. It can happen in young patients more often or not. Patient had a proximal brachiocephalic fistula. So all these factors constitute the typical story of central vein occlusion. Yeah. So yeah. So this is a very, very important slide. So I think all of us can remember this. So what we see important slide. So I think all of us can remember this. So what we see, the central vein is just the underlying problems. So there are myriad of problems. First, patient awareness and access to the services. So what is the waiting list of patients for creation of access? Then what are the surgeon preferences for creating an access? The tendency, with due respect to all our colleagues, surgical colleagues, the tendency is to create proximal fistulas. And the nephrologists are also culprit in this regard that we want a functional fistula. So proximal fistulas are the main culprits for these central vein occlusions. And then we lack a coordinated access care. And then the catheters, the proximal access with high flows and hemodynamics finally result in central vein occlusion. So if we have to treat this problem, it has to be a holistic approach. So that's what. So it's a tip of iceberg, what we see the central venous occlusion, because there is a myriad of things which are acting underlying. So just a run through of what the catheter does. It does endothelial damage, persistent movements of the catheter causing thrombin generation, platelet activation, and inflammatory response, ultimately results in occlusion. So this is a tunnel catheter in situ, and what it does to the central venous system. So there is soft thrombus, hard thrombus, fibrin sheath formation, and this is the pathophysiology. So again, a fibrin sheath. So thrombus progresses into fibrin sheath, and when fibrin sheath gets organized, this is the consequence. So various fibrin sheath. So we try to assess what's the burden of central venous occlusion in our own patient setup. So this is one of the project for one of our DM residents. She won the first prize for a oral presentation for this. So what we found out was, longer the temporary catheter stays and more the CRBSI episodes, the risk of CVO is very, very high. Most patients will be asymptomatic. That doesn't mean that you don't have to treat these patients, because ultimately they are going to present with symptomatic central venous obstruction. So timely intervention, you know, a basic check angiogram when you are removing the catheter will go a long way in preventing these CTOs, because the thrombus is much, much softer and the lesion is amenable to treatment when you pick it earlier. So these are the various grading systems to determine whether you should intervene or not in a central venous occlusion. So again, another scoring system just to determine whether you need to intervene in presence of any central venous occlusions. Okay. So most important thing is, based on the duration of the occlusion, our management strategies also differ. So if it's an acute occlusion less than 2 weeks, you can get away with thrombolysis, thromboaspiration, and anticoagulation. If it's subacute to chronic, probably you will have to do plasty. If it's chronic, that is more than 2 months, then you have to go for a myriad of endovascular procedures. So how do we diagnose? We start from the basic ultrasound. In duplex ultrasound, you can look for the peripheral vein analysis, subclavian, axillary, brachiocephalic veins, all can be visualized. So with central venous occlusion, the indirect findings are dampening of the venous waveforms in the upper body and loss of venous pulsatility. Imaging the SVC is directly challenging, but there is good advancement with microconvex probe and pediatric cardiac probe. We can image the superior vena cava as well. So here you can see, this is the right brachiocephalic, this is the left brachiocephalic. You can see the superior vena cava completely and the right atrium. So it's an advanced ultrasound machine. You can still visualize the SVC using this microconvex probe. Yeah, so this is one of the monogram to say what are the treatment strategies, how to stent in case of central vein occlusions. Okay, so how do we diagnose? So the gold standard always remains a fistulogram or a central venogram with DSA. So the first finding is reduced vessel opacification distal to occlusion and intraluminal filling defects. Then the second thing is presence of collateral pathways. This is very, very important clue that you have to intervene. Then sometimes when you are dealing with the CTO, long-standing CTO, CT venogram definitely helps to delineate the exact site of occlusion and also what is the thickness of the vein and what is the fibrotic pattern of the vein. And then to add to that, intravascular ultrasound also helps during the treatment. So when do we decide to treat CTO? When patient has severe or life-threatening symptoms. Then if patient has cerebral edema, strokes have been documented because of central venous occlusions. When there is laryngeal edema, which can present as hoarseness of voice, stridor, and difficulty in breathing. When there is hemodynamic compromise. So all these things, if a patient has contrast allergy, then an MRI can also be used. So what are the recanalization techniques when you encounter a CTO? So there are multiple recanalization techniques. The basic technique would be the back end of the hydrophilic wire. Then you have coaxial systems like TIPS and the other systems. Then go back re-entry catheter, fairly difficult to access. Then back end of the stiff wires and radio frequency ablation and laser ablation. These are, I think, very, very advanced techniques not for the beginners and not for interventional interventional nephrologists, I would say. You have to be really prepared to encounter cardiac tamponade, and a CTVS surgeon has to be scrubbed up if you are attempting these procedures. So it's a strict no for all these procedures if you are a basic interventional nephrologist. And I should confess that I had 3 cardiac deaths when I was attempting these procedures. So it's not everyone's cup of tea. So these are the tools of sharp recanalization, broken burrow technique, broken burrow needle, tips needle, and all this. So just a small illustration of sharp recanalization I had already shown. So we have used tips needle here to cross the CTO. And then before you, after you have done plain balloon angioplasty, all of us know that neointimal hyperplasia is very, very common in these lesions. So before we contemplate stenting, because the 1-year outcomes, there was one paper which looked at bare metal stents versus plain balloon angioplasty. The 1-year outcomes were in fact inferior with the bare metal stents. So before you consider stenting, it is always better to consider drug-coated balloons, because there is data to show that they prevent a neointimal hyperplasia. One is a paclitaxel coated balloon, but I don't think it has the size of the central vein requirements. Sirolimus coated balloons are available. They come up to the size of 12 and 14 and 16 also. So you can try sirolimus coated balloons before you decide on stenting. So as I told, stenting only when absolutely required, like if patient is not willing for thrombolysis, or if the lesion recurs on table, and if the lesion recurs within 1 month. So the advocacy has been that if a patient comes back even after 3 months, you still go ahead and do plain balloon angioplasty. Stenting only if it is absolutely required. So this case was on table elastic recoil, so we had to stent. So finally, I would like to say what is the approach to the management of CVO in a nutshell. So we have seen that it's a cascade of events. So I would say that the management of central vein occlusion begins when you diagnose patient with irreversible CKD or an EGFR of less than 20. So from there, your management starts of central vein occlusion. So you have to have various strategies. The most important thing is central vein sparing strategies, then CRBSI preventing strategies, because these are all the culprits, then attention to the flow on the ipsilateral site where you are proposing to create an access. Then the most important thing is careful attention towards the arteriotomy. Very, very important. You just can't do an arteriotomy when you are creating a proximal fistula as per whims and fancies. Very, very advisable that it should be less than 0.5 mm or 0.4 mm, because the flows in the brachial arteries are very, very high. So even a smaller arteriotomy will take care of the flows. So if you are very judicious in arteriotomy with the proximal fistulas, you are looking at central vein occlusion in a near future. So first, what is thoracic central vein sparing strategies? One is fistula first, then early access creation. So I think nephrologists should also be trained to create AV fistulas, because patients are better handled when we see them in the OPD and take them straight away to the AV access creation. Then femoral tunnel catheter as a bridge catheter. Before, there has been a recommendation in the KDOKI 2019 update as well. Then acute PD to see if you can postpone the hemodialysis till the fistula matures. So this was one of our studies. So our median catheter duration with femoral TCC was 3.2 months. The longest catheter we had was 18 months. So all these 40 patients, what we have seen, successfully transitioned into the long-term access. So it's not a bad strategy to consider femoral TCC as a bridge before you create a long-term access. The most important thing, a very, very common thing, we have to revise our strategies of preventing CRBSI, because CRBSI, more episodes of CRBSI is a main culprit for central vein occlusion. So revision of our practices is a need of the hour. So we had alcohol-based and betadine-based, but still our CRBSI remains the same. So there is a newer antiseptic that is available. It has more than 24 hours of residual surface action, and it's a PHMB compound which has been shown in the meta-analysis that it has better CRBSI prevention things. Then I've been searching for more than 7 years since I came back from US for a sterile ultrasound gel. Was not able to find out, but thankfully now we have sterile ultrasound gel that is available to prevent the infections, because Burkholderia infections and cross-contamination outbreaks have been very well proven in the literature because of the ultrasound gel contamination. So it's very, very important that you also focus on having a sterile ultrasound gel during procedures, and all my previous speakers have emphasized on ultrasound guided procedures. So this becomes a very, very important toolkit when you are doing USG guided procedures to have a sterile ultrasound gel. Then, as I said previously, it's time to revisit our ideas and surgical techniques. There is no hard and fast rule that if a patient has a brachiocephalic fistula, I should never create an RC fistula. This young child, this young kid is an example. Patient had left BC fistula, right BC fistula, had cardiac failure. I was requesting my vascular surgeons, CTVS surgeons to create a proximal fistula. None of them volunteered. Finally, I took it on my own and have created a radiocephalic fistula on this patient on the left side. The fistula has been working for 2 years and now he's waiting for the transplant. So we have to revisit our ideas. There is no hard and fast rule. There is no principle in access care. There is an ocean to innovate, and it's always the open-mindedness and open-mindedness towards your colleagues. That's very, very important. Even we have an experience of 20 years, but still a new kid in the block will have something to teach us. So that's what. Having an open mind, keeping our egos aside, I think we can deliver best access care. Thank you for your attention.
Next speaker, Dr. Srinidhi Nathani, consultant molecular hematologist and oncologist. She'll be talking about genetic markers and their role in the preventing AV vascular access outcome.
So let me set stage for this one, because I thought of putting few different things in the conference to make it interesting. And also, we are not going to talk about money always. What if we have all the money in the world and everything available to us? What can be the future? And the only one thing why I actually asked her, can we do it? Because I was talking to one of my friends in Johns Hopkins, and I was telling him that we all are, we are bugged about this recurrent stenosis and intimal hyperplasia, and we don't know how to treat it. And he said, he listened to me and he said, oh man, can we make vaccine against it? I was like, what? Then actually when I went, there has been work going on to make a vaccine against intimal hyperplasia. So here is she about, the totally different view. Can we look into some genetics, please?
So a very good afternoon, and I think I'm a completely different piece from the entire jigsaw puzzle which is here, and it's a complete new audience, but thank you Dr. Himanshu for this opportunity. And I won't get too technical because I am definitely from the technical side of genomics and genetics, but I won't get too technical. I will give an overview of what can be done and why is it important, because I know it's not guidelines till now. And just a disclaimer, I'm usually called to conferences for the entertainment quotient, so just feel free to, laugh. So this is where I work, where we both work, Dr. Himanshu and I, and so the demands of the patients and clinicians, as Dr. Himanshu also said, think big, think completely out of the box, and for thinking and implementing, the deadline was always yesterday. So when I got this invite, my reactions was like, wow, aisa bhi kuch hota hai. I was like, this is completely out of syllabus, because I come from Tata Memorial Hospital, Mumbai, when I joined Fortis, and it is completely oncology. I was like, wow, okay, then I need to study. So what you already know is that the AV access, the fistulas which you create, the plumbing which you do, the care of the created plumbing, the team which you have is a surgeon, an interventional radiologist, a nephrologist, nurse practitioners, vascular access care team. But so where do I fit in this jigsaw puzzle was my question. And when I started reading, I thought that the patient expects that the AV access has to be smooth, the maturation has to be smooth, the dialysis has to be smooth, everything has to be perfect. So, everybody who gives the patient an answer like this, they think, where were you? Where have you been? And probably the road is supposed to be very straight, but then the real world scenario is that the failure 3 months after creation is up to 40%. And the answer to this is very, very crooked. It's like Mumbai local trains. And so you have to do ishq with me. And I would say ishq nahi aasan, but you know, aag ka darya hai. So you have to talk to me. I am the genetics expert. That why did your AV fistula probably fail? So this was a very nice review article showing that what are the challenges and what are the causes why an AV fistula can fail. And all of us know inflammatory stimuli, oxidative stress, hypoxia, hemodynamic stressors, uremic milieu, and everything which can cause, you know, all sorts of thrombosis and everything. But then, have we ever wondered that why do these occur and where is this all stemming from? It is coming from the genes, it is coming from the environmental and the microenvironmental milieu and the different RNA expression of the different types of inflammatory cells which are there. So let me get down to the inflammation bit. So we all know that CD4 cells are the main culprits over here, and we have T helper 1 cells, T helper 2 cells, and Treg cells, which cause the macrophages to accumulate by secreting cytokines like interferons and everything. But from where do these come? So M2 is supposed to be anti-inflammatory, and they secrete IL-10 and TGF-beta, which promote wound healing. But what if you had too much of TGF-beta? So TGF stands for transforming growth factor beta, which causes a lot of fibrosis, which is going to cause neointimal hyperplasia, and you don't want that too much to happen. So all this ultimately boils down to the AKT-mTOR pathway. That is the genes which is involved, and that is where I come into play. And if the AKT-mTOR pathway is altered, all this inflammation cascade is going to get altered and your fistula is going to fail. So what is the clinical implication? If you see, there is an mTOR inhibitor called rapamycin, which may promote venous modeling while reducing accumulation of both the M1 and M2 macrophages. So if you look at the left panel, if the M1, M2 macrophages are reduced, if the accumulation is reduced, the fibrosis is going to reduce. Intraoperative implantation of collagen membranes eluting the rapamycin have also shown to improve the maturation rate to 87%. And they have also shown in a clinical trial where they took 30 patients where they showed that they did not cause too much of systemic immunosuppression or any significant side effects, although it is still yet to come into clinical practice. And again, the ACCESS study also showed that there was a safety of collagen and implants eluting rapamycin, which was completed in 2021. So what I tried to do was that just to tell you the pathogenesis behind it and what is the clinical evidence right now available and why should you test it. So obviously you cannot go and test for M1 and M2 macrophages. What you can do is check for AKT-mTOR pathway. If that is altered, you may have a hint that the maturation is going to get delayed, and as well as it might lead to a primary failure. When we go to hypoxia, we have post-translational modification of hypoxia-inducible factor. We all know about it, that there is going to be hydroxylation, and when you do a local delivery of HIF inhibitors such as SIHIF1/2A or everolimus or topoisomerase, it will inhibit neointimal hyperplasia. So again, this slide, the left panel is what is induced and the right panel tells you the clinical implication of it. And if you take VEGF-A, a single nucleotide polymorphism, so what that means is that one particular ATGC in the genome changes to what it should not be, and it might be present in more than 1% of normal population. That is why it is called a polymorphism. Ideally, it should be benign, but then in patients who have to undergo an AV access, and if this polymorphism is present, it is going to increase the risk of thrombosis in patients undergoing hemodialysis. So there also probably an anti-VEGF-A like BEV can be locally delivered, and that is the trial which was done. The other one is the heme oxygenase 1A, which degrades free radicals. So something which degrades free radicals, something which removes something bad. Free radicals are supposed to be bad, so we want it to be upregulated. So how do you upregulate it? You deliver it locally using a viral vector or a bacteriophage vector. And mouse models, they have shown a lot of efficiency. But the next in technology is CRISPR, which is being used in hematology, in oncology. So maybe that can help in editing the genome and help in delivering such kind of enzymes locally into the AV fistulas. We also have two very important molecular pathways. One is the TGF-beta signaling pathway, which I told you causes a lot of fibrosis, proliferation and survival. So who is the culprit here? So now we can't go and test for TGF-beta. We can go and test for the genes which induce TGF-beta one step ahead. That is the LMO7 and the microRNA 133. Now you're going to ask me, I know DNA, I know RNA, what is microRNA? MicroRNA is something which is not going to code for proteins, and we can test it. Now we are equipped, our lab is equipped to test for even the non-coding part of the genome, and we can tell you if microRNA is there or not, and that can help in regulating a lot of collagens and growth factors. So right now I'm sure your reaction is that why are you still talking, just get out of the podium. But then unfortunately you have to listen to me because I have been called to talk about genes. The other pathway is the ephrin pathway. You will be very surprised to know that ephrin is something which is very exciting. It is something like, when you make an AV fistula, and the maturation is a process where the vein adopts some of the molecular features of the artery. So when there was no fistula, the vein had A particular signature and the artery had a B particular signature. But when the fistula is created, it adopts some of the B features, and that can be tested genomically from the local site on the tissue or through a cell-free DNA from the blood. So whatever is circulating in the blood, we can check that as well, or you can give me a piece of some tissue from the local site and we can test for the ephrin expression there also. So ephrin B4 is exclusive for veins and B2 is exclusive for arteries. But when the maturation happens, it flips. So this is very, very important because they are going to trigger a lot of downstream pathways like AKT and ERK1 and cause a lot of neointimal hyperplasia, which will probably be very clinically important for you because it may not lead to good maturation and it can lead to failures. So if you know the expression of ephrin B2 and B4 before you create the fistula, you will probably know the risk of neointimal hyperplasia and then do something to prevent it. So what are the future perspectives and what can you get from me is that there is no documented association right now in routine clinical evaluation. There are no guidelines. There is nothing which mandates you to do any kind of testing. But what I can tell you is that any sample can be tested for all these inflammatory markers, all the hypoxia markers, all the genetic predispositions, all the collagenopathies, all the thrombotic diseases as well, and any material from the blood starting from the cells to the DNA, to the RNA, to the chromosomes, even the cell-free circulating DNA, even the platelets for that matter, we can culture them and take DNA out of that and then do any kind of omics, we call it. So genomics means we do it on DNA, transcriptomics means we do it on RNA, proteomics means we do it on proteins, and metabolomics means we do it on the metabolites, that is the breakdown products of proteins. The technology, we have it all under one roof. Normally, all state-of-the-art labs have all of them under one roof. So right now, the status of all reports and all labs which offer such kind of reports in India is like a fruit and vegetable market. Everybody's just doing what they want, not only. So in the vascular space, I think it is totally new. Nobody's venturing into it. But I would say even in the space where there are guidelines, the status is still like this. There is no consensus right now for molecular reporting. And everybody says, I am the best, I am the best. But so I think when we do something first time, the first mover advantage is that definitely she's doing it for the first time. So definitely I will be the best in the vascular space. And my choice of test would be to do a whole exome or a transcriptome. Why? Because it will tell you all the polymorphisms, mutations, as well as the microRNA. Or you can do some targeted panel, choose a set of genes which you want me to test. I will create a panel for you, taking into consideration inflammatory markers, hypoxia, TGF, and ephrin. Or you can do a bulk RNA sequencing, that is take the entire blood and take all the RNA out and do sequencing. Or you can do microarray and proteomics, but those are very high-end techniques and it's going to be a very, very costly affair. Typically, whole exome transcriptome combination would cost the patient close to 20,000 rupees with a turnaround time of 20 to 30 days. But I think that investment is good if you have to, be sure that something is going to work. So this is my choice. First is you have to test to know the utility. I think we don't have any India-specific data, and then only can we develop indigenous tests. So my urge would be that you should test to create our own data, probably multi-centric, and then only we'll know that do we actually need it, or whether are we genetically predisposed in a certain way, which the Western population is not. And because there is a lot of ethnic differences when it comes to genetic predisposition. What is pathogenic in the West is benign in India, and vice versa. My take home is that it is an unmet need, and success depends on the rule of right. So just like you have to choose the right patient, right vein, right time, and right technique, like that you have to also know that the patient is right genetically also. You have to test to know whether actually you need it or not, generate data, and very futuristic, just like in lung cancer and in hematology, we are using AI to predict if there is a genetic mutation or not. Probably there will be a time when we will be able to use AI and predict in this also that whether there will be a neointimal hyperplasia or not. So it has to be a possibilitarian approach rather than a guideline-based implementation approach. And finally, sooner or later you will definitely need me, just like Trump. So thank you.
Thank you, Dr. Srinidhi, for your talk. So our next topic is from Dr. Shabad Shamad on anastomotic stenosis of the RCF and interventional nephrologist experience. Sir is an associate professor from the Department of General Medicine and Nephrology from Swami Raman Himalayan University in Dehradun.
Good afternoon, everyone. Thank you, the chairperson. And fortunately, I have been promoted to professor. Now I'm no more an associate, so please do not demote me. I'm thankful to the organizers, and I express my gratitude to Himanshu sir, Dr. Ashutosh, and P.K. Rai sir for inviting me to this August lecture. And this is really an honor to be amongst the colleague and learned professionals. So my condition is something like the last batsman of the inning, that too before the lunch. And unlike New Zealand, recently concluded New Zealand series, where the batsman couldn't perform and the tailenders had to perform, my previous colleagues have done their job very well, and they've covered the topic excellently, especially Suvra sir, then Dr. Apurva. They have all talked about the juxtaanasmotic segment stenosis. So I'll try to add some value to the topic given to me. RCEVF is the most distal fistula, and this is the probably gold standard of the fistula because of its low flow, very low complication rate. Recently, one of my patients, who happened to be wife of my nursing staff, who had been under my care for last 8 years for focal segmental glomerulosclerosis, landed into ESRD. And she had a very peculiar request that I don't want to have very swollen things in my forearm. I need something good one, cosmetically better one. So I had to tell, okay, fine, I can attempt to construct fistula for you, but the failure rate is really high. It can be even up to 50%. In some series, it may even extend up to 2/3 of the fistula. So fortunately, I was able to construct snub box fistula for her, but the problem is these fistula have very high rate of failure. The same thing, that is low flow, which is very attractive and which prevents many of the complications, as Girish said, that the proximal fistula, that is brachiocephalic fistula, which is high flow fistula, they have got much lesser rate of primary failure compared to the radiocephalic fistula. Radiocephalic fistula, they have much higher rate of primary failure. The reason could be the size of the vessels involved. At the wrist, the size of the radial artery and cephalic vein is much smaller compared to brachial artery and cephalic vein at the level of elbow. The same thing, it might also work against its maturation purpose, because we have seen that the brachiocephalic fistula, even if it has got some stenosis, but the volume is still good enough for the dialysis to be continued, being pulled up rather. But in cases of radiocephalic fistula, the dialysis may not be possible and the fistula might not work at all. So in the mature fistula, about half of the fistula will fail after 3 to 7 years. The usual sequence is there is stenosis, there is occlusion, and finally there will be thrombosis of the fistula and the access will be lost. In the mature fistula, about 50 to 60%, they might develop juxtaanasmotic segment stenosis. So the peculiarity about juxtaanasmotic segment is, in various series, it has been defined as 3 to 5 centimeter from the anastomosis, somewhere 4 and somewhere 5 centimeter. This is the venous segment which is mobilized during the surgery. So it is skeletonized. Also, it bears the direct brunt of the high pressure from the arterial system. This disparity between the artery and the vein, and this turbulence of flow. This is the commonest site of stenosis. This disparity, it also adds to the problem while treating, because the disparity between artery and vein, so you can't pass the same balloon which is used for the venous part, and it can't come into the arterial segment, because there will be disparity and there is a possibility that there might be rupture of the arterial system. As Dr. Shiro sir was telling, that whenever you are treating juxtaanasmotic segment, you are supposed to treat the anastomosis also. This creates a lot of problem. Of late, there has been balloon from the Chinese company which has got tapered end, so it can go into the arterial system without damaging them. So coming to the pathophysiology, which is particular to the juxtaanasmotic segment, unlike the intercannulation zone or outflow veins, there is loss of vasa vasorum during the operation procedure. Also, because of the curve which is created, there is fluctuation and sharing stress over there. There might be kinking of the veins during venous maturation, and also there may be torsion of the vein. So all these things leads to downstream activation of the muscle. So there is cells migration. There is migration of cells from the media adventitia into the intima, which there will be proliferating over there, and also there will be secretion of the extracellular material, which leads to stenosis of the juxtaanasmotic segment. Coming to the presentation that I'm going to do is, I had performed the clinical audit the last 2 years, so all these are from there only. So most of the new fistula, they will be presenting with failure of maturation with radiocephalic fistula. They have juxtaanasmotic segment. That's the most common cause. And in fact, I assessed about 75% of the patients who had failed radiocephalic fistula. This was the main cause for their failure. In the old fistula, the reasons that there may be presentation like decreased arterial flow, and there will be difficulty in cannulation. Sometimes the technician, they'll devise new means to overcome this problem, so they'll put the needle in the same direction. That will increase the recirculation rate. Even sometimes what do? That they'll put a belt over the fistula so that they can get a good arterial flow. So that is something devised, and these are clear-cut indications that possibly this patient is having inflow problem. Just I forgot to mention that when we talk about inflow, this is basically taken as proximal artery and distal artery anatomically. But when we talk of physiological inflow, this includes both the arterial inflow plus the juxtaanasmotic segment. So they present clinically the same way. So this is not a functional inflow, of which juxtaanasmotic segment is the important part. On clinical examination, there will be poor augmentation of the pulse, and there might be sudden disappearance of thrill just beyond the anastomosis. This is very much telling evidence that there is a problem with the inflow. As regards to diagnosis, most of the time the diagnosis is made clinically on clinical examination only. Rarely do we need ultrasonography to confirm it. And as regards to digital subtraction angiography, this is confirmatory, but rarely do we need it. And whenever we have to do it, we have to keep in mind that we are going to intervene in this fistula. Otherwise, never we require digital subtraction angiography. While in some cases where the insurance companies, the financing agencies, they want that they should get the angiogram report before getting the sanction for the procedure, then only do we do the distal subtraction angiography. Otherwise, we straightway take the patient. So this is the distal subtraction angiogram, which is showing stenosis in the juxtaanasmotic segment, also at the A cannulation zone. So regarding doing angiography, one thing has to be taken care that whenever you are putting a needle over there or you have accessed the vein, you should get a retrograde reflux angiogram before you push the wire up into the arterial system, because as previous lecturers have told that there might be concomitant stenosis of the anastomosis also. So once you have passed the catheter, as you can see in this diagram, you can hardly assess the juxtaanasmotic part. So it's better that you perform reflux angiogram before you put the wire upstream. However, there may be problem when there is some collateral arising just near the juxtaanasmotic segment, then there may not be opacification of the juxtaanasmotic part. That's a problematic. Here the guiding catheter that I had used was 5 French only, and it has practically occluded the inflow. So the treatment options are endovascular and surgical. Endovascular may be plain old balloon angioplasty. Other speakers have told about this drug-coated balloon, and there may be cutting balloon also used. Some series have shown stenting also. The advantage of endovascular procedures are that it spares the proximal segments of the vein for future. So if you have done the endovascular procedure, your proximal is still spared, so you can construct the fistula proximally when required. And it has got similar secondary patency rate. As regards to surgical procedure, what do is we construct the fistula proximally, and sometimes interposition graft might have to be used. Possibly this is cheaper, and as earlier speaker said that about 10 fistula can be constructed instead of doing 1 angioplasty. It has got better primary patency rate, and however, it shortens the usable segment of the vein. So the decision has to be made whether to do angioplasty, taking consideration the remaining length of the vein plus the cost, repetitive cost of the angioplasty. A few points regarding endovascular management. So most of the times, if the fistula is mature, I'll be going through the venous approach. So it's a retrograde venous approach because the arteries are really unforgiving. So if you give the arterial puncture, then there's a possibility of arterial occlusion in the future. But the advantage of doing arterial puncture, that is retrograde transradial approach, is that you can take a distal one, and also the angle is much larger. This is an obtuse angle, so you can push your wire very easily into the venous system, unlike coming to the retrograde system. So where it takes almost about 360 tons, and it might be difficult to do that maneuver. The puncture can be at the distal interdistal space. The dorsal radial artery is much straighter over here, or you can do at the snub box, or if there is space, you can do at the wrist. Balloons usually, if arterial inflow is also involved, I'll be using something like 4 mm balloon. Rarely do I go beyond 4 mm. Sometimes, if the artery has been somewhat proximally, then maybe 5 mm balloon. As regards to juxtaanasmotic segment, usually 5 to 6 mm balloon is good enough. As I said earlier also, there is difficulty in sizing the balloon, considering the fact that if you leave some part, then just a proximal vein to the anastomosis, that will remain untreated, again causing problems. So this is something really challenging to manage. Whenever we are going into the arterial system, we restrict the pressure not more than 14 atmospheric pressure, and usually I'll give the anticoagulation because there may be possibility of thrombosis of the fistula. In fact, earlier I had lost few of the fistula during ballooning also. Also, as I was taught to do ballooning for 2 minutes, instead of doing 2 minutes, here I'll do a short inflation time so that the possibility of thrombosis goes away. This is the 2D image. You can see on the left hand there is stenosis of the juxtaanasmotic segment. The right side is after angioplasty, the same angiogram that I had shown you earlier. And after doing balloon angioplasty through the retrograde approach, you can see the juxtaanasmotic segment has been treated very well. It was 6 mm balloon that I had used for the juxtaanasmotic part. Complication are, there may be extravasation. That's very usual when you're treating the tight stenosis. And rarely do we come across these complications now of AVF thrombosis altogether. There may be, especially when you are coming to the retrograde approach and you are cannulating immature vein, there may be hematoma at the vascular access site. And yes, there is a possibility of radial artery occlusion. We do not have a long series, but that is a known fact that radial artery may be occluded. Recurrence of stenosis, that's a rule rather than an exception, and the patient will have recurrence. Primary patency at my place at 6 months was 20%, and secondary patency was, primary patency at 12 months was 41%. However, what I observed was immature fistula, they had low rate of recurrence. So now the next question is anything which can increase the patency rate after POBA is yes, there are possibility of using drug-coated balloon, which has shown to increase the primary patency rate at about 12 months. Stenting has also been done, especially that Supera balloon has been used at these places, but these have been case series only. The biggest problem, the biggest challenge that we face is about the cost aspect. Our patients have meager finances, so doing all these expensive things may not be suitable. Surgical treatment, this is usually a second choice, and as I said previously, neo-anastomosis can be done. Really, when we explain if the patient have to pay from the own pocket, they prefer a new fistula to be constructed rather than preferring repeated angioplasties, and that's also justifiable because they have longer patency when new fistula is constructed. Well, it's important to note that undergoing angioplasty is not the last angioplasty. That's really a beginning of the angioplasties to follow on. Because once you are doing angioplasty, there will be damage to the endothelium. Subsequently, there will be neointimal hyperplasia, and again, vigorous stenosis will be happening over there. So we have to focus on primary prevention. Basically, this is a surgical conduit, and this is an artificial one. So there's a point that we should have a good surgical skill, minimal trauma to the vasa vasorum, minimal handling of the vein, and we should try to avoid clamping the veins during the surgery. So no amount of these preventive measures cannot be enough. So basically, just to explain this, that on the arterial side, we have 12 point is the anterior most, and the venous also the same. So the first anastomosis type was when we do side-to-end anastomosis, the anastomosis done between A to X line. When we are doing side to straight line onlay technique, we are doing A, then taking Y. And piggyback slot technique is we are doing just anterior posteriorly. So this has shown that lesser rate of juxta-anastomotic segment stenosis will be happening. So my practice for anastomosis has been, first I was taught to do side-to-side anastomosis, then moved to side-to-end, and ultimately I have moved to piggyback slot technique now. Regarding piggyback slot technique, it is taking care of torsion in the Z-axis. Regarding this angle, this is also important. Various studies have shown if the angle is kept to less than 30 degrees, it will reduce the chance of juxta-anastomotic segment. So as you can see from here, if the stenosis is done, if the anastomosis is this way, and if we can increase this length before we do the anastomosis, so if we can do the transposition sort of thing, then maybe this angle will be reduced, and that should reduce the rate of juxta-anastomotic stenosis. I had been doing a pilot study for last 10 patients, and I have found really encouraging result that not only doing piggyback slot technique, rather I am doing transposition and moving proximally up and then doing tunneling of the cephalic vein and anastomosing to the artery. So the possibility of torsion and juxta-anastomotic segment stenosis decreases. This is justified when you see the snub box fistula. They have very little juxta-anastomotic segment stenosis because it's just up and down and very straight segment. So take home message is there should be proper surgical training, and it should not be left to the, I beg a pardon, to the junior most surgeon to do the surgery. Monitoring of the AVF at 2 to 4 weeks of time, and if required, you have to do the treatment. Timely intervention can be surgical or endovascular. Always you have to take consideration about the financial status of the patient, if they have to pay from their own pocket or no. If they don't have to pay from their own pocket, if they have insurance, something like in Uttarakhand, it's 100% coverage, you can afford to do repeated angioplasty even 3 to 4 times in a year, that's good enough. But if the patient has to pay from the own pocket, my patients usually prefer going for a surgical treatment if they don't have. Thank you so much.
Thank you, Dr. Shahbaz. Very nice presentation. So with that, we'll be moving to lunch, but before that we'll have some questions. So if anybody wants to have some questions, you can ask. And we can also have all the speakers.
Facilitation करो बाकी lunch में.
as you have, you are talking about these angulations of when you are making the anastomosis. So there was one concept like the piggy bag on this, that will automatically will reduce your angle, and that will be the better outcome, and just anastomotic stenosis would be less. So your comment on that, yeah.
Yes, actually, there's paucity of time, so I couldn't go into detail. One study was by Dr. Shenoy, where they have shown that PG back technique, that is, you are doing, this suppose this is the artery, this is the vein, so you're doing anterior-posteriorly. So the anterior-most portion of the artery and posterior-most portion of the vein. So you're doing venotomy and anterotomy like that, and you're doing anastomosis this was done by by Dr. Shenoy's group. Second was from Turkey also. They have shown that yes, it has good preventive aspect with regards to the anastomotic segment stenosis. So my further point was, so even if you're doing this way, so you're taking the Z axis, XY axis is still left there. So if you can bring it just straight post, then maybe that will prevent the anastomotic segment. The example is that of snub box. In the snub box, the artery and vein, they're almost aligned parallel to each other. So just simply moving down the vein and anastomosing with the artery. So in my series, I've just done the pilot study sort of thing. So it's a very little chances of any anastomotic stenosis.
We'll add on to the same thing actually. So if we mobilize the vein adequately,
yes,
no matter what the anastomosis we do, it's the same thing. So there should be no angulation basically. So one way I think Dr. Himanshu describes in the video that compress the fistula. If there is a pulse proximal and thrill distal, that means there is something. So the thrill should be uniform throughout the fistula. That is one thing that we can see even after a Doppler, and that prevents a lot of anastomotic stenosis. Any fistula which has any amount of pulse near the anastomosis, definitely he is going to come back with a good amount of juxtaposition.
That's an excellent insight into that one.
I think we probably didn't notice during the talk about endovascular fistula. So as a vascular surgeons, when we started doing, so a traditional used to be the side-to-side anastomosis, right? And then when we came in, a lot of, okay, we'll do end-to-end so that it'll mature well. But you see what is happening with future, when it's coming with endovascular fistula, it's going to be side-to-side anastomosis again. So the most important is the tissue handling. And then second is going to be your anatomy of the angle. Okay. So what question came, I think there was a thing about using supera. Okay. So putting it across the anastomosis. But sometimes when you have a forearm, how far you are, so cephalic when it comes in, and somewhere this 2/3 and 1/3, artery and veins are actually closer. Then vein goes away. Lot of us, we actually make it, when it make it here, we make it really big swing. Some patients are lucky, the vein stays closer, some it goes away. And then it again, as you said, again comes near to the radial artery, the snuff box.
Yes, sir.
So it's all about selecting your artery and vein as near as possible, and then making all the possible adjustment. One of the adjustment is if you have an artery and vein, and there's a paper about it, that they used to touch vein at the last. We have all learned from the vast experience of CABG that radial artery you can actually harvest with bit of cautery and mobilize it really well. And because once you clear all the adhesions, radial artery literally pops out. You get almost extra centimeter by clearing those adhesions. You can move that 1 extra centimeter to mobilize the artery, to slightly less mobilize the vein. So actually the anastomosis, the actual good U which you get by putting a supera across it, you can actually have a good nice anastomosis in a mobilized vein, and what we call is a boot shaped anastomosis. So there are different techniques to achieve that configuration. Either you achieve it by doing a right boot shaped anastomosis, or by piggyback technique, or just by doing side to side and ligating distally. So it's all about having a good hemodynamic.
Yes, sir, you have summed up everything nicely. Basically, this has to be surgical technique, which has to be improvised.
One more.
Mechanism, if you are able to reduce the angle, angulation from 45 degree at least to 30 degree, or as much as you can.
It's actually an art. It's actually,
this is actually the art.
You have to get the blood as streamlined as possible.
I have one question for Dr. Srinidhi. Just I wanted to know about inflammation, anti-inflammation, hypoxia, everything happens well. There are drugs to reduce inflammation. So what do you think, what would be the futuristic approach that whether the vaccine agents, all these are going toward? as Dr. Himanshu was talking about? Or is there any anti-inflammatory? You are talking about the sirolimus. Whether this systemic sirolimus is going to work for this patient, whether any patient on the dialysis is likely to tolerate that kind of the medicine orally or systematically. But the only thing, it is possible that some drug-eluting stent can work a little better. So what is your opinion about this vaccination? There's so much of the things playing all around during this just anastomotic stenosis.
So I think it is very multifactorial. It is not like you can target one molecule and give everolimus or sirolimus, especially to a patient undergoing dialysis. So I think you have to take the entire patient as a whole, look at the entire genomic profile as well as the local milieu, I would say the microenvironment. And I think in this particular case, more than systemic, I think local delivery is the key for any personalized, tailored approach rather than a systemic approach.
So I think in genetic, maybe next time we'll cover a bit more about it, peri-adventitial delivery of the drugs and some special wraps. So there are a lot into it. The first thing comes, are we going to look into it? And then your perspective. Maybe when you're talking, thought came to mind, that maybe not all patients, but we can have maybe few patients who have a fistula, same fistula running for 10 years. And then maybe we can have patients who have like 5 failed fistulas, really. So the extreme is easy and extreme is difficult patient, and you can actually have a look like the entire genome, whatever way, and then we can see, Indian patients what kind of findings they have.
Right. We need to first look at a case control kind of thing.
Look at what's the problem. So we have a very, very important announcement to make before.
We will be starting in next 2 minutes time. Would request everyone to be seated. Doctor.
मुझे एक सेशन वाला दो.
Welcome to the post-lunch session. We have, with some modifications because of timing, the first talk which we are going to have is a Zoom call. We have heard from US, we have heard from Germany. We'll be hearing later today from Australia, but this is from a place, Japan, where when I had first interaction, that interaction was, I saw they were doing brachial artery superficial transposition. I said, why? He said, oh, well, we have patients who have exhausted, options. We don't have veins remaining. I said, well, that's quite same because when you used to study in general surgery, we used to be amazed from outcomes of CA stomach. Their stages changed from US to Japan. So I was kind of happily surprised that, okay, we might be doing almost same kind of surgeries because we don't have same problem, that we do not have veins remaining. But then the next thing changed everything. He said, yeah, our majority of the patients have been on dialysis for 20 to 30 years. I said, wow, because we'll end up exhausting these veins sometime in as less, than 3 to 6 months. So I did not get time to talk about this. The theme for this year's is getting access to work beyond 10 years, because we have been in Veincon itself for last 7 years, and now we have patients whom we can say proudly that there are patients who are living beyond 10 years. So then, when the next generation of patient comes, those patients prospectively also we have to do something so that we are able to keep their accesses working for 10 years, 15 years and 20 years. And same time keep interventions to as less as possible. Because as pointed in some of the talks, okay, you can keep on fistula running, but it's not a zip. You cannot just zip, unzip, zip, unzip. It comes at a cost. And most importantly, it comes at a emotional cost. You know, imagine a person, you say, okay, we'll do angioplasty, or you say, okay, this is not working, we'll do another fistula. What about the mindset of that person? You know, fail is a very, very depressing word. So if you add that tags and multiply by it like 4 times, so we had somebody had a 4 failed fistula, just imagine how much depression that patient has to go through. So collectively, as access surgeons, what we call, our responsibility is also to create an environment where we are able to provide a comfortable environment to our patients, where they can look for having a life beyond first decade. Once we reach there, and I think there we are already reaching, once we reach there, then we can actually talk about a great life expectancy being on hemodialysis. So I would request, you know, some of those all who have actually finished the lunch, if you can come back to the main hall. We're going to start the next session, and for that I would like to call upon, for the chairpersons, Dr. Shubhabrata Banerjee. He is a consultant vascular surgeon from Manipal Hospital, Kolkata. Dr. Prem Shankar Patel is a consultant nephrologist and transplant physician at Patna. Dr. Vijay Pratap Singh is a consultant nephrologist, Bharat Gange Clinic, Gorakhpur. Dr. M.L. Patel, Professor Internal Medicine and Nephrology, KGMU, Lucknow. And Dr. Mufazzal Ahmad, Senior Consultant Nephrologist, Lucknow Kidney Care. Do we have a Zoom session connected? Dr. Masaki, can we... Very good afternoon, Dr. Masaki. A very warm welcome from India. And it's great to see you after a few years.
Okay.
So, Dr. Masaki.
Thank you very much for your kind introduction. My name is Masaki Murakami. I'm from Shizuoka, Japan. I will talk about managing AV access beyond the first decade of dialysis. In Japan, the rate of kidney transplantation is very low. 97% of Japanese ESKD patients selected hemodialysis, while only 3% of ESKD patients selected peritoneal dialysis. According to Robinson, the mortality rate of dialysis patients in Japan is low compared with the United States and European countries. In another country, kidney transplantation and peritoneal dialysis are major KRT modalities. On the contrary, most Japanese ESKD patients selected hemodialysis. Furthermore, the mortality rate of Japanese ESKD patient is very low. Therefore, most Japanese ESKD patients have been undergoing HD for a long time, sometimes over 30 years. managing vascular access beyond 3 decades of dialysis is necessary. This slide shows the choice of dialysis access in Japan. AVF is selected as the first option. AVG should be constructed as the second option. In general, central venous catheter is the third option. However, the patency of CVC is low. To continue hemodialysis treatment for a long time, another option is necessary in Japan. Brachial artery transposition is selected as a tertiary option in patient in whom a standard AV access cannot be created. The Japanese Society for Dialysis Therapy investigated the types of vascular access. 90% of HD patients have an AVF. 1.8% of hemodialysis patients undergo HD with brachial artery transposition. Therefore, more than 3,000 patients undergo dialysis with BAT. BAT is selected as a tertiary option in patients in whom a standard AV access cannot be created. The indication for BAT were as follows: an inadequate vessel for AV access creation, severe heart failure, hand ischemia, and central venous occlusion. I will give a case presentation with central venous occlusion. According to Kundu, treatment options for central venous disease include PTA, bare metal stent, and surgical bypass. Unfortunately, all the available treatment options have poor long-term patency requiring repeated interventions. In the ESBS guideline, the several surgical techniques using prosthetic graft for the patient with central venous occlusion are described as a tertiary vascular access. However, the risk of these surgeries were relatively high. According to this guideline, individuals should not undergo these surgeries without serious consideration. There is no ideal treatment for central venous occlusion. This patient was 70-year-old male. AV access location was left brachiocephalic AVF. Clinical abnormality was severe edema with chronic skin inflammation. He had been undergoing HD for 20 years. PTA is a primary option for central venous stenosis. PTA was performed for central venous stenosis in 2013. PTA was successful. However, the patency was relatively low. PTA had been performed in total 17 times to maintain central vein. Finally, central vein was occluded. PTA was failed. After that, ulcer because of venous hypertension developed. Therefore, additional procedure was needed. Before operation, we evaluated the vessel using ultrasound. The diameter of the brachial artery was more than 4 mm, which is adequate for cannulation. We can detect non-thrombosed vein. The diameter of non-thrombosed vein was more than 4 mm. The vein is available for returning route. Detection of the returning route is the key to successful BAT creation. Before brachial artery was transposed, AVF was ligated in November 2022. After 1 week, arm swelling and skin inflammation diminished. Then we created brachial artery transposition. The surgical technique is relatively simple. About 15 centimeter skin incision was made at the medial side of the brachial artery. A long incision and exposure were needed for repeated cannulation of the brachial artery. The brachial artery was exposed. Care was taken to avoid the damage to the median nerve, which lies near the brachial artery. Side branches of the brachial artery were ligated carefully using 407. The diameter of the brachial artery is more than 4 mm, which is adequate for cannulation. We created skin flap. The thickness of the skin flap is important. If the skin flap is too thick, cannulation of artery is difficult. If the skin flap is too thin, risk of skin necrosis is high. The subcutaneous tissue under the brachial artery was sutured. A skin flap was covered over the transposed brachial artery. Finally, we sutured skin. You can see transposed brachial artery here. After 3 weeks, transposed brachial artery could be cannulated. The patient was followed up after surgery every 6 months. BAT has been used without any intervention. Although brachial artery transposition has been used for several decades, there have been few studies. Therefore, we conducted a multi-center study to evaluate this technique. From January 2012 to December 2013, 5,000 vascular access related surgeries were performed at 10 participating hospitals. During this period, 233 consecutive patients who underwent brachial artery transposition were included in this multi-center retrospective study. The indication for brachial artery were as follows: an inadequate vessel for AV access condition, severe heart failure, hand ischemia, and central venous occlusion. Here the result. Successful rate was 98%. Because the surgical technique is simple, the first successful cannulation was achieved at a median of 18 days. The primary patency of the transposed brachial artery was 93% and 88% at 1 and 3 years, respectively. The primary patency of the transposed brachial artery itself was high. The primary patency of access circuit was 64%, and the secondary patency of access circuit was 74% at 1 year. The patency of access circuit was not so high. The main reason for the failure of access circuit was dysfunction of a return route. During the follow-up period, 13 impaired wound feeling, 6 large aneurysms, 5 brachial artery thrombosis developed. Complication rate of BAT was relatively low. BAT differs from normal AV access in several aspects. One of the advantages of BAT is no maturation time. The diameter of the brachial artery is generally adequate for cannulation. Another advantage of BAT is favorable patency. BAT can be created without any artificial material. The patency is high without intervention. Therefore, BAT is an economical technique. When we create AV access, shear stress may lead to stenosis. In contrast, the brachial artery is simply transposed in this operation. Therefore, arterial blood flow is almost physiological except during the hemodialysis session. Such hemodynamically normal flow should provide better patency for this method. However, BAT has a critical disadvantage. Adequate normal vein are necessary as a returning route. Brachial artery transposition is insufficient for vascular access by itself. Therefore, if the vein used for the return route have been wasted, the transpose artery becomes difficult to use. Artery cannulation is not common for foreign doctors. Firstly, a normal superficial vein was cannulated using tourniquet. Then the transpose artery was cannulated without using tourniquet. She is not a doctor. For medical staff, perform cannulation of transpose brachial artery. The cannulation method for BAT was basically the same as the AV fissure. Cannulation of the artery is comparatively easy. The diameter of the brachial artery is more than 4 mm. In fact, cannulation of the normal vein using 17-gauge needles is sometimes difficult. After removal of the cannula, adequate pressure to the brachial artery was applied to prevent bleeding. The normal vein was compressed for 5 minutes. The brachial artery was compressed tightly for 5 minutes, followed by another press for 10 minutes with moderate pressure. The risk for bleeding is relatively low because a brachial artery was superficialized and easily to be compressed. Furthermore, repeated cannulation and hemostasis make the arterial wall thick and stabilized. According to a national survey, the KTV was similar in 3 groups. Patients with a temporary CVC show the lowest dialysis adequacy. In patients with BAT, the risk of recirculation was low because a different route was used for blood return. The dialysis adequacy in BAT cases is similar to AV access cases. KDOC guideline suggests central venous occlusion is one of the major problems and represents the Achilles heel of vascular access. There is no ideal treatment for central venous occlusion. Generally, angioplasty is the primary option. If a return route cannot be detected, graft bypass or catheter at the opposite site is an alternative option. Although it seems difficult to perform a new procedure in your country, central venous occlusion can be treated by economical surgical procedure using brachial artery transposition. Thank you for your attention.
Thank you, Dr. Masaki. One question. Can you shed some more light about the returning vein? How do you select it? And which all veins, and how do you make sure, because these veins don't have higher blood flow in normal scenarios, how you keep patency about? And do you use even
actually, detection with the return route is the key to successful BAT creation. So, if we cannot detect the returning route, we cannot perform brachial artery transposition. And for example, in the central venous occlusion case, we can detect many collateral veins. So, if we ligated the main AVF, we can detect many collateral veins which can be cannulated. then we will use these collateral large vein.
So if I get it right, these are patients who have central venous obstruction with a swollen arm, and anyways these veins have a good dilated peripheral veins. So once you do ligate the fistula, and
Yes.
you wait for almost a week, once the arm swelling is down, then that same patent vein, you use it as a returning vein, right?
Yes, that's all. That's all.
Yeah, I mean, it's wonderful, and also sometimes solutions can be so simple, because I didn't see any metal, any wire, and and any drug-eluting balloon, which, as you rightly said, that sometimes there is no ideal treatment for central vein occlusion, and it's a dead end, because as you mentioned, one patient 17 times PTA. We ourselves have patients who have got keep on just getting one, and then so many times you are putting foreign bodies and the lines and wires inside. You are exposing them for more and more of infection. Any question from the audience? Any comment? Dr. Neelam?
So wonderful talk. I have a question. One of the indications that you've said of this brachial artery transposition is hand ischemia. So in such cases, how do you deal if an ischemic complication then occurs following the procedure?
After the brachial artery transposition, the risk of hand ischemia is very low. So when we created AVF, hand ischemia sometimes occurs. On the contrary, when we created brachial artery transposition, the risk of hand ischemia is very low, because artificial blood flow is almost physiological, except during the hemodialysis session.
So I noticed one thing. You use plastic needles for the cannulation? In the video?
Yes.
So is it only for the BAT procedure, or across you use plastic needle for the cannulation?
Actually, for the AVF or AVG, in Japan, a plastic needle is used for AVF or AVG. So the needle is the same as for AVF or AVG. Actually, in Taiwan, in another country, they performed BAT. In Taiwan, metallic needle is used for BAT. So, in my opinion, metallic needle is available for brachial artery transposition.
Well, yeah.
Just one question. Arteries are known to undergo spasm. So, do you encounter anything like that when you are, needling it for dialysis on a regular basis? The brachial artery. Any spasm that comes in the way of dialysis?
Actually, the risk of the spasm is very low when we candidate the BOT.
Any contraindication to any artery? Which artery you cannot, apart from size, as which you have already mentioned?
If the diameter of the brachial artery is more than 4 millimeter, is a good indication for BAT. And the diameter is more than 3.5 millimeter is adequate indication.
Heavy calcification, calcified arteries, because sometimes they may be difficult to, I don't know, lift. Calcification in the artery, does it matter?
Actually, we sometimes used calcified brachial artery for this operation. So, in my opinion, calcified brachial artery is not a problem for brachial artery transposition. But if in your country, if you perform brachial artery. In the first case, you can select non-calcified brachial artery. Because we gave a case presentation in this patient, but you can see the calcified brachial artery using ultrasound in these cases.
Well, thank you, Dr. Masaki. If there's no question, I would like to thank you for giving this wonderful talk. We hope that we do learn few things from their talk, and most importantly, looking from the different angle that central venous can be actually treated by not even treating that itself. So thanks a lot, and it was wonderful having you.
Thank you very much.
So now I'd like chairpersons to continue with the session, please.
Next talk on
good afternoon. First of all, I thank the organizer, especially PVR sir and Himanshu and Ashutosh for having me here. So I'm from Trichy, Tamil Nadu. I'm there practicing there for 25 years. I graduated from IKDRC. So my topic is AVF aneurysm, which is quite not, the definition is not very standardized, and even treatment protocol is not standardized. When I gone through the I just hit the YouTube or some sites in the Google, I could not find any comprehensive approach towards AVF aneurysm. Everything there's a case reports, authors, individual authors' opinion. Just based on my practice and some literature available, I formulated this talk. I hope it will be useful. And so AVF aneurysm, it can be simple, any AV fistula is aneurysm only, right? So it's kind of, they say that 3 times the normal size vein, or 18 millimeter more than the diameter, it's called AVF aneurysm. It could be simple host type to hem will come to, a giant venous aneurysm, otherwise known as python, or a serpentine, monstrous, there's people, so many names they're calling it. So these are some of the pictures I got from Dr. Girish Reddy from INU. So just 5-6 slides, you see which variant is causing AVF aneurysm. So I'll just go rapidly because my time is limited. So all this, just have some kind of a memory in your mind and calculate how many BCF AV fistulas causing AVF aneurysm. So most of the case we encounter in our practice are basically from BC brachiocephalic AVF. Very rarely we see from radiocephalic. So this thing. With this, some pictures, I'll go into the talk. Okay, aneurysm divided into true and false. False, we know simplistically it's a hematoma communicating with the lumen. Over the time, it becomes a fibrotic sac without a wall. It could be focal at the point of needling or where interventions are made, or at the anastomotic site. Mostly we see in 30 days, 40 days, AV fistula is infected. The true aneurysm is external abnormal remodeling due to Alport syndrome. In case of Alport syndrome, ADPKD is genetic one. Downstream stenosis may be the injury, but most of the time we don't know the cause, how it happens. Here the whole flow, outflow vein can be or focal. Here the focus. So the causes could be generally injury, remodeling, and downstream stenosis. The most common is areas of BC AVF and RC, then brachiobasilic AVF. So pseudoaneurysm, we call this AVF. Pseudoaneurysm is a common abbreviation we use it. Anastomotic site, and along this. So anastomotic site, the presentation would be non-tender, painful swelling, sometimes progressive, signs of inflammation. Sometimes you will see eroded skin with telltale signs of impending rupture or blowout with bleeding. This is a common presentation. So this is one case, a 22 years old fistula, days fistula, just a swelling spotted by our staff. Then with the ultrasound showing pseudoaneurysm. So this is what the thing. Ultrasound is a handy, and we just it is a basic side-to-side brachiobasilic fistula. So this is one, and intervened preemptively, and both arteries were tied because I think mostly 99% is all infection only. So this is same picture, right? This is another impending rupture, identified before rupture. Another case. So this identification is very important. Pseudoaneurysm. This is a blood and stopped. The another case, lost 1 liter blood during sleep. So he came and we intervened. This case was non-infected, and the aneurysmal mouth was closed, and a fistula was sacrificed at that. So pseudoaneurysm often display yin-yang phenomenon, and this is a common finding, very interesting finding. We can even teach your staff to find out the early things. So pseudoaneurysm along the course, mostly it's a needle injury. So this is what happens right then. So this patient, one patient, we had a pseudoaneurysm along the path. I just closed. In this case, the inadvertently artery was punctured, pseudoaneurysm was made out, and the mouth was closed. Now coming to the true aneurysm, generally it happens with rope ladder technique and abnormal external remodeling. Downstream stenosis, this is what the most important point I want to highlight. See, brachial fistula is very easy, but if you make more than 5 millimeter, 6 millimeter diameter, then most of the brachial fistula, I think Girish was telling in the point, annotating same point just in his lecture, that by 6 months time you will develop either high output cardiac failure or distal downstream stenosis. So make sure that if you are doing or your surgeon is doing, make sure that your 5 millimeter or less than 5 millimeter adequate enough to have a good BCAV fistula. And sometimes high blood pressure, uncontrolled blood pressure, large artery I had already alluded to. So these are the common causes for true aneurysm I can attribute, but the majority of times we don't know the cause. So two classifications been put forth by two investigators, like Bellas et al. And Valente et al. So both of them, whenever you see the literature, they are not widely followed. One is aneurysm is a morphology related, and this is aneurysm with thrombosis stenosis. This is a description. I am not going to detail for the paucity of time. So I made a concoction of both. This is the Bellas and Bayak. Then both said 18 millimeter more than diameter thing. So here, now the practical classification. I just concocted. I thought this can be taken up by some research in our country to make it as a very useful one. It's a combined Valente and Bellas et al. The true aneurysm is without stenosis. Many times we in stage 4 CKD we create a fistula. Then even without using it, you will develop a serpentine-like fistula. This hose pipe-like uniform aneurysm, tortuous serpentine, but there is no stenosis in the distal. Here, only thing is you have to differentiate between high and low outflow. If it is more than 2000 ml outflow, then the likelihood of chance of developing HOF, then you might intervene by flow reduction. So here, AVF with no thrombosis or stenosis. This is what I told that first type 1. So this is simple, most very useful bedside test. Any AVF aneurysm, just do a limb elevation above the head. This will give a 90% idea that what we are dealing with. So this we fail to do most of the time. So it collapses completely. So however the aneurysm is serpentine, monstrous, if it is having good collapsing, then I will not worry about it. It's for just a asymptomatic, just for cosmetic purpose, I will not intervene. So the type 2 aneurysm with the interaneurysmal stenosis, very often we see in recent times with or without thrombosis, and AVF aneurysm with cephalic arch central arch stenosis. So this is what, see you most of the time AVF aneurysm is the treatment of choice is the intervention by surgical. If you go inside, you find that moment you flip up remove the sleeve, the redundant sleeve, proximally you find distally you find a very narrow segment. So what to do then? So these kind of scenarios we are caught between rock. This in a dilemma. So this before that we would understand what is what. But before intervention, generally we'll do venography, we'll identify. But that is a general classification is all about. So sometimes after the stenosis, you get a complete narrowing. Then you have to go for a turn down procedure. So this is with the thrombosis. This is a central vein stenosis with dilatation. Here, see the clinical sign is very important. You have a tense AV fistula, does not collapse in occlusion, does not collapse in elevation, no pulse augmentation, so not some typing error, and prolonged bleeding after decannulation and high venous pressure. If you have aneurysm with these kind of things, you can suspect central vein stenosis, you can investigate. But the problem here is you have to estimate the flow. If you open the central vein stenosis, it's like opening the floodgate. Patient might go for a high output cardiac failure. So you have to weigh the balance. Individual case is managed based on the merits and demerits of particular clinical scenario. So this is a narrowed segment. This is all with clot. This is a typical case. One is collapsing, another is not collapsing with on elevation. So here definitely the next choice, we don't know whether you have to go for the flow reduction, then you remove the stenosis. So that's why the definition is not clear. Even the surgical, the management of AVF aneurysm is not clear. It's all based on individual cases. So this okay. See, another important point, the type 2 aneurysmal with the central vein stenosis. If you do a Doppler, instead of continuous rumbling flow, you will get a typical high-pitched systolic and diastolic difference, and you will get sometimes, biphasic flow instead of monophasic. I mean, just above the baseline, you will get a biphasic flow. This is a clue in ultrasound, that this patient may be having central vein stenosis. But unfortunately, I don't have audio. If I play the audio, you can see the sound. This is what in Doppler helps in our clinical judgment. So type 3 AV fistula aneurysm is a partial thrombus and complete thrombus. Here you have aneurysm. You have just to do ultrasound for routine sake, you will get some thrombus hanging over the wall. But though there is no obstruction, but this needs a sleeve removal along with thrombus. So it needs surgical intervention. Another is a partial thrombus. Another is a complete thrombus. So here you have to abandon the fistula, go for the next choice. Now another type 4. AV fistula aneurysm with focal aneurysm. This happens, this is often we see because of poor needling technique or with secondary infection. The simple thing is you go and resect the aneurysm and make your fistula patent. And another is a complete thrombus. So this is a fourth very practical classification. This I devised over the years of observation based on both Valenti and Ballas classification. So the treatment is AV aneurysm is a benign process. Most of them very stable, asymptomatic. AV pseudoaneurysm and AV fistula aneurysm managed purely on clinical findings and USG with available facilities. How you are trained and what is your team is supposed to have such kind of quality of managing these patients. Venography is indicated where outflow stenosis suspected, when intervention is anticipated, prior to surgical and non-emergency. In an emergency, you have to go and tie the things, right? When you're non-emergency, you can go for venography. And prior to endovascular stenting. Someone was, I think Himanshu was making a point today morning, right? That, instead of CT, you can go for a venograph, dynamic thing you can understand, a roadmap to the access outflow through to the right atrium as well as allows a dynamic assessment. So better to go for a dynamic flow assessment than the static CT angiogram. The three main indications for true aneurysmal intervention is a group 1, group 2, group 3. First is AVF causing some discomfort. People might be having very abnormal, cosmetically disfiguring, then you have to listen to the patient choice, or you anticipate some kind of impending trouble, you can go for it. AVF aneurysm causing bleeding risk. And some third is very important, access flow issues, whether it is high flow or outflow stenosis or low flow. In high flow, you have a heart failure or you have a Steele syndrome. Either way, you have to intervene. In the low flow, maybe feeding artery may be thrombus or juxta-anastomotic. Here also you have to intervene. Otherwise, the distal AV fistula will go for thrombus because of low flow. The outflow, you have the central vein stenosis along with the intra-aneurysmal stenosis needs intervention. But most of the time after intervention, this will have a recurrence. Then you have to plan for other side fistula or other option of RRT. So this is a general indication for aneurysmal intervention. So if I have this, suppose I presume this patient is 8 years old, AV fistula, I see this kind of aneurysmal. I will not go for intervention if it is soft, non-tender, no increase in size recent times, no functional problems, collapse on elevation, no HOHF, no Steele phenomenon. Why should I intervene? So just watch. So all aneurysm not dangerous. There are 5 danger signs. Rapid growth, when a bump turn into cone shape like things, and a painful like a lump, like a blood infiltration in the tissue, hyperpulsatile, and skin devascularization like skin ulceration, blackish. The simple thing is when skin and subcutaneous get adherent and become one layer and some SR-like formation forming, it's a sign that it's going to rupture soon. So these are the danger indication, and of course ischemia. So these are the 5 danger signs, and there is no intervention required. Here intervention is required. So when you adopt a conservative management in asymptomatic patient, the 2 things, you have to keep periodically investigate for outflow stenosis, and modification of cannulation sites and technique you have to implement in your protocol. So generally the type of treatment is 5 types: aneurysmography, or plication, or resection, or ligation and endovascular report. These are the 5 available things. See, most of the time AVF aneurysm requires surgical repair, but you can go in a frail patient's endovascular because over the like a covered stent, through the stent it's very difficult to cannulate. but in difficult, frail patients, you can do it. Ligation is a simple ligation, and you can use a prosthetic graft. And resection also, when suppose the facility is not available, you are only trained in kind of resection and go for the other side, that's also feasible. But most of the time, even 2 years ago, I was doing that kind of work. Now I am trying to do some kind of aneurysmography. It all depends on your experience and the pressing necessity of the patient's clinical situation. There's all these things. And aneurysmography, you can use even stapler needle. Stapler they are using for the gastric sleeve, gastrectomy for the bariatric surgery. That kind of thing you can use for the aneurysmography. Or simple, you can resection and anastomose and all these things you can do in aneurysmography. But this is a general outline. It depends on individual patients. So in a nutshell, there is no standard definition for AV fistula aneurysm. Natural history of different types and growth not yet defined. The best treatment modality is not clear. The most of the treatments are guided by clinical experience rather than evidence. So surgical approaches remain the mainstay of treatment. Endovascular stenting and the stent cannulation can be considered in frail patients. But ultimately the mantra is you have to preserve the patency and prohibit prosthetics. That means you don't use prosthetic material, you invite more trouble to the patients. So my sincere thanks to Girish Reddy, all the images, because I don't see this kind of aneurysm, because the institute is a huge loading is seeing every day 1 or 2 patients are coming with aneurysm, with central vein stenosis, it needs intervention. So I sincerely thank my friend, he contributed all the images except 1 or 2 images. Thanks.
Thank you, sir, for your nice elaborative talk on the, one of the important complications of AVF, that is aneurysm and its management. Sir, one small questions from my side before going to audience. What you talk about the aneurysm formation in the patients who is on the long-term dialysis, but in the last couple of months, I encountered aneurysm formation and impending rupture, leading to even rupture in immediate post-creation within a week or 2 weeks before getting the primary maturation itself. What could be the reason? What I found, it was the infection at surgical site leading to deep penetration of infection. What is your experience or in other cause as well which leads to the aneurysmal dilatation and aneurysm formation in immediate post-creation of AV fistula?
That's why I don't have much experience under the last 20 years. I've hardly seen 10 patients. So my practice is entirely different. I create fistula on stage 4, and when the patient comes, put a line, next day I create a fistula. And I do a lot of reverse AV fistula. I was telling to one of my friends, most of the reverse fistula I don't see aneurysm. It all depends on surgical techniques. If you keep less than 4 millimeter diameter in arteriotomy, mostly generally this will not happen. And for the first, you set a very clinical scenario. If you get a very impending rupture, I'll go for closure till 2 years ago. But now I started doing, I put another line to temporary management. I'll try to resect, allow it to heal, then I'll start using it if it is feasible.
Thank you. Any question from audience, please? If there is no more questions, so we should, thank you, sir. And we will proceed to next talk, which is on before and after I started doing the Doppler myself, plastic surgeon's perspectives. And for this talk, we have Dr. Prashant Branwal, sir. Sir is consulting cosmetic and plastic surgeon at Banaras Plastic Surgery Hospital, Varanasi. Welcome to sir. And next 15 minutes are your pledge.
Good afternoon, seniors and dear friends. I will be speaking about my fistula outcomes after I started using Doppler. AV fistula is a surgical connection made between an artery and a vein for patients requiring long-term hemodialysis, and the process strengthens the vein in few weeks, which provides a reliable site for the repeated needle insertion required to filter the blood. It is preferred over other type of vascular access because it has low risk of infection and clotting. It has longer durability and better flow rates. It has reduced long-term healthcare costs. So to have all these advantages, we need a Doppler study before making an AV fistula. Before Doppler, we primarily rely on physical examination by palpation and auscultation, and use of traditional angiography for confirmation of any issues. Revision surgeries were higher because of primary failure of fistula because of thin caliber of vessels. There is lower fistula maturation rate because of late detection of issues. How Doppler helps? In preoperative arterial mapping, it can measure vessel diameter, which ideally should be more than 1.8 mm. It detects high bifurcation of brachial artery, which has incidence of 12 to 20%. In one of my case, artery was just 2 mm size at elbow. And because of Doppler finding, I could make a long opening in radial artery without fear of any steel phenomena. It can detect calcification in the artery. Although calcification do not represent any contraindication to surgery, but it can influence AVF outcomes and render surgery more difficult. Flow rates of more than 20 ml per minute in radial artery depicts good outcome of AV fistula construction. Sometimes in few females, even brachial artery shows lesser flow rate, which warns us about a delay in maturation or access dysfunction. Reactive hyperemia test is an excellent index of functional status of the artery. By this, we can know preoperatively arterial ability to increase its caliber. This is reactive hyperemia test. Ischemia is induced after making a fist for 2 minutes. When hand is opened, arterial spectrum becomes biphasic, which shows vessel is capable of dilatation. Then comes pre-op venous mapping. Doppler helps in mapping cephalic and basilic vein of upper limb for its suitability to use to create AV fistula. And the parameters which are helpful are its scores, its caliber, compressibility, and collateral circulation. Vein diameter should be measured at 8 different sites: distal forearm, mid forearm, proximal forearm, distal arm, mid arm, and proximal arm. Vein course should be linear and should lie less than 6 mm below the skin surface to facilitate the venipuncture. In this, can we repeat? Here the vein is lying 1.05 centimeter below the skin deep. So it is not good for making AV fistula, and if you are making it, we have to then superficialize this vein. Vein compressibility is assessed by exerting intermittent pressure with the transducer, which causes complete collapse of the wall. The vein should be compressible before making a fistula. Here in this case, radiocephalic AV fistula was made 1 year back, and the patient came with no thrill. On Doppler, there was thrombosis up to the mid forearm. Here, Dopplers help to plan and create AV fistula at elbow in radiocephalic. Here you can see the fistula is, the vein is compressing, and now it is not compressing. After transducer, the vein is thrombosed. The thrombosis was up till here, proximal forearm, and with help of Doppler, we can make radiocephalic fistula at elbow. Otherwise, we could have landed up making brachiocephalic fistula. An obese lady consulted me for AV fistula creation, and clinically vein was palpable at elbow, but in forearm it was not clinically appreciable, which on Doppler reveals a good size vein of 2.2 mm with a depth of 6.1 mm from skin surface. And usually in such cases, without Doppler, a surgeon will reconstruct or create an AV fistula at elbow. In this case, Doppler helps me to create fistula in distal forearm. Another patient whose brachiocephalic AV fistula was attempted at 2 different centers, and it was closed after surgeon finds vein of small caliber. Vein mapping of Doppler reveals only 1 mm size of cephalic vein at arm and 3 mm of size of basilic vein, which later was planned for stress transposition. Now comes AV fistula maturation. Maturation is defined as development of physical characteristics which render AV fistula suitable for venipuncture. And sonography criteria published by National Kidney Foundation are flow volume should be more than 600, vein diameter should be more than 6 mm, outflow vein skin depth should be less than 6 mm. If the blood flow rate is more than 250 ml per minute in first week and more than 500 ml in fourth week, it is more likely fistula will mature. And this allows one to predict the probable outcome and correcting if there is any. There is no other imaging tool except a Doppler which can be used to monitor the fistula during its maturation. There is no other imaging tool. It is recommended that Doppler should always be done before a fistulous vein is first used for venipuncture. Ultrasound mapping of the outflow veins can facilitate the first cannulation and simplify subsequent punctures. I'm skipping this formula used to calculate blood flow volume is area into mean velocity into 60, and to avoid error, the area should be measured in zoom function, sample volume should be oriented parallel to the direction of flow, and sample volume should be positioned at a center, and amplitude should be adjusted to allow sampling of 60% of the vessels. Follow-up. Our goal should be to maximize fistula survival by prevention, early detection, and immediate treatment of complication. Measurement of blood flow is now considered as the best means of surveillance. Reduced blood flow volumes are predictive of fistular dysfunction. Value of less than 500 is predictive of access dysfunction, and less than 300 suggests imminent thrombosis. Decrease in flow volume of 25% in a period of 2 to 3 months is also predictive of dysfunction. Absence of increased inflow of at least 20% after an angioplasty indicates failure of treatment. Doppler provides direct visualization of stenosis with precise information of stenosis location and its severity. The criteria of stenosis are visual narrowing of more than 50% as assessed on grayscale imaging, and an elevated PSV ratio of 2:1. Sometimes radiologists would suggest stenosis at one place, but clinical examination and Doppler study were okay. So by doing Doppler and simultaneous clinical examination both by the same person, we can delay intervention in such cases. 47-year-old lady referred by a nephrologist with proximal forearm swelling after venipuncture during dialysis. On clinical examination, there was wheezing sound, but on ultrasound study, fistulous vein diameter was okay. It won't be as a high-risk case and need for close follow-up. Another case with lower arm swelling after venipuncture looks clinically hematoma, but there was no sign of ecchymosis on skin, which raised a suspicion to me, and Doppler revealed a large pseudoaneurysm extending in between muscles fiber of biceps. This is pseudoaneurysm sac, and this is brachial artery, and this is the connection. This was by venipuncture. After closing the puncture of brachial artery, this aneurysmal sac was excised surgically. I do not have much data about reduction in thrombosis rates, increase in successful maturation after using Doppler, but definitely it has increased my number of patients who are eligible for AV fistula reconstruction, and also it has reduced my failure rates. Patients on hemodialysis are tired and are in morbid condition to have regular checkup with Doppler by a surgeon or a radiologist. So there is a need of nephrologists to have Doppler machine at dialysis center to improve the monitoring of the patients. Doppler has reduced the need of more expensive imaging studies or surgeries. Post-op surveillance has increased fistula survival rate by treating early detection of complication, and hence reduces hospitalization due to thrombosis or fistula failure. It has a learning curve and challenges by correct interpretation. For me, it is very difficult to calculate volume of blood flow per minute, which I am still running with my radiologist friend. And to conclude, although physical examination provides acceptable information for superficial veins, but it is insufficient in considerable number of patients. So this imaging tool is a must if a physician or surgeon wants to excel in this field of surgery. Thank you.
Thank you, sir, for highlighting the importance of Doppler in fistula planning and maintenance. Any questions, please?
It's a huge comment. I have not seen a person interested to learn across this specialty more than Dr. Prashant. I've been seeing him, I've been meeting almost 7 years now. He's literally, and sorry, I was out of work. Did you use that initial picture which I made.
I forgot.
Okay.
It was in
I will post in group.
Yeah.
So he literally stood and saw me, you know, the ultrasound, even surgical techniques, and with his expertise, he actually found, he figured it out that using ultrasound is the most important part.
Yeah, definitely.
That was the beginning, and now he is presenting about something which I can say even as a vascular surgeon, you know, we kind of learn the art of guesswork. So I don't do much of the flow measurement because it should not be done. It's simply, okay, who will learn this? So in his quest to learning, he has passed us, and now he's with the radiologist friend learning. Thank you, boss. It's been wonderful learning from you always.
Yeah.
And something what you have given me, so as a vascular surgeon when I was in training, so we were not much into using vascular loops. So much so that actually had a surgical loops, but I didn't used to use because, you know, okay, this used to be a surgeon's swag that, okay, I can create a fistula with the naked eyes. Then he said, no, you use it. He insisted on me using it. Now it's been 6 years or more than that. There's not even a case I do not use surgical loops. So thank you for pushing me for that.
Thank you much.
If no more questions, so I conclude these sessions and proceed to next sessions. Thank you, madam.
I'll request Dr. T.K. Sinha sir to please felicitate our chairpersons and speaker. So moving ahead with our next session, which is the 6th session of the day on evolving dialysis care trends, I would like to welcome and invite our chairpersons on the dais. I welcome Dr. Manoj Singhal sir, Principal Director Nephrology and Kidney Transplantation at Max Hospital, Vaishali, Uttar Pradesh. Dr. N.S. Sengar sir, Professor Nephrology at MLB Medical College, Jhansi. Dr. Nirbhay Kumar, Director and Senior Consultant Department of Nephrology at Regency Hospital, Kanpur. Dr. Lalit Pusnani, Professor Nephrology at RML Hospital, New Delhi. Dr. Ravi Khushwa, Associate Professor Nephrology at SGPJ Hospital, Lucknow.
afternoon, ladies and gentlemen. So let me just take this opportunity to welcome you to this afternoon session. So now this time, maybe we'll switch gear from vascular access to technology of dialysis. So in this series, we have a couple of speakers. We'll be discussing more about dialysis technology as such. First and foremost is Professor R.K. Sharma. He is the Director and Head of Department of Nephrology, Medanta, Lucknow. And he will be talking about CONVINCE trial. We all have dilemma, what is the role of online hemodiafiltration, where it should be used, whether it changes the outcome of these patients. So I think we have Dr. Sharma here. He'll guide us through this topic.
Good afternoon, ladies and gentlemen. At the outset, I thank the organizers, especially Pradeep Rai, for organizing such a informative and in-depth scientific meeting in this area. I have been given this topic about the outcome and importance of hemodiafiltration in end-stage renal disease patients. The background is this article which you might have also read, which was published in New England Journal of Medicine, which talked about effect of SDF as compared to hemodialysis on mortality in patients with kidney failure. And the study actually concluded that in patients with kidney failure who are on kidney replacement therapy, using the high volume, high dose hemodiafiltration resulted in a lower risk of death from any cause as compared to the parallel arm of patients who were on high flux hemodialysis. In India, we have had a lot of discussion about the problem of access to the dialysis. If you want to give online high volume SDF, access is very important. The concept of incremental dialysis is also very important for Indian patients. But at the end of the day, we need dialysis with better clearances. The dialysis of whatever type we are using should have economic advantage, which is very important for our patients. The lower erythropoietin dose, phosphate binders, better quality of life, lower hospitalization rates, longer stay on twice a week hemodialysis if the residual renal function is preserved. These are important components of various issues in our Indian patients. But we know that when we are talking of hemodiafiltration, we talk about a convective dose which has to be optimum, high volume, as translated according to the body surface area, the anthropometric of the patient and the needs. So ultimately it's a personalized care, because somebody who is 70, 80 kilo as compared to another who is 40, 50 kilo would need lesser, or if it's a higher than body surface area, then the higher convection volume if you want to give adequate hemodiafiltration. Because the idea is when you catch these patients early, which doesn't happen in most of our Indian patients, you can start with maybe 1 or 2 hemodialysis per week, and as they lose the residual renal function, they will need more frequent or more dose of dialysis, and it is possible that hemodiafiltration with higher volume would be the much more useful and effective way to take care of patients when they reach advanced kidney failure and have loss of kidney function. The anemia management would also be, as the studies they suggest, this is one of the Turkish SDF study, which suggested that patients on SDF, they required less erythropoietin dose, which is useful even from the economic point of view. But it is very important that most of the studies which have been reported, good randomized studies, have talked about high volume SDF, 23 liters per session. And to achieve that, you have to have a very good vascular access, about 350 ml per minute of blood flow rate. The fistula needles which we use of the gauge of 15 or 16 G, and if it is not possible, you might end up increasing the time of dialysis in these patients. We know from the contrast study that CRP levels are less in patients who are on SDF as compared to hemodialysis. There is much better removal of beta-2 microglobulin, which has a positive effect on mortality. But it is interesting that in these 4 studies, the contrast Turkish, Scholl and the French study, there was only one study which suggested the Scholl study a significant benefit in the primary endpoint of 30% low risk of high of all-cause mortality in patients with SDF. In other studies, the benefit was not significant as compared to hemodialysis. But what all these studies suggested, if you're able to achieve higher convective volumes, which ranged to the tune of 17 liters to 25 liters, the benefit was seen. So the message was the studies are inconclusive, though they were randomized studies, but the volume component of convection which was used in SDF was very important. When this European SDF pooling was analyzed along with the George's Institute of Global Health, it showed benefit in the data which was put together in terms of the outcome. The survival benefit of SDF from these 4 studies, 3 of them were inconclusive, was based on convective volume if it was more than 23 liters. So that's why the 23 liters of high volume SDF has been considered as the one which you should try to achieve if you want to give the benefit in terms of the mortality risk being reduced in SDF, which needs to be high volume. This is the data of the same CONVINCE study, which has been reported in 2024, which showed that there was definitely benefit in terms of the quality of life in these patients. The quality of life in patients with SDF was much better. In India, we know that patients on dialysis, this is the data which is not neither a good registry data nor a good large studies, which suggest that the outcome in our Indian patients who are on dialysis is much inferior to the Western population. Even in US, if you look at the US RDS data, patients who are 40 years old on dialysis, their life expectancy is actually 40 years less than what is expected from, in the general healthy US population. So still there's a huge gap in terms of the patients who are on dialysis. And here, these are some of the studies in Indian patients where you can see, if you look at the quality of life, both the physical and mental. If you look at the second and third column, the last column and the previous one, on dialysis, there was significant reduction in both physical and the mental quality of life parameters as these patients were kept on hemodialysis. So the message is our patients have much inferior outcome, and their quality of life significantly deteriorates on dialysis. So keeping that in mind, this trial has been done where in this CONVINCE trial, the patients who were able to achieve good flows in the vascular access and also they did not have any pre-existing cardiovascular disease. They were able to achieve a convective volume of more than or at least equivalent to 23 liters, and there was very minimal dropout rate. So these two arms with high volume SDF of more than 23 liters were compared with high flux hemodialysis to look at 3-year follow-up of outcomes. And what it showed that patients who were on SDF, there was 23% reduction in the mortality as compared to the high flux hemodialysis. And the conclusion which was actually derived that there is a low risk of death from any cause among patients who are on high volume SDF as compared to patients who are on high flux hemodialysis. The studies, the CONVINCE study was very well designed, very well conducted. They achieved a reasonably regular high volume convective filtration, and the dropout rates were very minimal. The limitations being that the patients who were enrolled, there was a selection bias. They were younger patients, patients without cardiac disease, healthier patients, and they achieved the outcome benefits even earlier and even more than what was really envisaged. So this was one very strange finding in these patients. But what we have to understand that this well-conducted study has shown that high volume hemodiafiltration has benefits both in terms of reduced mortality and also in terms of the quality of life. The most of the benefits of the mortality were related to the infections being less. And there was actually no effect on the cardiovascular mortality in these patients, which is a little surprising because most of the other studies and randomized studies have really talked about the cardiovascular benefits of the LDF. This is another meta-analysis which is showing a similar findings, and this is one of the these are two meta-analyses which have higher number of patients pooling both the 4 studies, and other studies have shown again the similar benefit. And this is another review which is by Claudio Ronco, which is talking about whether the CONVINCE trial is enough, which is going to convince us to change from the conventional hemodialysis. Actually, here the question is having a conventional high flux hemodialysis. In India, if you see, hardly 1.5% of our patients are on SDF, and there could be another 2% of patients who are on high flux hemodialysis. So our number is really very small. And as the national dialysis program expands, we have more patients who are on conventional hemodialysis. So this number is not very easy to increase, seeing unless the government accepts that SDF will be a component of national dialysis control program. As I have already emphasized, if we are talking about SDF, you have to target higher convective rates of 23 liter of filtration of the convective transfer. So vascular access, the needle gauge, the blood flow rate, and a good anticoagulation, they are all very important. And the dialyzer which you're using, plus the filtration and the treatment time. The hardware is also very important, and also the quality of dialysis which we are going to use. So I think I'll stop here. There is another trial going on, 4HRT, which is more of a trial where the registry-based trial, which is going to again look at whether SDF is really far superior to conventional hemodialysis. Thank you very much.
I think Dr. Sharma in his presentation has alluded to various problems which we see in patients who are on dialysis. So there are problems at a population level, as he has highlighted, the access to dialysis, the cost of providing dialysis to the healthcare systems, and then of course outcome of these patients on a population level. If we talk of an individual patient level, again there are a lot of problems as we have discussed in this. So maybe online hemodiafiltration is an option in a patient where we have all these facilities. So the patient have a good vascular access, he is compliant to the treatment, and he has money. Somebody is paying for his dialysis. Otherwise, this dialysis is expensive as compared to the conventional dialysis, and is generally not covered by many of the insurance companies. So in a selective patient, definitely there may be a role of this dialysis which can improve the outcome. But in general population, I think our patients need more dialysis for the money what they pay. So if we optimize the blood flow and if we optimize the size of dialyzer and other parameters, we can improve their outcome even on the conventional dialysis. Any comment?
Can I respond?
Yes.
What you're saying is very perfect. The CONVINCE study is a way to go forward that our administrators, they understand the importance of, now we have been able to get this thing accepted that people should get dialysis. This was not possible 20, 30 years back. But now they have to understand, just like RO was accepted, that what is the need for SDF in this whole dialysis program, because it is more expensive, but you have to see whether the quality of life, survival, because that is the next thing which they have to look at. And definitely, it is only taken off in a bigger way in corporate sector. There are many corporate settings where patients are on SDF in a big way. But in the government sector, probably when we were in SCPGI, we were one of the first government institution, though it was a partially paid institution, that we started on a reasonably big SDF program. That time the SDF program was even not that much existent in many centers. So I agree with you, but this is the study which is one step. Maybe if other studies come and this thing takes, in USA still the number is 0, very little, because it is not accepted by their administrators as a therapy to be given to the patients.
I completely agree with you. Even this CONVINCE trial, see, the benefit is very small. So 23%, although that's what they have shown, but if you look at the number needed to treat is almost 23 patients for say 2.5 or 3 years to prevent one death. And there's no difference in any other outcome, secondary outcomes or any other outcome. Especially where you expect the benefit. For example, patients who have underlying diabetes, patients who have comorbidities, heart disease, there was no benefit in survival. The quality of life, definitely surrogate markers were there which have shown benefit, but the hard outcome mortality has not been, and that's the reason it has not been accepted in US. So I guess there theoretically, yes, there is benefit of online HDF. There is symptomatic improvement, but at least we have not been able to show the benefit in terms of hard outcome or mortality so far. So I think we need more data to be convinced that that really improves the long-term outcome. Any other comment from? Yeah, Dr. Dhananjay.
Thank you, sir. Very nice presentation. I'm having three questions. One question is regarding this incremental dialysis. I think this word is now being used a lot because people want to start weekly dialysis and go to twice or thrice a week. But problem is how to select the patient who is fit for these type of incremental dialysis. And another part of this problem is how you are going to fit the patient in your system. Because once you are putting some patient on once in a week dialysis and twice a week dialysis, then definitely it's very difficult to make any schedule for the patients. So what is your take on this very important issue? How we are going to select a patient for incremental dialysis?
Yeah, you're very right. The type of dialysis which we are talking about, once a week, twice a week, thrice a week, plus minus the high HDF or high flux, is something which, if you look at the European and US nephrologists, they will have a lot of points against the so-called incremental dialysis, but you will be surprised. Some of the good studies on incremental dialysis have come from Europe. And recently I was attending a conference where they were presenting this type of data that this was about conventional hemodialysis. You can have patients which we know who have residual renal function, and because of the practical consideration which you can take for 1 or 2 sessions of dialysis per week. You have to monitor these patients better, and also you have to see that they don't deteriorate. And then as they progress, you can increase the frequency of hemodialysis. They are going back that we should not use the standard formula that any patient who presents with less than 20 ml of creatinine clearance, you just start at least 2 dialysis per week or 3 dialysis per week. We can choose patients depending on their residual renal function and even start with less frequent dialysis. It is also useful for very elderly patients who are not able to tolerate dialysis, who are not able to go to the centers. So I think this is a concept, and there are studies coming up with long follow-up also. But it needs much more sincere follow-up and monitoring of these patients, which sometimes is not there because we just put them on dialysis and do not see these patients. That should not happen.
Another question, sir, Mike, regarding this use of HDX versus this HDF. So one company is coming with Theranova. This is one dialyzer. Theranova.
Oh. Theranova is a mid-cutoff dialyzer, and it has a different concept that this is a dialyzer by using conventional dialysis or high flux dialysis. You can remove much better the higher molecular weight substances. And sometimes we have used it even in patients with multiple myeloma because it is not that expensive. So it removes molecules with higher molecular weight. But it has not been used in a big way in terms of what you are probably trying to hint at, that what benefit it will have in patients who have end-stage renal disease and are on dialysis. I would consider patients who have neuropathy or patients who have amyloid deposition, they could be one candidate for Theranova dialysis. maybe even patients with a lot of light chains, multiple myeloma, who cannot afford the real 1.5 lakh of dialysis session using that filter, would be another candidate who are undergoing chemotherapy for multiple myeloma.
Thank you, Dr. Ranjan. So, there are no more questions. We thank Dr. Sharma for this lucid presentation, and we move on to the next talk.
So for the next talk, we have Dr. Abhilash Chandra. He's Professor and Head of Department of Nephrology at Dr. RML Institute of Medical Sciences, Lucknow, and he's speaking about fate of access around transplantation.
Good evening to all. Thanks to the organizers for inviting me to talk on this topic. I'm extremely grateful for the hospitality offered. I was given this topic, fate of access around transplant. So what I thought and what it meant possibly was that what to do with the access we have for dialysis when the patient is going for a transplant. So are there any guidelines? Practically there are no guidelines in this regard. We all know that renal transplant is the most definitive and the cost-effective option when compared to keeping the patients on dialysis. But we all are aware that patients are on RRT in the form of dialysis or HD or PD before they are taken for transplant. So first we can discuss fistula, which is again one of the most common entity used for dialysis, hemodialysis. So what does fistula does to our body? It raises the cardiac output to almost from 5 liters per minute to 6.5 liters per minute. So when we have a patient who is getting dialyzed through AVF, we don't have any guidelines to actually decide what to do with that fistula. So what do? We actually teach the patient to monitor the signs for any occurrence of pain or swelling, new swelling, or a change in the size of fistula, or to appreciate any change in the thrill which is there in the fistula. So in order to decide what to do with that particular fistula, we need to know what are the endpoints which the fistula is going to have on our organs, primarily the kidneys and the heart. So a fistula creates an environment which leads to a decline in blood pressure. It decreases the foreign GFR, and in terms of cardiac impact, it increases the cardiac oxygen demand, increases cardiac output, it increases venous return, and it favors an eccentric modeling of the left ventricle. But what if we ligate the fistula? So if you ligate, we see a decrease in left ventricular end testicular diameter. It decreases left ventricular mass as well as mass index. But it also has some negative impacts, like it raises the diastolic blood pressure, increases TPR, raises pulse pressure, and at times it may lead to worsening of GFR as well. So we need to keep these things in mind before we decide what to do with a fistula, running fistula, in a patient who is undergoing a transplant. So are there any studies? There are a few studies which studied the outcome of patients who underwent a closure of fistula. One of the studies is from Veincon et al. They showed that there was a decline in GFR in patients who underwent a closure of fistula versus who didn't consider for a closure of fistula. This was another study by Letachevich et al. They studied the implications of functioning fistula on blood pressure control and renal allograft dysfunction. And they showed that presence of fistula led to a slight decrease in diastolic blood pressure, but no impact on renal function as such. Another small study by Mason et al., and they showed that in the event of a closure of fistula, there was a rise in diastolic blood pressure to the tune of say 4 to 6 millimeter mercury, and there was a decline in NT-proBNP, and the most important findings were that It led to a decrease in end-diastolic volume, decreased left ventricular mass, and left LA volume as well. So cardiac impact was quite significant. So in order to answer all these questions, there was a meta-analysis which looked into both these factors, the graft outcome as well as the blood pressure and the cardiac effect of closure of fistula. This was done by Zhang et al., published in 2020 in Annals of Vascular Surgery. They included 10 studies in this meta-analysis, and they showed that patient who didn't have a running fistula had a slightly higher blood pressure. So sorry, in not having a fistula, they had a lower blood pressure, and also they had a lower left ventricular mass index compared to those patients who had a running fistula. And when it came to creatinine values, those who didn't have a patent fistula had a lower creatinine value as compared to those who had a patent fistula. So this was a different outcome as compared to the earlier quoted study. One of the studies looked into the factors which led to a closure of fistula, and they reported that the Steele syndrome was the most common entity which was responsible for a late ligation of fistula, followed by aneurysm and cosmetic reasons. So if we club all these studies together, what do we make out? Surgical ligation can be attempted, can be found in special indications if you have a high running fistula, high flow fistula, more than 1.5 liters per minute. If you notice an arterial Steele phenomena, or if you see that patient has a high cardiovascular status and is running a risk of entering into a congestive heart failure, you can still consider a surgical ligation of fistula while taking the patient for a transplant. But whenever you consider for a closure of fistula, you need to consider the threat of a graft dysfunction at a later stage and a possible return to HD when you may require a new fistula. And particularly if you have exhausted the peripheral veins for earlier fistula making, creation of a novel fistula could be a difficult thing to do. So you have to consider all these factors into mind. What about tunnel catheters? Tunnel catheters are also quite commonly used, but the data regarding the tunnel catheter in the use of tunnel catheter in the peri-transplant period is again all the more scarce. There are no guidelines as such. So how do we handle tunnel catheters? The best approach possibly would be an active surveillance of infection. You can do a blood culture maybe 2 weeks prior to taking for a patient for a transplant. If you are giving antibiotics locks, it's good enough. They have shown to reduce the incidence of catheter-related blood stream infections. So you can continue with the antibiotic locks. What about prophylactic antibiotics? There are no guidelines as such which could suggest that use of prophylactic antibiotics helps in reduction of CRB size in the transplant period. So best option is not to use prophylactic antibiotics, because unnecessarily you may be selecting the resistant bacteria. The most commonly taken approach is to keep the catheter in place for 1 to 2 weeks post-transplant to see for any possibility of delayed graft function, where you may need the access to be there for dialysis. What about PD catheter? PD catheter, again, there are no specific guidelines, but some societies have suggested that the PD catheter can be kept as long as up to 3 months, so that you almost negate the possibility of possibly requiring a dialysis in the post-transplant period in the case of graft failure or a delayed graft function. Some have said that it can be kept up to 6 weeks, and some have also suggested that if you are taking patients for a live renal transplant where the risk of delayed graft function is anyhow very low, you can still consider removal of the PD catheter right at the transplant itself. So main factor which is to be considered while keeping the PD catheter in situ is the likelihood of a delayed graft function occurring post-transplant. So people have studied keeping the PD catheter in case of a delayed graft function where you have used PD catheter for PD. And they found that when they compared the patients who were kept on hemodialysis versus those who were on PD, the outcome was same in terms of graft failure. The same study also studied the length of hospital stay, which was similar in both the modalities, be it PD, be it HD. And in terms of duration of delayed graft function, it was again almost parallel. So the modality didn't have any effect on the graft outcome as such in cases of delayed graft function. One of the studies took around 137 PD patients, but they had a poorer outcome. They said that almost in 15 patients requiring post-transplant PD, almost a third of patients developed peritonitis and 20% developed fluid leaks. So they suggested that it's best to remove the PD catheter and opt for a hemodialysis if you at all require a dialysis post-transplant. This is a study by Peluso et al. They showed that the risk of catheter infection is pretty low, and they suggested that you can keep the catheter as long as to 30 to 45 days, and then you can possibly remove the PD catheter when the possibility of graft failure is anyhow very low. This was a meta-analysis done by Zabitowski et al., where they included only 8 observational studies. They it was not a collection of randomized trials. It was a collection of observational studies. So the level of evidence was pretty low, but they still studied it. They studied 2 factors as to how many catheter-related infections are there, and the possibility of requiring dialysis based on the fact that whether the catheter is kept in situ or not. And they found that if the catheter was kept in situ, the likelihood of requiring dialysis post-transplant was almost twice as high compared to patients who had the catheter removed. They also studied the risk of peritonitis, and they said that it's almost to the prevalence for peritonitis was almost to the tune of 6.3%. So even in the presence of these evidence, they said that the studies had an inherent bias, because PD catheter in situ was there particularly in those patients who were more likely to require dialysis or more likely to have a delayed graft function in post-transplant period. So there was an inherent bias in most of the studies. So level of evidence was still low. So can we sum up the findings in the earlier studies and to decide whether we should keep the PD catheter in situ or not? So first you need to assess the risk for delayed graft function. If there is no risk, like taking patients for live-related renal transplant, so you can anyhow remove PD catheters right at the transplantation itself. But if there is a risk, you need to assess whether the peritoneal membrane was breached during transplant, or were there other surgical issues related to PD catheter being left in situ, or there was a high risk of peritonitis or PD catheter site infection. If any of the factors is there, then it's best to remove the PD catheter then and there itself. If no, then you can keep the PD catheter in situ and use it in case you require dialysis. A small data from our own center, we had, this is the data for roughly around 200 patients. Our patients are mostly from the younger age group. 37 years is the mean age. We had predominantly male patients in our setting with the dialysis vintage around more than a year. We had running fistulas in almost 157 patients in 200. And tunnel catheter was there in situ in 28 patients. Temporary catheter was used for dialysis prior to transplant in as many as 10 patients. And PD catheter was there in just 5 patients. So if we talk in terms of outcome, this is just a 4-week outcome. And we noticed that there was an access thrombosis in as many as 32 patients. And the removal time of the tunnel catheter was around 8 plus minus 4 days. So we keep the patient for 2 weeks in RKTU. So this is by the time they are set for discharge, we remove the tunnel catheter. We remove the temporary catheter a little early. All PD catheters were removed at the transplant time itself, at the time of transplantation itself, because We are only doing live-related transplants. So anyhow, we don't expect a high rate of delayed graft function in our setting. What about infections? This has been the most talked about when you keep the catheter in situ for so long. We had 3 CRBSI episodes in internal catheters. All were managed with antibiotics and removal of catheter, and there was no mortality reported. In terms of temporary catheter, we just had 1 episode of CRBSI, which was again managed by antibiotics and no mortality reported. There was no tunnel infection or peritonitis because we had all the PD catheters removed at the transplantation itself. So to conclude, AVF closure at the time of transplant can be considered if AVF closure leads to improvement in NT-proBNP levels and the cardiovascular profile, but it also leads to an increase in diastolic blood pressure. So closure can be considered taking all these factors into mind. Change in AGFR slope in various studies after AVF closure has shown mixed results. So possibly it's difficult to base our decision on GFR slope as such. Maybe availability of more scoring scales could lead to a better decision making when it comes to closure of fistulas, which includes a global cardiovascular risk assessment as well. And keeping PD catheter requires a good assessment of DGF risk, PM membrane, peritoneal membrane breach, and the risk of peritonitis. Thanks for patient listening.
Thank you, Abhilash, for a wonderful presentation. Just one question. Is there any international data available for spontaneous closure of fistula post-transplant? And what is the median time to spontaneous closure for fistula? Most of the patients have, according to your own study, almost from 200, you had almost 35 patients with spontaneous closure by 4 weeks. So almost 20% of patients already have a spontaneous closure of fistula. So why not ligate the fistula post-transplant? What is the benefit there?
First, the data. Data is there. In the immediate post-transplant period, if we take say around 2 months of post-transplant period, the international data suggests that is roughly around between 10 to 15% of patients are, in fact 8 to 15% of patients are likely to have a spontaneous AV access thrombosis in immediate post-transplant period. Later on, roughly additionally 10 to 20% also notice spontaneously closure of fistula. So the other question was why can't we just close it? Closure requires again assessment of a possibility of graft function, or how long are you going to have this graft. Say the survival of a graft is roughly around 50% at the end of 10 years. So half of the patients are likely to require dialysis again. So whenever you think of a closure of fistula in the transplant period, you always think that what if he requires this access in the event of a graft failure. So the suggestion would be that if you didn't have a history of multiple access failures, then you can accept for the graft closure or the fistula closure. But if you had exhausted other peripheral access sites, then it's best to keep the fistula running as long as possible. So, and of course, in addition, you also need to take into consideration the cardiovascular profile of the patient. So if it allows, we can still consider for a closure of fistula. But the most important factor which should be there in your mind is the possibility of graft failure in the later years of his transplant period.
The house is open for questions. Thank you, Abhilash.
So as a part of the session, we'll be taking more questions at the end. So we are getting the next talk is from Mount Sinai. Dr. Ankit Sakhuja is a Director of Artificial Intelligence and Informatics, Institute of Critical Care Medicine, Director of Clinical Informatics Research and Division of Data Driven and Digital Medicine. His introduction keeps on going. He's an old friend, and actually initially I approached him because I wanted to talk him about the current status of artificial kidney, because he also have to have the previous experience of being a nephrologist. But with this current role, we realize that, okay, we can curate something about role of AI in vascular access. So he has actually curated this talk because as such, there is no talk which exists on this. He has to go through a lot. So thanks, Ankit. Great to see you after so many years. And all up to you.
Thank you, Himanshu, for the kind introduction. Good morning, everyone from New York City. It's an absolute pleasure to have the opportunity to talk about artificial intelligence in front of such an excellent group of clinicians. It's heartwarming to see artificial intelligence finding applications in newer fields within healthcare and such a burgeoning interest in artificial intelligence. So in this talk, I'm going to go over some of the basics of artificial intelligence, and then we'll talk about some of the very specific examples of studies, how artificial intelligence so far has been implemented in the field of vascular access. I'm going to turn my video off just so that you can all concentrate on the slides, and please feel free to ask any questions as they come up. All right, so the first question is, why do we really even care about artificial intelligence? And the answer is simple, right? There are so many things in our daily lives that depend on artificial intelligence, from various appliances in our homes to the facial recognition software that we use to unlock our cell phones. Navigation apps that we use to get from one place to the other, to text editors, virtual assistants, chatbots, even self-driving cars, you name it. That all is built on artificial intelligence and shows how artificial intelligence has percolated our world. And it's not a surprise then that artificial intelligence is finding its ways into the realms of healthcare. But that really begs the question, what is artificial intelligence? Very, very simply, artificial intelligence is the science of making intelligent machines. Now, this is a rabbit hole, right? Question is, what is intelligence? Very simply, intelligence is the ability to learn from experience and apply that learned behavior to deal with new situations. So intelligence has many elements to it, as enumerated on this very busy slide over here. So we can say that artificial intelligence is the ability for a computer to think, learn, and simulate mental processes, such that it can independently perform complex tasks that once required human input. So now that we have that somewhat out of our way, let's talk a little bit more about what are the various types of artificial intelligence that are out there that are useful to us in the current times in healthcare. So if we look at all the artificial intelligence algorithms that are out there, we can put them in three buckets. One is machine learning, one is deep learning, and one is natural language processing. So let's unpack these a little bit now. What's machine learning? Machine learning is the technology that allows computers to learn themselves without the need for explicit programming. Now, that doesn't mean that we don't have to do any programming. That's what we do in our lab day in and day out. We program computers. But we don't have to spoon feed the instructions to a computer. And there are three types of machine learning algorithms that are out there. There are supervised algorithms, unsupervised algorithms, and then there is something called as reinforcement learning. So what's supervised learning? Let's say you have a basket of fruits. There are some apples in it, some oranges in it, some bananas in it. And you want the computer to separate them out into apples separate, oranges separate, bananas separate. What you would do in this case is show the computer that, this is what an apple looks like, this is what an orange looks like, and this is what a banana looks like. Now here the important thing is, we are not telling the computer that, the apple is red, or its shape is this, or its texture is this, or the weight is this, or the dimensions are this. We're just telling the computer the final labels, that this is what an apple is, this is what an orange is, this is what a banana is. And then this algorithm figures it out that, the shape of the apple usually looks like this versus orange like this versus banana like this, or the color looks like this. So we are not giving or spoon feeding explicit instructions, but we are still providing some coding to help the machine learn. Now with this, what the computer can do is, it can separate these fruits out. Pretty phenomenal. But what is even more interesting is that after this session of training, if you give this computer a new basket of fruits, which is, new data or validation data, it can do the same thing on that data, and it can separate those baskets of fruits out, which it has never seen before. One of the very, very simple examples of this supervised machine learning is regression analysis that we all know of. Very simply, the goal of regression is to find the best fitting relationship, which is basically just a mathematical function that describes how the independent variable influences the dependent variable, right? Like how does the disease acuity affect the length of stay in the hospital? Now, another example, which you will see a lot in machine learning literature, is something called as decision trees. Now, these decision trees, they create splits along variables that allow for the best discrimination between the classes. So the goal of a decision tree is to find the feature and the threshold. And feature is the variable. So the variable and the threshold of a variable that produces the most homogeneous groups. Say, for example, I want to go out and play cricket today in New York City. The first thing I'm going to do is, check the weather, right? And if the weather is cloudy, then it's a good day to play cricket in New York City. But if it's sunny, then I need to look at humidity. And if it is not too humid, I can go out and play. If it's too humid, then that may not be a great idea for me to go out and play today. I don't want to get all sweaty over there, right? If it's rainy, I need to see how windy it is. If it's very windy, then I cannot play. But if it's not that windy, I can play. So you can see that this becomes a tree of these decisions which split along different variables at different thresholds. So this is what a decision tree looks like. And we can make these extremely complex decision trees for a lot of things, for many things in healthcare, very similar to this very, very simple decision tree. But now let's say that, I want to play cricket in Lucknow, or I want to play it in Mumbai or Delhi. The problem with this decision tree is that this has been built according to the conditions of weather in New York City. So in a way, you can say that this decision tree is biased for New York City and may not work very well or may not generalize very well to how the weather is in Lucknow or Delhi or Mumbai, right? So what do we do in that case? There are two ways to handle that. We can create this multiple decision trees in various subsets of data. So say we have data from all these cities for weather, we can create these decision trees with all these different weather patterns. And we then take the final prediction as an aggregate of these results. This is something called as a random forest of trees, right? And this is again a very, very common machine learning algorithm that you will see in any of the machine learning literature. Another way to build these trees is where we build this decision tree, and every next decision tree is going to learn from the mistakes of the past tree in making these predictions. This is something called as gradient boosting of trees, and a very common example of an algorithm used for this is something called as XGBoost. So when you're reading through the literature of machine learning, you'll come across some of these terms very, very commonly. but this is at the crux of what they mean. This is an example of how some of these machine learning algorithms have been used in literature. So this is a study from Mount Sinai where researchers wanted to identify accurately patients who are in the hospital and have malnutrition. Turns out it's not that easy to identify those patients in a hospital setting. So they used machine learning, and more specifically, they used this random forest classifier. What they did is they took these 5,000 some patients, split that data set of 5,000 patients into 70% for training and 30% for testing their developed algorithm, which is a very standard way of doing things in machine learning world. And what they found was that their classifier must plus, which was based on random forest, ended up performing much better than the must score, which was standard of care until that point. And now, since then, at Sinai, we use must plus to identify these patients who have malnutrition in the hospital. All right, so moving on to unsupervised learning. Let's go back to our basket of fruits. We have these apples, oranges, bananas, and whatnot, right? We still want the computer to sort these things out separately. But this time, we are not going to tell the computer what's an apple, what's an orange, what's a banana. We want the computer to figure it out itself, right? And as it turns out, using these unsupervised algorithms, and they're unsupervised because we are not giving any instructions whatsoever to the computer, it can still figure out in a very decent way that this is what one group of fruits is, this is what the other is, this is what the third is. What it cannot say at that time is that what is an apple, what's an orange, what's a banana, because it just doesn't know that, right? All it can tell you is that this red-looking pear-shaped fruit is this orange round fruit is this, and this elongated yellow fruit is this. So this is an example of unsupervised learning, which is used a lot in healthcare these days to identify heterogeneities in seemingly homogeneous populations. For example, this is a study from our group where we wanted to see if the patients who develop acute kidney injury are homogeneous group of patients or not in a hospital setting. And the researchers here found that there were actually 3 different subgroups or subphenotypes of patients who develop acute kidney injury. Not only were they different in terms of various lab parameters, they were also different in terms of outcomes. And as you can see, for both need for dialysis and mortality. What this can do is help identify these more homogeneous populations for various trial settings. And that's how slowly this machine learning technique is starting to be used to have a more enriched populations for trials at the outset. There are many other disease conditions in which this has been used, including sepsis, ARDS, etc. All right, finally, let's talk a little bit about reinforcement learning. So this is still a very nascent and more upcoming machine learning technique where the computer learns by directly interacting with the environment. So the computer learns just like you and me by trial and error. And it continues to get feedback for its actions. If its actions lead to an outcome that we like, we give it a positive feedback or a positive reinforcement. If it takes actions that lead to an outcome we don't like, it gets a negative feedback or a negative reinforcement, hence the name reinforcement learning. A very, I think, easy example to understand this is this little kid whose parents want her to go from this table to the chair, but take her first steps to go, right? So if that is the case, what would happen is this kid would get up and walk, right? If the kid does not fall, takes the correct steps, her parents would give her accolades, right? The kid will feel good about herself, take more steps, and get more accolades. Here, if the kid takes a misstep, the kid will fall and will get a boo-boo, right? And the kid won't like that. So that's your negative reinforcement. And the next time onwards, this kid will adjust her steps to make sure she doesn't fall. But if the kid continues to take the right steps, continues to get accolades, continues to get positive reinforcement, and that's how, this kid will learn how to put her steps one after the other in this precise pattern so she doesn't fall and can get from the table to chair. And this is exactly how we code a lot of these algorithms in our lab, by giving these incentives to the computer to take the right action. Okay, moving on to deep learning. This is something that is very, very commonly used, and a lot of terms get thrown around. So I'm going to try to introduce some of these concepts to everybody here. So deep learning is really built on the concept of artificial neuron. Just like a neuron takes inputs, processes them, and then comes up with an output, here we have an artificial neuron, or sometimes called as a perceptron. It takes these inputs, processes them, and comes up with an output. Now, if you look under the hood, artificial neuron is really nothing but a mathematical function. Here, each neuron takes an input, and then each input is multiplied by a weight. What is this weight? This weight is just a perceived importance of each input for that neuron, for that particular outcome at that particular time. And these are set at random. And that is why when we are doing deep learning, when we are developing these deep learning algorithms, you have to run hundreds, sometimes thousands of iterations to find those exact weights or perceived importances that the neuron should give to each input to find the right mix of weights to predict an outcome, right? So for example, here, the second input becomes the most important one, and the third one, the least important one, right? At least in this iteration. Now, these weighted inputs are then added together to form a weighted sum, and this weighted sum is then compared against a pre-decided threshold. Now, this threshold decides whether the neuron should even bother firing or not, just like, neurons in our body, right? If the neuron should fire, this threshold also has information built in about how the neuron should fire. It can have multiple different types of outputs, from 0 to 1, between 0 and 1, and we can spit out a probability function. So it all depends on what we are trying to achieve from this neuron at that point. Now, rarely is, a single neuron helpful for anything, and same thing in machine learning. We usually need layers of neurons, something we call as very aptly multi-layered perceptron, or this is your classic artificial neural network. So in this, we have an input layer of neurons where the whole function of the input layer is just to pass the inputs to the hidden layer where all the analysis happens. Now, once the analysis happens in the hidden layer, that passes on the output to an output layer, and then we see the output on our user. If there are 2 or more hidden layers, that's when we start to call it a deep neural network. So deep neural network is nothing but a layer of perceptrons where there are 2 layers that run analysis, called as hidden layers. But rarely are things so simple in healthcare, right? In healthcare, we have another layer of complexity in our data. Our data is time series, which means that in this data, we have multiple time steps, and the outcome at each time step depends not only on the input at that time step, but also what happened at that time during the previous step. For example, say someone in the ICU has hypotension, right? And I'm making a model to predict their mortality. Yes, their blood pressure at that time point will be an important variable in predicting mortality, but say I go in and give them a medication to raise their blood pressure. In addition to the blood pressure, the response to that medication will also be an important part of the equation, right? So in addition to what their blood pressure is now, I also need to know what happened when a minute back I gave them a medication. How did they respond to their blood pressure? Now, this temporal relationship cannot be effectively captured by this artificial neural network that I just showed you. So this is where we use special models where neuron gets input not just from the input layer, but also from itself at each time step. And this is what we call as a recurrent neural network. Now, in AI world these days, we have a lot more fancier models also. So this recurrent neural network has this very short memory of what happened at the last time step. But we have models now which can have a longer memory, something called as a long short-term memory network. There are these transformer architectures out there which are used in things like ChatGPT, right? Which have even longer memory context built into them. Another type of data that we use in medicine is imaging data, right? But if you think about it, all images are made up of these pixels, right? So we use these deep learning architectures called as convolutional neural networks, or CNNs, to review these images. What these CNNs do is they use this filter, or which is a magnifying glass, to scan the image, few sections at a time, and just looking for these specific patterns, right? So it'll just keep scanning, and all it is doing is trying to look for specific patterns. Once this filtering step is done, the CNN shrinks down this information further with a pooling step to really try to hone down on what is really important in this image, right? And a CNN has multiple layers of this filtering step and this pooling step. And once all this is done, with every step that is coming up, it builds upon the patterns discovered by each previous layer. And ultimately, it creates a comprehensive idea of what the image is. And for example, in that chest X-ray, it can tell you whether the image was normal or abnormal. And this is, something very similar to what you would use. Say if you take pictures of AV fistulas, and you want to see if there is a problem with the picture of the AV fistula or not, this is the AI technique you'll use, and I'll show you an example of this later in the talk. Now, finally, I think we need to talk a little bit about natural language processing, because that is the big buzzword these days, right? Very, very simply, natural language processing is where we train the algorithms to understand, interpret, and generate human language. And they have come a long way. Let's take an example. So these are 3 sentences. My dog's name is Tiger. He has golden fur, and he's a golden retriever, right? Not too long ago, the natural language processing, all that could do was to count the number of words in this sentence. Then it took a little while where it could start to learn to capture these semantic relationships, where it could tell that, golden and tiger look like they are somewhere close together. And now these natural language processing algorithms can understand that, tiger is the name and golden is actually the color of the fur. It's not a name, but it's the color of the fur, which is pretty remarkable if you think, right? Where are all these NLP applications used? One of the prime examples is text classification, where it can categorize text into predefined classes. A very good example of this is the spam filter in your emails. We use it for natural language generation. With over 2/3 of information being unstructured data, it's very useful in retrieving unstructured information. And then, analyzing the sentiment of text messages. That is very important for a lot of companies, right? For brand reputation management, we can understand the sentiment of the populations with this, right? So very powerful techniques. All right, and then with how important large language models like ChatGPT have become in last years, I think we need to talk a little bit about them. So what are large language models? They offer a very comprehensive approach to language tasks. Large language models have this fluency, which is beyond your traditional natural language systems, right? Why is that? Because they are trained on vast data sets from a diverse sources, as you can see on the left side of the screen. These different types of data are then fed into this large language model, where during the training phase, like any other AI model, the model learns to understand, interpret, and make predictions based on the data it has seen. After this, the model goes through a phase of adaptation, where it adjusts to perform some very, very other specific tasks, as you can see on the right side of the screen. Now, these LLMs, they are a result of an amalgamation of deep learning and natural language processing, and a very good use case of the use of transformers, which can handle the sequential data very well while assessing the significance of each word that comes over there. And this is a prime example of how large language models can be used in healthcare. In this study from Stanford, researchers showed that you can summarize parts of the patient charts very effectively, even better than humans, when using these large language models. All right, so let's talk a little bit about how AI has been used in vascular access. And here I have picked some very specific cases to show you how in different ways it has been used and could potentially be used with your guys' help. So this is an example of a study where the authors wanted to identify AV fistula failure using artificial intelligence. So they used 13,000 some patients from a European clinical database, and all patients had mature fistula at least for 3 months. And they said that, we are going to identify AV fistula failure if somebody switched to a different access, there was occurrence of a procedure aimed at reestablishing patency, or there was any hospitalization due to complications related to the fistula. They used, very normal set of variables, something that, we'll call as structured variables that are very easily available in any Excel sheets, right? They took their data set, split it into 70% for training, 30% for validation, which is again very standard in machine learning world. And they developed this model to identify AV fistula failure. And as you can see over here, the model's performance was really good. So what this shows you is that using relatively routinely collected parameters that were available in a large registry, the authors could use machine learning to identify AV fistula failure in these patients. It's pretty remarkable. Now, another thing that the authors in the study were able to battle was the seemingly black box nature of artificial intelligence algorithms. That is a lot of reservation with artificial intelligence algorithms, that we don't know what the machine is thinking and how it's making decisions. A way to do that is that we look a little bit under the hood to see what variables is the machine giving importance to. And we can generate a set of variable importance or a feature importance graph, if you will, where we can see that what the machine is thinking. And this helps us understand what is really going on in these algorithms and maybe refine them and maybe even allow them to start to think a little bit more like how we would make decisions. Now, this is another example of a study that used artificial intelligence. So here, what authors did is they used an electronic stethoscope to procure sounds from AV fistula. The first position was at the arteriovenous junction, and then after that, the positions were spaced about 3 centimeters apart. And then they used deep learning to analyze these captured sounds to identify the stenosis in the fistula. And as you can see over here, they were able to build a pretty decent model using the captured sounds and deep learning. This is another example now where the authors used a very different kind of data. So far we have seen that they use structured data. We've used sound to analyze using artificial intelligence. Here we are using waveforms. So they use plethysmograph sensors, put them on the fistulas, and use those waveforms that are generated from the plethysmographs and fed them in the CNN model that we had discussed, to identify what the quality of the graph was, and were able to classify the quality of the graph in 5 different categories from poor to excellent. And as you can see over here, the performance of this model was also pretty decent, right? And then finally, this is another kind of application of artificial intelligence in the field, where this time authors enrolled patients from 20 different clinics across US, and they took pictures of their AV fistulas and fed them through the CNN model and tried to see if the model can identify advanced aneurysms. And as you can see over here again, that the model was able to identify advanced aneurysms with much ease, right? So you can see that artificial intelligence has been used to process structured data, waveform data, imaging data, even sound data, to make decisions about vascular accesses. This is still, I think, only scratching the surface though, because there can be many potential applications of AI in this space, right? From identifying what type of access is best for a patient to determining maybe even optimal timing or treatment strategies for various complications. Thank you.
Thank you, Ankit. I know that some of the initial part might have been slightly over the head, but I'm telling you, I tried to learn about how the AI works, and this was one of the most simplified talk I've ever seen. So I think even in the history of AI explanation, at least in our field, I'll be putting your talk as one of the landmarks. So thank you for that.
Thank you, Manju.
If any questions from audience, because I think there's a role. I think we discussed about, and a lot of papers have been coming about prediction of and finding the AV fistula stenosis, because in the entire audience will agree that if one thing we want, if we can find a stenosed fistula in time, we can save it. Okay. If we fail to do that, fistula gets thrombosed, outcomes are totally different. And this is just one of the area where we can actually have the AI looking in the future. I saw one of the paper in Nature where they use the sound models from the sound outputs from the stethoscope and putting those as a feedback for the AI model. So thank you. Thanks a lot, Ankit. And we'll continue with this.
Thank you, Manju, for having me.
Thank you. So I think there's a one talk remaining for the session.
Yes.
We'll, because of time, we'll be continuing session even after this. The tea will be served inside. So that's just to save the time.
Coming back to the presentations here. So next talk is going to be on acute kidney injury, prescribing CRRT in 2024, a contemporary overview. And to deliver this talk, we have none other than Dr. Dinesh Kullar. He is a chairman of nephrology and renal transplant medicine at Max Saket Complex, New Delhi. I think he's not new to all of us. We all know him, and let's see what he has in store for us.
Good evening, everyone. At the outset, my sincere thanks to the organizing team for this wonderful opportunity. It's a pleasure to be here in this wonderful city. And as Manoj was saying, shifting gears, and yes, we are shifting gears and talking about something which is equally important to all of us as nephrologists. When Dr. Rai told me that I am supposed to be delivering a talk of 45 minutes duration, let me confess the title of this talk was Prescribing CRRT in 2024, a comprehensive review. And when he finally told me, no, you are just allotted 15 minutes, I changed the topic and made it a contemporary overview. And let me try to see how much can I really fit it into these 15 minutes. We're all aware about what CRRT stands for. I will not go into the controversies because it's been actually mired into so many of them ever since we started using CRRT, and we were always told, why this expensive therapy when you can achieve same kind of outcomes with the help of SLED. I will not go into controversy, having been convinced over the years that CRRT has a niche place, has a definite role to play in our critically ill patients. And the way, when I was listening to wonderful talk by Professor R.K. Sharma, it didn't require the trial to convince me about the advantages of online hemodiafiltration. In the same breath, I would say, I am quite convinced that CRRT is a wonderful modality of treatment in our critically ill patients. And these are typically the various kind of modalities which we are all familiar with. And when it comes to the advantages, we know there are set advantages, which again is something which all of us as nephrologists are quite well aware of, and especially keeping in mind the hemodynamic instability of these kind of patients. Well, there are certain disadvantages as well. It's a very slow modality of treatment, and it'll ensure only a slower toxin clearance. It'll need a lot of perseverance, a lot of training of our technical staff, and you have to be quite careful about what kind of problems and nuances you have to deal with while dealing with the patient of CRRT, undergoing CRRT. Well, typically, how long should you be doing CKRT? The moment we talk about CKRT, the first thing which comes to mind is going to be a prolonged therapy. Prolonged means at least 24 hours, but it doesn't end there. So many times we find ourselves going uninterruptedly over many days, especially if the circuit doesn't get clotted. You will find typically yourself persisting with CRRT over the next many days. And it all depends upon when does renal recovery take place. That's one, are you going to incorporate ECMO in the therapy of a critically ill patient? And certainly the overall condition of the patient will decide how long do you persist with the CKRD. Well, why choose? And as I said, not raising this kind of controversy one more time, but yes, to put things in the right perspective, we need to know why are we actually going in for this costly therapy. Well, so many times as we know, the severity and the kind of patients which we are seeing and their severity of illness, often we come across patients who have multi-organ failure, who have a lot of hemodynamic instability, and imagining them to be put on conventional dialysis is unimaginable. So that is why we want a steady removal of solutes, which enables this form of therapy to achieve greater azotemia control and symptoms control. Longer treatment time in CKRT with a continuous supply of buffer provides better metabolic profile in your patient as far as the acid base and the electrolyte imbalance is concerned. And it also offers more precise fluid balance to be achieved in these patients. And of course, you can also significantly think about giving them proper nutrition. So why CKRT? Well, there are many positives attached to CKRT, and a superior volume control, as is seen in this picture, is one of them. Well, intracranial pressure changes is the first thing which comes to mind. The moment you come across a patient with acute brain injury, a massive IC bleed, or a liver failure, the first thing which comes to mind in a patient who is hemodynamically unstable is the CKRT, because of very little chances of significant intracranial pressure changes when you put these patients on this modality of treatment. Well, these are the classical indications which you would always keep in mind when you are wanting to put your patient on CKRT. We are all familiar with what any kind of dialytic support will do to the potassium control, the acid control, acidosis control, and the kind of volume balance you can achieve, especially in patients who are oligoanuric. But there are specific indications when it comes to CKRT, and when you want to treat severe dysnatremias, be it hypo or hyper, that's something which comes to your mind. Intracranial hypertension, as I said a short while ago, cardiopulmonary failure requiring especially ECMO, the first thing which comes to mind is CKRT as the additional support. And of course, when it comes to organ support in patients with more advanced heart or liver disease who are definitely unable to tolerate intermittent HD, you would keep CKRT as one of the specific indications in these kind of patients. Well, also in patients who require a continuous solute removal, especially in the cases of malignancies where you have high cell turnover or cell lysis like rhabdomyolysis, you would want to put CKRT as the preferred modality of treatment. And another very peculiar indication, when you have done a challenging task of subjecting a patient of primary hyperoxaluria to a combined liver and kidney transplantation, so many times you would want yourself putting your patients on CKRT for removing that extra load of oxalate till the time the system falls in place. Well, this is most important. This is why, because there is importance of timing of fluid replacement in CKRT. As we know, initially we pump in a lot of fluid in patients who came to you in shock state, and then there is a maintenance or a decelerating phase followed by equilibrium phase, and then finally mobilization. And this is what happens when you are putting your patient on CKRT as well. Well, timing has been controversial. We have a long list of various trials which have tried to address this issue as to when to start CKRT. But ultimately what we realized is it's your experience. It's that patient in front of you in the intensive care unit where you will use all your experience over the years to decide when to act. Too early may be bad, and too early, too late also is equally bad. So you have to be acting at the right time. And when do you stop? Again, the patient's clinical situation will tell you, now is the time to stop. Again, you need tremendous experience. It may look very easy, but then when you finally have to take that decision, you struggle at times. Whether you are wanting to give anticoagulation to your patient, again will depend upon whether your patient has bleeding tendencies or not. So, moving further, these are the typical trials which we have in mind, and just to recapitulate every nephrologist and critical care experts' knowledge about what we have learned, whether early is good or bad or late is good or bad. ELAINE and START-AKI typically took patients, enrolled patients who were in stage 2, and they compared these patients, especially with ELAINE, in those patients who had reached stage 3. They were surgical patients in ELAINE. And what these trials over the years have shown us is that early, except for ELAINE trial, which showed acting early in these patients who predominantly had surgical causes of AKI, was a good strategy, while all others said it doesn't make a difference. So what we have learned over the years is use your wisdom to not do it as a knee-jerk reaction. At the same time, do not delay it before it's too late. So this is what these trials have also shown. Well, the anticoagulation bit is important. So as I said at the outset, this is going to be an overview. All of us who have been using CKRT are well familiarized with what I am talking at the moment, and anticoagulation is certainly an integral part what we have to decide on a daily basis whether to give it or not. And the guidelines say wherever it's possible, use regional citrate anticoagulation as the modality of anticoagulation rather than the conventional heparin. Well, if you do not want to use citrate, if there is any contraindication to the use of citrate, as we'll discuss later, you may opt for both fractionated or unfractionated heparin, but try to avoid other kind of anticoagulants. Well, we also are familiar with what can go wrong if we are using regional citrate anticoagulation and are not familiarized with the nitty-gritties and what all can go wrong. As you can see in this slide, if there is an excess buffer from citrate, you can expect a total calcium ratio of total calcium to ionized calcium to be less than 2.5. The same ratio will be less than 2.5 even when there is an insufficient buffer, as you can see in the lowest panel. But the treatment is different, because on one hand, if you give excess of citrate, either you are giving it and obviously there is going to be conversion of citrate into bicarbonate, you can expect metabolic alkalosis, and you will actually find yourself reducing the blood flow rate and probably reduce the buffer concentration in other CKRT solutions. While the important thing here to remember is that if there is an insufficient buffer from citrate, that means you are not able to provide adequate citrate supply. Again, you will find a ratio less than 2.5, but in stark contrast to the first scenario, you are finding metabolic acidosis in this scenario, and you would want to increase blood flow, you would want to decrease dialysis rate and increase the buffer concentration. So those who are familiar with usage of regional citrate anticoagulation are, I'm sure, quite familiar with the kind of challenges we face on a daily basis. Now about the use of vascular access, this is very important. We are all familiar with what we normally do, right jugular as the first choice, followed by right femoral, left internal, left jugular vein, and the last choice would always be a subclavian. This is what we have learned over the years. Typically 11 to 12 French size of the catheter, but if you have to remove carbon dioxide extracorporeally, maybe you would want to go in for a wider 14 to 16 French catheter. Now, which modality? Now again, when you say CKRT, the first thing which comes to mind, it's convection as opposed to diffusion, unless you are going in for CVVHDF, which means it's a combination of diffusion and convection. But what is the modality you choose? Always treat them as complementary to each other. So many times you'll find yourself shifting from one to the other as and when the clinical situation changes. And the recommendations by KDIGO are to use CKRT rather than intermittent in patients who are hemodynamically unstable. And that's the essence. That's why we are talking about CKRT. So again, when it comes to acute brain injury and other causes, and I think this is what I and Dr. P.K. Rai were discussing when Dr. Rai, who seems to be a little busy at the moment, when we were talking about the kind of topic he had in mind for me. So this is one particular area which we concurred that we think about CKRT the moment patient of liver failure comes to us, hemodynamically unstable and having some kind of intracranial edema after bleed. Well, you would rather be finding yourself using bicarbonate than lactate, especially in a patient who has circulatory shock, severe shock, and has already evidence of lactic acidosis. And you should make sure that you conform to the Army standards when you are looking at the sterility of the dialysis fluids which you are taking. The dose, typically, we all know something like 3.9 of KT/V on a weekly basis. But when it comes to CKRT dose, we have realized that 20 to 25 is good enough. We don't have to really try and achieve more than 35 or 40. But to be able to achieve 20 to 25 and taking care of the downtime, time lost and so many other factors, you would typically want to try and keep it between 25 and 30 to take care of the necessary stoppages in between. So what we have realized is more than 35 doesn't offer you anything better. Be happy with what you are able to achieve if you are able to deliver an effluent volume of 20 to 25 ml per kilo per hour. So this is the dialysate flow rates. As you can see here, when it comes to CVVHD, which is diffusion, you would be more interested in increasing the volume of dialysate, and you can actually expect some kind of increased solute clearance. But when it comes to hemofiltration, as you can see in the lower panel, the solute clearance with CVVH, it depends upon the effluent volume. So when we are talking about CKRT, you all know that we talk about CKRT. I think Dr. Manoj, Dr. P.K. Rai just informed me he had given me 5 extra minutes because of the time lost initially. So maybe I think he'll stick on to his words. So I'll need just about 5 more minutes. The ultrafiltration, as you know, is important. As you can see in this chart, what is ultrafiltration? It's the difference, the net ultrafiltration is the difference between ultrafiltration minus what we have actually given, the replacement fluid and the dialysate volume. And what is important to remember here is that if, as you can see, the net ultrafiltration rate is less than 1 or is more than 1.75 milliliters per kilo per hour, which means typically about 60 ml to 100 ml per hour, that's the safe range. Less than that is not good for the patient. More than 100 in a typically a 60 kilo patient is again not going to be a good news for your patient in the long run. Appropriate blood flow rates, we all know in the setting of CKRT, you would want to. Now remember, this is for the young impressionable minds if they are here or logged on to us via YouTube. Remember that the rule is you would want to keep the blood flow rate 2.5 times more than the dialysate rate so that you allow effective exchange at this point in time. If it comes to CVVH, you probably would want to keep in the pre-filter state blood flow rate of more than 6 times the dialysate rate. the substitution fluid rate. And when it comes to post filter, 5 times more than the substitution fluid rate. So what are the factors which affect the filter life? Well, the access is important and the circuit. Now in the circuit, if you have employed CVVH-DF or CVVH-D, it definitely is preferred modality because there are 44% chances that the circuit will clot, less likely to clot as compared to CVVH. And of course, the type of catheter which you use, and of course is equally important is the dose. You keep the blood flow at a higher rate, you give a higher dose, and you do not ignore the kind of ultrafiltration rates which have been advised. You will probably find the filter life to be significantly improved. And these are the factors: a lower pH, a higher APTT, and when you mobilize these patients, these are the ones which can have positive influence on the filter life. While if your patient has elevated fibrinogen and platelet count and is requiring transfusion as a higher SOFA score, you probably will find the filter getting clotted earlier. Now, what are the potential applications? AEIOU is what is easy to remember. Acidosis, where typically if pH is less than 7.1 or bicarbonate less than 15, electrolyte imbalance, as we have already talked about. Intoxication, we all know that for intoxication, intermittent hemodialysis would be better, but so many times if patient is hemodynamically unstable, maybe you would want to employ CKRT in these patients. Volume overload certainly is taken better care of if you have employed CKRT in your patients. And of course, the uremic, the manifestations in the form of encephalopathy or pericarditis. Now, a word about sepsis. We all know what sepsis is. Well, just to conclude that CKRT use should appropriately support different organs like kidney, liver, lungs, heart in hemodynamically unstable patients with septicemia, especially in the intensive care unit, because we believe that CKRT may better facilitate recovery of kidney function as opposed to other modalities. Well, in cardiac surgery, there's a term now, cardiac surgery associated AKI, and based on the different definitions, the incidence is something to the tune of 20 to 30%, depends upon the time on cardiopulmonary bypass, and it is a recommendation that if you use KDCO-based AKI bundle, you can expect a significant reduction in the AKI incidence. So that's a good thing for the cardiac surgeons. And this is a very recent article in JAMA which says that the use of non-selective extracorporeal blood purification devices, if you have used in the cardiopulmonary bypass circuit, this is going to be a good news for your patient, especially causing a significant reduction in AKI in the first 7 days. Now, AKI can cause respiratory failure, and on the other hand, ECMO, whenever you employ ECMO, and we find ourselves using ECMO more and more often, especially those where the facility is available, ECMO can cause AKI for the various reasons, as you can see on this slide. For the paucity of time, I'm slipping. But coming to something very important, which we are called as nephrologists very often to address the issue of liver failure, AKI in liver failure, and that's we know because of the renal hypoperfusion and so many things which are quite peculiar to patients with liver disease. You will find it a struggle to adequately treat them, optimally treat them. And it has been shown that CKRT is the preferred modality of treatment, at least in this subset of patients. It certainly gives rise to a significantly lower incidence of intracranial hypertension. And again, it is no different when it comes to treating and meticulously treating your patients with a very significant dysnatremia, be it low or a high sodium value. We all know that if you pump in too much of fluid, it is not going to be a wise decision, a wise thing to do, because you may end up seeing your patients in fluid overload, and CKRT offers an advantage where you can actually very fine-tune the volume status of your patient. Now, the problem is the hemodynamic instability, HI, which is associated with KRT. Now, what it depends is, there's a fluid in the third space, and the moment it comes back into the intravascular space, there's going to be a plasma refilling. Now, this and the difference between the ultrafiltration rate and the plasma refilling is going to decide whether your patient becomes hemodynamically unstable or not. Please do keep this entity in mind when we are optimizing support, the extracorporeal support to our critically ill patients. So to conclude, ladies and gentlemen, many ICU patients are, as we all know, hemodynamically unstable and develop multi-organ failure, typically AKI as well, and require extracorporeal support. Sepsis is certainly the most common cause and something which we always struggle with, and we take pride in the fact that we as nephrologists are always looked upon as the saviors as far as this particular condition when sepsis gets complicated by AKI is concerned. AKI is an independent risk factor for respiratory failure, and vice versa when you use ECMO in these patients with 2 to 3-fold increased mortality when one complicates the other. And of course, to conclude, management involves treatment of the underlying cause, thorough through timely administration of medications and appropriate use of KRT modality, appropriate fluid resuscitation, appropriate is the key word here, and a lung protective or support devices. So KDIGO, no doubt, rightly so, I would reiterate, recommends use of CKRT in hemodynamically unstable patients as well. CKRT modalities can be used in different situations, and I hope over the last 15 or 20 minutes I've been able to press home the point that it is certainly a very useful modality, and we should keep it away from the unnecessary controversies which it has found itself mingled in over the last so many years, ever since we started using CKRT in our country as well. Thank you very much for your patient listening.
Thank you, Dr. Kohler, for summarizing the issues in the management of acute kidney injury and CRRT in ICU. So in the paucity of time, so maybe we don't have much time for question and answer. So we may close this session here and request the organizers to take over from here.
Thank you very much.
Can I please request the faculty to come on the dais for the felicitation? I'll request Dr. Hemant Kumar sir to please felicitate our chairpersons and speaker. Thank you, faculty. So with this, we are moving ahead with our 7th session, which is transplant in complex scenarios. And I welcome and invite our chairpersons on the dais. I welcome Dr. Pradeep Kumar Dole, Professor, Nephrology at JMCH Guwahati. Dr. Praveen Pandey, Head and Chairman, Urology, Robotics and Renal Transplant at Chandan Super Speciality Hospital, Lucknow. Dr. Jitendra Pratap Singh, Chairman, Urology and Renal Transplant at Chandan Super Speciality Hospital, Lucknow. Dr. Aditya Sengar, Consultant Urologist, Uro-Oncologist and Kidney Transplant at Precision Urology Hospital, Lucknow. Dr. Veincon Jha, Professor, Nephrology and Transplant at Sri Ram Murthy Samark Hospital, Bareilly.
Good evening. It's good to see we are getting geared up for the evening, and I keep this session reserved for a really hot topic. We have been speaking about AV fistula, interventions, plasty, and I thought, yes, vascular does involve transplant as well. So why not talk about some complex scenarios? So what we'll do, looking at time also, so we have 2 speakers and one of our resident from department. So Dr. Naila will be setting up stage by putting 2 different case scenarios about renal transplant and aortic either anomaly or pathology. And then we'll be moving on to the first talk, which is by Dr. Jason Chuan. It's an online talk. And then Professor Anand Kumar could not make it here, but he has sent his, he is right now in Ayodhya, so he cannot attend on phone, but he has sent his pre-recorded entire talk, so we'll be running that after that. So, Dr. Naila Khan.
Good evening, everyone. My name is Dr. Naila Khan, and I'll be talking about 2 interesting cases of aortic pathologies associated with renal transplants. First of all, the 3 main types of pathologies that can be seen in aorta, as we all know: dissections, aneurysms, and occlusions. The treatment guidelines are beyond the scope of our discussion today due to the time constraints. So here is the first case. The first case is of a young patient who happens to be a kidney donor with a considerable amount of tortuosity, or as we say, a tortuous aorta with no atherosclerosis. Here is the further imaging for it. Now the second case is of a 39-year-old female patient with end-stage renal disease secondary to hypertensive nephropathy. She was on continuous hemodialysis via left brachiocephalic fistula for almost 3 years and was also planned for a kidney transplant, and was also on continuous monitoring for central venous hypertension. However, she soon presented to us with back pain, which she had almost had for 2 weeks, that had gotten worse in the last 2 days. On further imaging, that is a CT angio, it was found to be an acute type B aortic dissection with a severely narrowed true lumen. Following this finding, her KTP was put on hold and she underwent a TVAR, that is a thoracic endovascular aortic repair. A TVAR was done, and it involved a covered stent and a bare metal stent, which was put in across the distal thoracic and the proximal aorta. proximal abdominal aorta to ensure adequate expansion of the true lumen. 6 months post-GVAR, she successfully underwent a kidney transplant. Now, 2 years after the transplant, a follow-up CT angio has shown an aneurysmal progression in the abdominal aorta's false lumen, which currently measures about 4 centimeters in diameter. And this further requires further management and planning to get the desired outcome. Therefore, this opens up a topic for us to discuss about. What all precautions need to be taken for patients undergoing renal transplants who have had a previous history of aortic diseases? And also, what all can be done for them when 5 years or 10 years down the line, they develop any aortic complications or any recurrences of their previous pathologies? Therefore, I'd like to open the stage for the discussion on it and would request the speakers to give their insights. Thank you.
So aortic pathology is interesting. So I'd like to invite Dr. Jason Chuen. He's a director and vascular endovascular surgeon at Austin Health, Heidelberg, Melbourne. He's a unique blend of vascular surgeon being a transplant surgeon, because that's slightly different from Indian, because of here the mainly urology practice is being done. And as a part of vascular surgery, we, internationally, the treatment of aortic pathologies, as well as transplant, what he does. So let's see what he has to say, what we achieve in India as a team approach. So over to you, Dr. Chuen.
Thank you very much. I hope you can hear me. If you can, I'd just like a bit of confirmation, maybe a round of applause or something.
Yes, loud and clear.
Okay. All right. So thank you very much for inviting me to give a talk at your esteemed meeting. I'm testing the limits of technology here. So please let me know if there's any issues. I'm sorry that I couldn't see those case presentation slides in real time, but after my talk, I'll have a chance to have a look at those images and then hopefully contribute to the discussion. So I've been asked to give a talk about renal transplantation as a vascular surgeon, and I'll perhaps say that the relationship between vascular surgery and transplantation has been a mixed and complex one in Australia as well. I don't think that that is too different to what you're experiencing in India. But I do have to give perhaps a quick disclosure, which is that in technical terms, I haven't received a formal fellowship in transplantation. And you could really say that I'm a bit of an imposter. The training program in renal transplantation surgery and transplant surgery in Australia has moved along over the course of many years. And there is a Transplant Society of Australia and New Zealand, which now has a formal training program. But that didn't really extend or exist when I first started getting involved in this. And in fact, I went through my entire vascular surgery training without doing any formal cadaveric renal transplantation procedures. And in fact, my first job as a vascular surgeon consultant, I was asked and offered a full-time position including renal transplantation. I turned it down because I felt that I wasn't qualified. And I moved from Sydney to Melbourne, and in Melbourne, after I commenced my role as a specialist vascular surgeon, there was a shortage of renal transplant surgeons at the hospital I was working at. And they turned to the vascular surgery team and said, would you mind joining the roster? And I said, well, I've never done a kidney transplant before. And they said, that doesn't matter. We'll just give it a go. And if you have any problems, we'll be here to back you up. And after, I think, my second case, they said, that's it. We don't need you to stand here anymore. And we'll let you take care of it. So I'm probably a bit like this zebra amongst the crowd of horses. I don't know whether I really belong here or not. In any case, it's not really about who the surgeon is. It's not about me. It's not about you. It is about the patients. And this is Lionel. He was our first live donor renal transplant at Austin Health in Melbourne. And this was performed in 1975. His sister donated her kidney to Lionel. He was a phlebotomist who worked in Malaysia, and he was actually turned down for a kidney transplant in Singapore and travelled to Melbourne, Australia to have his transplant. And we had the pleasure of Lionel coming to visit us earlier this year, 49 years after his transplant, and he is doing exceptionally well. And we need to keep that in mind when we're treating our patients. So just for a little bit of friendly rivalry, I will sort of highlight some of the differences between Australia and India from a transplant perspective. Now, the difference is really quite vast. I mean, Australia has a population of 27 million, and the population of India is about 53 times that of Australia. The area is actually half that of Australia, and as a result, you have a population density that is far greater than that that we experience in Australia. And that's probably quite difficult for you to imagine, but you may notice from that map that the transplant centres, and that reflects the population centres in Australia, are really centred around the coastal areas. And there isn't a lot of population in the centre of Australia, so there's a large area which is unoccupied or unpopulated. We have half the number of transplant centres that you have, and the number of kidney transplants that are performed in Australia is far behind what you do in India. So again, perhaps like a zebra amongst a flock of sheep, I don't really know why I'm here talking to you about kidney transplantation when India probably has such a large experience. But what we do notice is there is a significant difference in where these kidneys come from. So in India, the vast majority of kidney transplants are live donor transplants, whereas that is uncommon in Australia. We don't have this strong driver for living donor transplants, and we rely really very much on not just altruistic donors and deceased kidney donors, but our growing paired and domino kidney exchange program. There is a bit of friendly rivalry that will still happen, and I believe that the test is going to be held in Perth in a few weeks' time, so I will leave that alone lest I start a fight across the oceans. So this reflects the activity in terms of deceased kidney transplantation in Australia, and like every other country, there was a significant dip during COVID, and I think that was experienced in India as well. In terms of our hospital, We have a very sort of robust and mixed experience in terms of the physicians and clinicians that are delivering renal transplantation. We don't tend to have one transplant surgeon or one transplant doctor who takes care of everything. So we have a very much a team approach. Even our nephrologists, they sort of present themselves in different ways as transplant physicians or immunologists or nephrologists, but by and large, we have settled to a core team of renal physicians who have this overarching experience of managing the workup side, the matching side, the immunological side, and the postoperative care side of transplantation. As I mentioned, the person performing renal transplantation at our hospital and in many cases around Australia has changed over time. So originally when transplant surgery or kidney transplantation was done, it was done as a team between a general surgeon, a vascular surgeon and a urologist. And in fact, that's reflected in our remuneration schedules in that there is a separate payment for a transplant surgeon who is a urologist and a transplant surgeon who is a vascular surgeon. And there is a payment that goes to each of them together if they're operating to perform a renal transplant in the same operation. But we also see that the experience in renal transplantation is sometimes used as a stepping stone for other forms of transplantation. So, for example, it is not uncommon that a liver transplant surgeon starts out getting their training and their fellowship in or based on renal transplantation rather than going directly into liver transplant surgery. And we talk about the level of training. So the Transplant Society of Australia and New Zealand actually differentiates between what we call a type 1 and a type 2 transplant surgeon, where a type 1 transplant surgeon has a much more comprehensive training and background in transplant immunology and transplant physiology. And a type 2 surgeon generally is more focused on the technical and the surgical delivery side without taking on that sort of medical and other roles, which means that the type 2 surgeon sort of forms the backbone of roster delivery and service delivery, whereas a type 1 surgeon will generally take on more of a leadership role. Transplantation is a very complex area. It needs to have a lot of focus points. There isn't really a way that you can just walk up to a hospital and then build a transplant program overnight. You need to make sure that you are able to address all of the areas that allow a transplant program to be successful. And they include where your donors come from, so both cadaveric and live donors. They involve how do you manage the transition of a potential recipient and their work up to a waiting list, and then the prioritization, the matching, and the triage of those patients and the organs that become available. Organ harvest for transplantation is not a straightforward thing, especially when you're harvesting not just for kidneys, but also for hearts and livers and lungs and pancreas and intestines now. And the way that that's done really requires a specialist surgeon, both in terms of the live donor harvest and the deceased harvest process. And the involvement of our intensive care specialists and emergency physicians in this process is absolutely essential. There is a growing process of organ preservation, perfusion and transport with our hypothermic and normothermic transport systems. and the psychological and emotional aspect of all of the need to have both coordinators who are experienced in that social support side, as well as the administrative support of all of the moving parts that allow a transplant to happen is absolutely essential, as well as the nurses, both on the wards, in our outpatient clinics and in the community. So why does vascular surgery need to be there? Well, you could make an argument that with an experienced enough team with a wide enough range of expertise that the vascular surgeon doesn't have to be there all the time, but there will always be times when a vascular surgeon will be called upon. And it's very rare and probably almost impossible to guarantee that you have a sustainable and self-sustaining transplant expertise without supplementation from other specialties. So a transplant surgeon doesn't come out of nowhere. They have to come from somewhere, and that somewhere may well be general surgery, it might be hepatobiliary surgery, it may be vascular surgery, or it may be urology. So even if you have a functioning transplant training program, the people who feed into that training program have to come from somewhere, and you will never have enough surgeons to meet the demand that is required of transplantation. And that's especially true if there is a transition or a growth in the donation of kidneys. And that might be live donors, or it may be cadaveric donors. But if, for example, Australia switched from an opt-in system of organ donation to an opt-out system of organ donation like in Spain, the number of transplant surgeons you would need overnight would dramatically increase. There would be no hope of training those people within a reasonable time frame, and so the need to rely on a pre-trained workforce is essential. In addition, leaving out the immunological side of things, operating on things like renal artery aneurysms and performing autotransplantation is a core part of vascular surgery, and we still consider that to be something that a vascular surgeon should be capable of. And whilst not all vascular surgeons will come through their training having done one or more autotransplants, it is something that is part of our core syllabus and needs to be preserved. The other thing is that we find the recipients that are getting transplants are now becoming more and more complex. They're becoming older, they're becoming more comorbid, and the skill set required in extending transplantation to those people is broadening. So as vascular surgeons, we take pride in being able to plumb anything to anything else. Whether that's a good idea or not is a different matter, but there are times when patients will be put forward for transplantation that require that sort of additional vessel preparation, such as endarterectomy, patch angioplasty, or otherwise. The donor pool is also something that we always struggle with. Unless there is a dramatic increase in the number of donated live kidneys, then we're reliant on deceased kidney donations. Nobody wants more patients to die in order to donate a kidney. So of the kidneys that you get, how do you ensure that as many of them are usable as possible? So again, that requires an expansion of skill set and perhaps some degree of inventiveness in terms of how they're plumbed in, but also the development and the utilization of advanced techniques. It doesn't necessarily make sense to have a transplant surgeon who is trained in all of those techniques, especially if you're in a hospital that has a vascular surgeon on site. And we may as well tap each other on the shoulder to help each other out. After transplantation, there are also always going to be issues either with the anastomosis or the transplant artery and vein, or with the progressive atherosclerotic disease that these patients will also get, and the impact of having a kidney on an outflow limb that is compromised in the first place. So there's lots of places where a vascular surgeon can be involved and lend our expertise. And these are the very common issues that we would encounter in our discussions, in our meetings, about assessing whether a recipient is suitable or not, whether a donor organ is suitable, and how do we optimize and maximize the success of that transplant, and then dealing with all the issues that can arise post-transplant. And just to very briefly run through the kind of cases that we discuss between us, even just over the last few weeks, it's not uncommon to have patients who have transplant renal artery stenoses picked up on duplex ultrasound like this. And imaging them can be extremely challenging. You obviously don't want to put them through a high contrast load CT angiogram, so we try to work out how we're going to image this with whilst putting the kidney under the least amount of contrast strain as possible. And this is very difficult, especially because the anatomy of these transplants is always a bit unfriendly to imaging. Everything is overlaid in ways that aren't sort of normal anatomy, and we have to sort of pull out all the tricks in the book in order to make sure that we can identify what is going on. And that might include selective angiography, it might include being actively involved in the imaging of these. So when you are doing an angiogram, you have to have how you're going to manage and treat this in mind when you're acquiring the images. It's very difficult to just send a request form off to a radiologist and say, please image this kidney, because they won't necessarily show you what you need to see. In addition, sometimes you have to undertake empirical therapy at the time, and so having someone with the open endovascular and salvage skills to deal with the problem if there should be, say, an acute hemorrhage on table, for example, is very important. And even sort of cases like this of a patient who has had renal transplant, and on the table we discovered that they had a small hilar aneurysm that we elected not to treat. They need ongoing surveillance. And how do you image this? How do you confirm what's going on? And how do you make sure that you can continue to survey this over time? And how do you differentiate between whether this is just some tortuous anatomy or whether this is a true aneurysm? These are things that require an advanced understanding of vascular anatomy and vascular pathology. And yes, it can be acquired by a transplant surgeon with a lot of experience over time, but there are also specialties within your sort of major hospital that already have this experience and knowledge, and why not make use of that? And this, I think, sounded a bit like one of the cases that has been put up, but this was a case that we discussed last week about a patient with a previous type A aortic dissection that had been repaired and put up for kidney transplantation. Having a dissection that extends down one leg makes it challenging, and the other leg is supplied by a false lumen as well. We have to think about not just what are the technical issues involved with transplantation, which vessel can we access, which one can we put a kidney onto, but what is the flow in that vessel, and how do we assess the flow beforehand, and how do we assess it afterwards? And how does that impact on our long-term management of this patient? Because they may well need intervention for their type B aortic dissection at a later stage. We have to keep in mind whether that's going to be an open or an endovascular repair. Everything that you do to this patient will limit their options in the future. And as vascular surgeons, we're constantly teaching and training our trainees to always have a plan B and a plan C and a plan D. And if you aren't involved early on in these cases, then your plan A, B, C, D, E can all disappear in a heartbeat, and you are left with no treatment options for a patient like this. And this is another case that we had discussed last week, and this is becoming a bit more common, is that there is now an increasing ability to treat patients with iliofemoral DVTs, and a sort of an exuberant willingness to put in stents in these patients. So even though this patient didn't have any arterial pathology, they were prothrombotic with antiphospholipid syndrome. They were anticoagulated with a mitral valve replacement, and someone who wasn't familiar with these types of stents and what was in place would have put a stent across would have put a clamp across them and essentially crushed the vein and crushed the stent. So this type of case requires a lot of investigation, a lot of understanding and consultation in order to plan out exactly what the sequence of events will be when they do, or if they do come to having a renal transplant. And that's leaving aside all of the patients who are put forward for donation or transplantation who happen to have other vascular pathology, such as splenic or visceral artery aneurysms and fibromuscular dysplasia. And then there's a smattering of sort of biopsy-related trauma to these vessels which need open or endovascular embolization. So it's tempting to think that a vascular surgeon can sort of waltz in and take over the entirety of the whole transplant process, and all we need to do is learn a bit of immunology, but that's not really the case at all. Delivering an effective transplant program requires a whole lot of teamwork. It requires embracing the knowledge and the expertise and experience of your colleagues, and making sure that you share your knowledge and that you work together to make sure that you deliver the best outcomes for your patients. So these are my tips, which are to know what you can and what you can't do. So that's not to say that another specialist coming along might not have these skill sets, but I certainly don't pretend to be an immunologist, a urologist, or a nephrologist. Make sure that you collaborate and share your work with other people, because helping others is how we help patients. And the other thing is that as vascular surgeons, we deal with a lot of patients who are nearing end of life. We're dealing with a lot of patients with untreatable vascular disease or progressive vascular disease. We're treating patients who are facing decisions around the futility of care. And somebody has to be holistic and have that overview about whether or not putting a patient through the transplant workup process or giving them a transplant is really a good idea. Sometimes giving patients futile hope can actually be very much not in their best interests. And each member of that team needs to be able to make that call. So I will always be prepared to humbly offer my opinion, and that the other side of that is that offering an opinion also means you have to listen to other people's opinions and then work out a compromise where necessary. So I will end my talk there, and thank you for listening to me drone on from Australia.
Thank you, Justin. That was an excellent talk. A quick question. Did it get disconnected? Okay, so we have, okay, yeah, you're here back. So, quick question. How much aortic disease progression you see? Because those patients, you said you have a patient which is like on 49 years post-transplant. So you will have some idea about patients who have had renal transplant and developed the aortic pathologies later on. So like somebody has developed aneurysm. So one concern is always using the contrast-induced, the interventions. So how do you plan it? You go all endovascular, or you see the kidney status, this single kidney, or you add something like IVUS or something? Any comment on that?
Look, we've had an extraordinary shift and change in medicine over the past few decades. If we went back sort of 20 or 30 years, we did not have the luxury of doing even CT scans or ultrasounds as freely as we do now. I would say that even though we have kidneys that sort of function extremely well, there's always a reluctance to put them at risk. And that involves not just contrast imaging, but also biopsies. Every time you biopsy a kidney, you risk damaging and losing that kidney. So we rely heavily on non-invasive duplex ultrasound to assess these kidneys. And that's a very sort of fraught area sometimes because the anatomy is not straight. You don't have nice straight vessels like in normal renal arteries. These vessels sort of go all over the place, and they're in areas where the sonographic windows are challenging. So you have to make use of that. IVUS was not readily available until recent years. It is something that we even sort of in a place like Australia, IVUS is an expensive proposition. For 1,000 Australian dollars a case to use an IVUS catheter, is it really worth it? I think I've probably opened an IVUS catheter probably about 5 times over the past 5 years in these patients, and afterwards I've sort of wondered whether it was really worth it. But what I do think is that a selective angiogram is often much lower contrast than a CT scan. And the advantage of being able to use a selective catheter and a 3D spin to do a Dyna CT or a helical CT spin on the table with an angio machine gives you a lot more information than we used to be able to obtain. And the other thing we can do, and which shouldn't be overlooked, is pressure measurements. Pressure measurements are hugely useful in the assessment of these without giving contrast.
Well, thank you. Any questions from the session or chairpersons?
Okay, can I have one question?
Yeah, please.
Obviously. So, Dr. Jason, thank you for your lucid presentations. I have one question for you. Suppose a patient who is waiting for your renal transplantation, and at the same time, while on a routine evaluation, the patient had a aortic aneurysm, which is impending rupture, right? So in that case, how that transplantation can be done? So what is your approach in that case? Whether you should go for transplantation even in presence of aortic aneurysm or not?
So if I hear correctly, you're talking about a hypothetical patient who is on a waiting list for renal transplantation and has a ruptured aneurysm, is that right?
Yeah. Yes.
Yes, yeah.
Yeah, look, I mean,
or even may not
I
be
think
ruptured,
that
you've just diagnosed patient who was on transplant list or getting planned, and then you also found that patient has like 7 centimeter unruptured aneurysm, right?
Look, I think that perhaps we're overthinking things there a little bit. I mean, the fact is that if we take the scenario of someone who has a ruptured aneurysm, then they need to survive the night. And if they don't survive the night, then it doesn't matter whether or not they're ever going to get a kidney transplant. So you treat the aneurysm, you do whatever it takes to get them through this hospital episode, and then you think about what you're going to do with renal replacement therapy.
I think the question was, will you consider doing aorto bifem or like aortic aneurysm repair and transplant together, like in an elective aneurysm?
Absolutely. Well, in a rupture scenario, absolutely not, because that patient's...
Not in a ruptured scenario, but say if you have an aorto biiliac occlusion or aortic aneurysm, okay? And in this case, if patient's also been planned for transplant, will you consider doing the aorto bifem as the procedure along with the renal transplant, or you would prefer to stage it, right?
Look, I would very much prefer to stage something like that. Obviously every patient is different, and you've got to think about what the scenario is. But for an open operation, any kind of open aortic procedure, these patients will have significant cardiovascular physiological changes afterwards. And you only need someone to drop their blood pressure moderately after a transplant for that to thrombose, and inotropy will just play havoc with a transplant. For someone with occlusive disease, you would try your best to preserve the iliac arteries as a destination conduit for subsequent transplantation. So you stay out of that area. For an endovascular procedure, you have to think about where are they going to clamp for a transplant in the future, and you try to make sure that your stents stay clear of those areas.
Well, thank you, Jason. It was great hearing from you, getting this perspective. Thanks a lot. I think it's already past midnight for you. So thank you. Thanks a lot.
You're welcome.
Next, we have actually a pre-recorded video from Professor Anand Kumar sir. He couldn't make it, but on the same scenario and totally different Indian perspective, and Dr. Dinesh is here, he will also probably share the patients. So we are going to play his video, pre-recorded talk. Can we have it?
plain CT orthopedic vessels. And then we get the idea of how is the atherosclerosis. If need be, we do the CT angio or give the contrast. And then we decide if we have to do atherectomy. Then it is very important once you do atherectomy in the external iliac vessel that you must fix the intima distally. Otherwise, there will be dissection. And whenever you, after similar rates of survival with experienced vascular surgery. Thank you.
So do we have any questions?
There will be no question. Yeah, it's already recorded. Okay, please, yeah.
So it was a very nice presentation by sir. We all have been students, and we are just a club and current looking at him doing surgeries and learning from him from distant places. So one must be very careful in selecting such cases because it all depends upon your learning curve, at what point of your career you are, and more and more transplant centers are coming up across the country. So in such cases, one should be careful about the systemic nature of the disease as well, because there are certain progressive vascular diseases and they can lead to compromise of the graft itself. So that must be kept in mind. Plus the orthotopic kidney transplant, yes, it's a very good viable option, but one has to be very, very lucky that if it's a diffuse disease involving both the common iliac arteries and the external and internal iliac arteries on the both the sides, and the aorta and the renal artery on the particular area is normal. So that has to be kept in mind. So yes, it is possible people are doing, and we should be aware of this so that we don't reject such patients and we keep on expanding the pool for transplant.
Okay, sir, it's on. Okay, sir, please proceed.
Since Dr. Anand Kumar is not here, I'm not a surgeon, I am his nephrology counterpart, and I just wanted to share the kind of amazing surgery this team does. And I think what you just witnessed is just one aspect of what this surgical team, the kind of amazing work they do, and doesn't come as a surprise. So if you have a great surgeon by your side, I think it's a great boon for any nephrology team not to be bothered at all about what kind of surgical challenges are thrown at them. So I would take this opportunity to thank my surgical counterpart for the amazing work. He wanted to be here. I think he was engaged in some other plan engagement, so he could make it in person.
Okay, if no more questions, the session will be closed.
Thank you. Can I please request Dr. Dinesh Kulla sir to felicitate our chairpersons? Thank you, Chairpersons. So with this, we are moving ahead. Well, it is indeed my honor and privilege to welcome you all to the prestigious Professor P.K. Srivastav Memorial Oration. For the same, I would like to invite and welcome the chairpersons in the dais. I welcome Dr. J.P. Ojha sir, Dr. A.K. Singh sir, Dr. Hemant Kumar sir, Dr. P.K. Rai sir. I'll request everyone to please join us on the dais.
Good evening. Good evening. This is the very prestigious oration in the name of Professor P.K. Srivastava. He is Pramod Kumar Srivastava. A brief introduction about Professor Srivastava. He was born in Ghosi Tahsil of Mount district on 20th April 1930. His primary education was from Jubilee Inter College, Gorakhpur. Then he did graduation and post-graduation in internal medicine from KGMC, Lucknow. He wanted to become a pediatrician, but he was more impressed by his father. His father, Sri Maya Prasad Srivastava, was the principal of the Jubilee Inter College, Gorakhpur. So he decided to become a teacher, and he became teacher. He joined Department of Internal Medicine, College of Medical Sciences, Banaras University as a lecturer, and where he was promoted to reader and then professor. Director of Institute, Professor K. Rupa, requested him to develop the department of nephrology. He accepted. And then he got training in nephrology from United Kingdom at General Infirmary Hospital, Leeds, under Professor Parson. On return from England, he started division of nephrology in the Department of Internal Medicine, and very initial stage hemodialysis, peritoneal was started, but he was not happy. He said that nephrology without kidney transplant is incomplete. But whatever he could do, he did it. The two aspects of his personality I must share with you. He was an exceptional teacher and caregiver to his patient. He used to say, I will be happy to serve poorest among poor. His personality was epitome of exceptional kindness, devotion and sincerity towards the patient. He used to say, if I reborn, I want to become a teacher, whatever, even primary school teacher is enough for me. He was an excellent teacher, a skilled clinician, and very careful caregiver. There are so many people described him, but one description I want to share with you. Dr. S.N. Thakur, Dean Faculty of Science, defined him as a rishi and a very kind caregiver. He was a brilliant teacher, clinician, researcher, singer, and poet. I think I don't find enough words to describe his personality. He took his last breath as Los Angeles County, USA on 3rd December 2014 due to undefined adenocarcinoma. At today's event, I pay my respectful tribute to great teacher and my mentor, Professor Srivastava. I think Professor P.K. Srivastava memorial oration was started under the collaboration of Nephrology Society of Varanasi and Department of Nephrology, BHU. The first oration was given at 4th November 2017, and first orator was Professor Amit Gupta. In this session, this oration was given by Professor Narayan Prasad. Narayan Prasad need no introduction. He is well known to all of us. Currently, he is professor head at Department of Nephrology, SGPGI Lucknow. I am very eager to listen this oration from Dr. Narayan Prasad. Without wasting my time, I am honored to invite Professor Narayan Prasad.
There is one alteration. Actually, the chief guest and the guest of honor, they have come, but our two persons as a chief guest and guest of honor, they have got some urgent work. That's why we will have to change this and reschedule the things a little bit. We will go for the oration subsequently. And Professor Sharma and Professor A.K. Rai, they have to go to attend some meeting. So we will go for the inaugural function first, and then we'll continue.
No problem.
Because
no problem. No problem.
That we can.
Okay, that's okay. No problem.
So we can start.
उसके बाद हम ऐड कर
So with a little change in program, as we prepare for the further inaugural part, I would like to run through some things, some achievements, little happiness, a few points which we have gone through and done over last 1 year. So as we know that renal transplant versus lifelong dialysis number is not to compare at all. It's huge discrepancy. We started a couple of years back, we started this tradition of recording the stories of our patients who are at the base of everything what we are, everything what we talk about, everything which we dream about. So these are some stories of some patients who have been fighting their individual own kidney fight daily. The purpose of making these videos are just to show that what is all they have to go through. It may be just a small thing for a normal person. So, and there are a couple of them. There's a song.
So meanwhile, till the dais is prepared for the inaugural function, we'll just have some talking, me and Himanshu, to all of you. So when we started in Varanasi, it was somewhere around 2000.
Good evening, everybody. As there has been some change in the schedule because Professor Alok Kumar Rai and Professor R.K. Sharma has to go and attend some meeting in the Lucknow city, and it is very important meeting for them. So we have just rescheduled things, and I invite the chief guest, Professor R.K. Sharma, to please come on the dais, and please sir, you are most welcome, and take your seat. Professor, now I invite Professor A.K. Rai, Vice Chancellor of Lucknow University, to please come on the dais and please take your seat, sir. Now I invite Dr. Ravi Elhens, boss, please come and take your seat. He is our guest of honor today, and it is really a pleasant moment for all of us to have Dr. Ravi Elhens here as the guest of honor. Now I invite Professor Amit Gupta sir to come, and he is already on the dais, and please take your seat, sir. He is the chairman of this Veincon 2024 this year, and I invite Professor J.P. Oja sir also to please come on the dais. May Dr. Devan, can you help him? And Professor M.K. Mitra sir, he is the senior most nephrologist of Lucknow and Uttar Pradesh, you can say, because when we were studying at SGPGI, a good number of people who are sitting here in the audience, they have been taught by Professor M.K. Mitra to become a nephrologist. He is the key person who ignited most of his students, those who did MBBS and MD from KGMU. And when I joined SGPGI in 1992 as a DM student, he was a regular visitor of our nephrology society, and we used to get enlightened with his experiences in nephrology. So As you all know that he is the most beloved and respected nephrologist and eminent nephrologist of the city, and most of the people here sitting here, majority of the people has been his students, and I welcome you, sir. And with these things, I invite all the dignitaries and to come for the lamp lighting as the inaugural ceremony of this Veincon conference. Please, I request all the dignitaries to please come forward for the lamp lighting. Dr. Mahinder and Dr. Himanshu, please come and join us.
Himanshu?
Please. Now, Ms. Paul, please come, and we are going to honor all the dignitaries with the bouquet and memento. Professor, yes, Professor Sharma, sir. Yes. Professor Gupta will honor with the bouquet of Professor Alok Kumar Rai, sir. Now, Professor Gupta will be honoring Professor, yes. Himanshu, please come and honor Dr. Himanshu, and Dr. Amen, please come. Please honor the Professor J.P. Ojha sir with the bouquet. And Dr. Himanshu, please come and honor Dr. Ravi Alhans with the bouquet. Yes. I request Dr. Himanshu to please honor the chief guest, Professor R.K. Sharma sir, with the memento. request Dr. Mahinder to please come on the dais and honor Professor Amit Gupta sir, chairman of the. Dr. Diwan, please come forward and honor Professor Mitra sir with the memento. I request Professor Amit Gupta sir to honor with memento Professor J.P. Oja, who is chief patron also of this Veincon 2024. Please. I'm really overwhelmed with the response which we have got from our dignitaries as well as the distinguished guests, and I do not have words to express my feelings. And in this function, I would like that Dr. M.N. Singh should come and he should speak few words regarding the conference, and subsequently we will invite our dignitaries to say blessings and best wishes for this conference. Dr. M.N. Singh, please.
Thank you, sir. And since there are 2 mics and 2 organizing secretaries, so I will like my other organizing secretary to be here with me. And it was
it looks like an IFI award ceremony kind of thing.
I will try something like that. So he gave me a topic, past, present and future. I was just thinking about it. So the past is always emotional, the future is always ravishing, the present is always ravishing and future is always exhilarating, I would say.
Yeah.
No? So we started all these things right from 2015. When we arrived in Varanasi in 2015, the problems were of some different sort. The most common access used to be the single lumen femoral, and the patients were not agreeing for double lumen uncuffed catheter even. So we tried a bit, we made a rule, okay, in any CKD patients, we are not even going to insert an uncuffed catheter. It has to be a permacath or fistula only. We faced a lot of resistance and problems. The fistula surgeons were a bit more rigid. They were not listening to anything, and it was like if the BP of the patient is 160 by 100, the patient used to get rejected from operation theatre that he is not fit and fistula cannot be made. At that time, Dr. Prashant Barnwal, who was one of our speakers, was there. And we did a lot of collaboration, but still many things were there that needed to be done, but we were not able to do it. So on one fine day, I just posted a message on what was it? Facebook. On Facebook, ki Himanshu, तुम्हारा call नहीं लग रहा है, where are you? So the reply came after 3 days. He said, boss, अभी US से लौटा हूँ, क्या काम है? हमको बैग तो पैक्ड है, कहता हाँ बैग पैक्ड है, हमको क्या, just take that bag and come to Varanasi. So he followed, because there was no place for him to stay in Delhi also. At least I have a home in Varanasi.
So actually, I have a more photographic memory of this entire incident. So I was in Mayo Clinic that time, और मेरा कुछ ना वापस लौटने का पक्का था नहीं कि कहाँ पे शुरू करूँगा. तो ठीक है, वापस जाके देखेंगे, कहीं ना कहीं तो जॉब मिल ही जाएगी. So उस बीच में it was around 1st or 2nd of July, और बॉस का मैसेज आता है. बॉस is what we call our seniors in BHU. So all those from BHU, they know it. So बॉस का मैसेज आता है, कहाँ भाई? मैंने कहा कि बस लौट रहा हूँ. कहता अच्छा ठीक है. मैं I landed on 7th. He said एक काम करना, तो कुछ केसेस हैं अभी, तो मुझे लगा और तो कुछ करने को है नहीं, तो आ जाते हैं. तो 8th of July 2016 हम दिल्ली से सीधे बनारस लैंड किया.
And in Varanasi, in one day, we operated 10 fistulas.
नहीं. So इसमें कहानी है कि मैं
And he was non-operating surgeon for last 1.5 years at that time.
पहले दिन हमने एक केस ऑपरेट किया सर. It was a very interesting कि एक बच्चा था. He had a bilateral radial and brachial arteries fistula made, and it has bursted and bilateral arteries are ligated. मैं भी थोड़ा सा नया था तो उसमें उसका था क्या, he had a good artery, good collateral, so उसकी radial artery palpable थी. So I actually went and made a redo radiocephalic proximalization करके, then I realized कि it was not working. So first day, first fistula failed. Then I went back and I realized, and then next day we came, and next day we did 10 cases.
And after that, it's just a counting. You do 10 a day, you do 15 a day. I don't know how come a surgeon can operate for 24 hours continuously and get a thrill out of that. But that was not the fact actually. The more important thing was how to transfer this same set of skills in other persons or other surgeons. So there was another person, Professor P.K. Rai sir. Anything that happens in nephrology in Varanasi, he is after that, he is behind that in some or other way. So in 2015, somehow sir made Varanasi Nephrology Society. We all were amazed. We thought, okay, we were just gathering in any talk and any scientific event. What's the need of a society? And after that, he didn't just put on. He just geared off. In every meeting, he used to push us, कि तुम लोग नए लोग आ गए हो, केवल पैसे कमा रहे हो, you are not doing anything good, you are not doing anything scientific. Sir, scientific करें क्या scientific? There is so much in science. We small Varanasi Nephrology Society just made up of 6 or 7 people at that time, sir. What we can do? What new we can do? We didn't have anything to offer. Because you are not using your brain. It was just like in every meeting, you are not doing anything, you are not doing, करें क्या? Then on one fine day we decided, okay, Himanshu, whatever work that we do in one single day, we are just going to post it online, and it will just be an online conference.
As I say, I have a better photographic memory. रात के 2 बजे कॉल आता है डॉक्टर महेंद्र की, यार हिमांशु सुनो एक काम करना है. So I think he has come back from the society meeting और उस दिन discussion हुआ था, ये ना कुछ करना है. तो he said कि एक काम करो, you think about this और कुछ बना करके दो. And then I am a person who sleeps late. कुछ रात में लिख करके I wrote down a program. सुबह WhatsApp पे it was back.
And it was the same program that we were doing every day. And we got Rishabh ji, one of the finest audio-visual. And what we did, just in the OT we put 2-3 cameras and the display downstairs. There was a perfect audio-visual operative conference. We invited people. It was a good response. And it went off. It was perfect. And now another question was that, are we going to continue it, or it was a one-time event? So here comes the concept of transferring the skill. Now many of the surgeons in the city who were operating fistulas got impressed by Himanshu. They started seeing the thing, they started feeling the difference. And next 2 conferences were there in Varanasi.
So the video from the first conference of brachiocephalic fistula, it was a close-up video. It's there on my YouTube channel, and it's got 80,000 views. 80,000 views of a surgery. It is age restricted, and a lot of surgeons actually come to me, sir, when I dekha tha, and there's a parachute landing technique. So it was one of very good push-off, and then next year we took it same way, but first year was more of a basic interventions, radiocephalic fistula, brachiocephalic fistula, doing angiogram. Next year we took it next level. We said, okay, let's show what is the AV graft, patch plasties. So it was, and basilic vein transposition.
But actually the transferring of skill is not that easy, and it will not happen until and unless you transfer the idea. So in next conferences, we focus more on the ideas rather than the skills. And in 2019, we went to Jaipur, and Dr. Ajay Pal Singh was the secretary that time. He arranged everything, and it was a good, successful conference. 2020 was COVID. And in 21, we did an
yeah, it was 21. It was online, but this was one of the best online meetings I've seen. It went for 8 hours, and almost more than 70 to 80 attendees, which actually sat down and saw and had a comment on that live, workshop that time.
Yeah, in 22 and 23, we combined this conference with the GRAS forum, and it was an RRT update sort of thing. And now this year, by order of our Gurujan and the man behind everything that is happening in Varanasi, Dr. P.K. Rai sir, we are doing it here in Lucknow, and by grace of all our teachers and by blessing of all of you, it looks to be quite successful. And the topic that we chose are the practical one, and these are actually those topics where we are falling apart, where the differences comes, where our surgeon is trapped, where the physician doesn't know what to do.
So we chose those topics only. This aorta session is also here because we faced some problems in transplantation during aorta. And one of the cases that we saw today is one prospective donor. So now what's the future, Dr.
I think individual level pay there has been much achievement, but as a society, yes, that's what we are coming at. Future. So there are a couple of things as role. Number one, we have to improve the quality of content. Okay. Next year we are thinking to have a different level of conference, and the seed has already been put in this year by putting as a hybrid conference. So entire conference video which has been there and today, and it will be tomorrow also, we will be segregating in small talks, so that if for say you have to go through certain talks again, you can always come back and watch that, and you can share something you liked or something like that. That's one of the initiatives which will happen from this year, and next year we'll make it much more interactive and different platforms.
Sure. And are you planning to start something for skill sharing also?
So yes, we had some idea. So basically it's, see, access is a teamwork, which what we have learned from right from beginning. And if every team player knows कि छक्के की boundary कहाँ पे जाती है, तो he can go and he can try to catch the ball. But if you don't know who does what, so it becomes difficult. We are we have seen the interventions in access have gone into so much of depth that it's not just about connecting artery to vein. So connecting well, there are different ways to connect it. Assessing, so ultrasound se lekar ke, then coordinating, preserving the veins, then once the complication is happening, guided punctures, preventing punctures, treating complications, angioplasties. We saw brachial artery superficial transposition, magical procedures. So what we thought, we are going to start a short observership. It's going to be 7 days of observership. It's mainly designed for the final year PGs or very young consultants, either nephrology or vascular surgery, or anybody who tends to either be an access surgeon himself or who wants to develop a comprehensive access program, so that you may not be an access surgeon, but you want to have access program. This 7 days will, to begin with, it will be totally sponsored for the trainees, which I have told. It will be 5 days of 5 days of didactic lectures and attending some live cases with my place at Fortis Hospital, Gurgaon. Then we'll be sponsoring the flight down from Gurgaon to Varanasi, and then 2 days of clinical exercises where you see the follow-up patients, look at the Doppler planning, you see the new patients, how do we plan, and then being part of the surgery. So it's going to be, I think these 7 days, I cannot make an access surgeon, but yes, somebody who wishes to be, I can show them the entire gamut of access surgery. So these are going to be starting from this year. We'll share more details, and tomorrow in PG quiz, the winner will be, the person who will be getting it will come from the PG quiz tomorrow. So make sure if you've got a residents or anybody who are going to participate in this PG quiz, please be there.
And today we saw a lot of difference between the IR guys and the vascular surgeons regarding various procedures. So why not to shape our next meeting as a debate one? We put more of debates and then less of lectures. So
we have already got some glimpse of this year. We have had multiple people from specialties. We had urology, we had IR from, then we have intervention nephrology, we have vascular surgeon, and we have nephrology. So, and plastic surgeon, not to miss. So next year, yes, and we also saw what is it, as you said, there's a difference in methodology. So yes, next year we are going to make our talks much more shorter, much more crispier. We are going to have much more debates. Probably there will be a committee which will also guide you through the initial part so that we can have more interesting lectures.
So that is all from the organizing secretaries. Over to you, sir.
Thanks a lot, Dr. Himanshu and Dr. Emin Singh, for briefing about the past, present and future of Veincon, and we all wish that it should grow and grow like anything, so that we all get enlightened and we really get into vascular access program, and only the long vascular access survival can lead to longevity of CKD stage 5 patients. Now I will switch over to the felicitation ceremony and felicitation of few distinguished nephrologists and urologists of the country. The organizing committee decided that in this conference we will be honoring the renowned nephrologist and urologist of the country, and I will like to invite, the first name is Professor Sanjeev Gulati from Fortis. He has been, he is in the audience. Dr. Gulati, please. Yes. I want that he should be welcomed with a big hand, because he has been a former president of Indian Society of Nephrology. He has been additional professor there in Sanjay Gandhi, and he is one of the renowned pediatric nephrologists of the country, and he has developed a lot of nephrology training and transplant training in Fortis Hospital. And I invite Professor Gulati, and I will like that Professor Sharma and the distinguished guest of honor and all the dignitaries to honor Professor Sanjeev Gulati with a memento. And now, congratulations, Dr. Gulati. Now I invite, please help him in taking. I invite Professor Dinesh Khuller from Max Hospital, New Delhi. You all have heard him. He is one of the best orator and very thorough academician, and he has published a lot of, he has done a lot of publications in the field of vascular interventions. He has made more than 5,000 AV fistulas, and I am telling you, maybe it should go in the Limca Book of World Records. I do not know whether he has tried or not, but he has made a nephrologist making more than 5,000 AV fistulas, and it really needs a big hand of applause. And I would like to ask the dignitaries to honor Professor Khuller with the memento. And Professor Gupta, please. Now I invite Dr. Manoj Singhal. He is one of my favorite junior and younger brother. Again from Delhi, he is Director of Nephrology Services at Fortis Hospital, and he is alumnus of SGPGI. He is also alumnus of KGMU. He has been taught by Professor Mitra. He has been taught by Professor R.K. Sharma and Professor Amit Gupta sir. And it is I'm feeling pleased in honoring him at this juncture in Veincon Conference 2024 with the memento and bouquet, and I request Professor Sharma to honor him felicitate him with the sal. Congratulations, Dr. Manoj Singhal. Now I invite, actually Professor Sankhwar was supposed to come, but he has not come. In place of Professor Sankhwar, he has been professor of urology in KGMU, and at present for last few months he is director of Institute of Medical Sciences BHU. And on behalf of Dr. Sankhwar, Dr. Ujjwal will come and receive his memento, and he is going to be felicitated by the dignitaries on the dais. Dr. Ujjwal. Two more persons. Congratulations, Professor Sankhwar and Dr. Ujjwal on behalf of Professor Sankhwar. And really, Dr. Professor Sankhwar, after joining there at IMS BHU, he is very dynamic, and he has developed urology, nephrology, and he has recently started kidney transplant program at BHU. And it is really a great news for all of us. And two more persons who were supposed to come, but they have not come. They will be honored in absentia. One is Dr. Nautiyal from Delhi, and he has been mentor of many nephrologists in the country, and I personally know him. It was just a brief introduction with him when he joined as an assistant professor for only few days, and thereafter he left. But sir and Professor Sharma, they said that you be with him for few days, and subsequently once he is going to come regularly, then. But thereafter he went to Delhi and he continued there at Jaipur Golden. And Dr. Emin Singh has been closely associated with Dr. Nautiyal. And when the organizing committee was deciding to honor him, we just talked, Dr. Emin Singh talked to him, but as his wife is suffering from diabetic end-stage kidney disease, he is on dialysis, he showed his inability to attend this in person, and somebody from the Delhi, from Dr. Himanshu's team, went there, and he was honored and felicitated by the Veincon on behalf of the organizing committee of Veincon 2024. And the last person whom we wanted, and he agreed also, was Professor N.S. Sanger. At present he is principal of Jhansi Medical College, and because of his administrative engagements, he could not come, and the last moment he cancelled his visit to Lucknow. And maybe somebody can receive his, I do not know, nobody is here from Jhansi, but on behalf of Dr. Sanger, as there is one story associated with Dr. Sanger with me. He did MBBS and MD from SN Medical College, Agra, and thereafter he did his DM from IMS BHU, and for few years or few months he was there in SGPGI also. But one interesting point was he joined with me as an MBBS student in IMS BHU, and for as long as the ragging was going on, he continued as a MBBS student in IMS BHU. Once ragging was over and the freshers party was given, thereafter he got the information that he has been selected and he would like to go to his own hometown, which was Agra was the most close place for him from his hometown. And he was my cadaver partner also. And he is a good friend of mine, and he is a successful teacher, administrator. And can you bring his... Yes, I should. Yes, I'm going to receive on behalf of him, and it will be. प्रश्न वाला बता दो और
छोटा सा इसके बाद 5 मिनट की टॉकिंग है।
हाँ कोई बात नहीं नहीं नोट से सुनो साढ़े 5 से पहले में से we can just Dr. Nautiyal's felicitation has been displayed, and maybe we feel honored in honoring Dr. Nautiyal, who is not here. He is in Delhi at present. And with these words, I will invite the guest of honor, Professor Alok Kumar Rai, to say a few words as his best wishes for this conference. Although he is not a doctor and he is not a nephrologist, but his blessings and best wishes are required, and he is very close to my heart. Professor Alok Kumar Rai.
Thank you. Very distinguished and eminent doctors sitting on the dais and off the dais, and my very dear friends. You know, there are two kinds of doctors. One are ilmi doctor, the others are tibbi doctors. Now, in the hall, there are tibbi doctors and ilmi plus tibbi doctors. Probably I am the only ilmi doctor. So it is a great deal of challenge for me to establish my relevance to be in this hall. But such challenges as a Vice Chancellor we keep facing, because at University of Lucknow we have 53 departments and 17 institutes, ranging from science, arts, commerce, law, education, painting, drawing, everything, almost all the subject, principal and main subjects, and they keep inviting us. So as chief guest we go there and we have to speak something. So you can understand how challenging the job of a Vice Chancellor is, besides the challenges that comes from the students and the faculty members. But there are certain things that I would certainly would like to bring for your contemplation, because there are some very eminent people who have come, who have been very, very accomplished. It is very important to forge an association with educational institution, not only for the sake of developing discipline, but also for the sake of societal good. As a doctor, taking cue from what the previous two gentlemen was talking about, कि पैसे तो बहुत कमाते हैं आप, या सिर्फ पैसे कमा रहे हैं आप. But when you forge an alliance with an educational institution, all that you earn goes for a meaningful service as well. I wish this program would have been organized in my campus of University of Lucknow. This gives a lot of positive feeling to all these students who may not be a medical student, though University of Lucknow was, while KGMC was part of it, and many of you might be from KGMC and may have got your degree from University of Lucknow only. But even otherwise, it is extremely important to motivate all the students to do good, how good you are doing, what new you are doing, what innovation you are bringing into, and how are you working as a tool for the greater good of the society and to a section of society that is in a real need. So it is important to forge an alliance with educational institution, not merely for the sake of pursuance of the practice that you are in, but also for the greater societal good. Another important thing is, I have come to know that a lot of professors from SGPGI have also come. We are contemplating for a program on healthcare, management, and it is neither the are. Because what happens, after a stage, you cease to be just a practitioner and you foray into a territory where you may require certain additional skill. We have got certain program of public health, etc., where we get a lot of enrollment from doctors. But then a specific program in association with certain specialized and leading institute, medical institute, who would attend to the basic needs of the doctors, of the output that they come up with a university, a regular multidisciplinary research university, and a customized program can be created. I hope from this very, very wonderful and very, very prolific platform, I'm sharing this idea of forging and coming up with a program in association with the medical college, of course with the help of certain hospitals or other medical institute. We are open for it, and we can come up with such program who would attend the last mile of the profession. So my sincere wishes to the organizers. I can see there have been participations from abroad, there have been participation from leading practitioners. I have been coming to meet so many people out here. It's a 2-day deliberation. Will certainly meet the end result of not just furthering the domain knowledge of the discipline, but also of the society. Thank you very much for making me part of it. Thank you very, very much.
Thank you, Professor Rai, for giving your best wishes on this occasion. Now I invite Dr. Rabi Alhans. Please come and say a few words as a part of your blessings to this conference and the nephrology fraternity in the field of growth of vascular access. Please come, say a few words.
It is a great honor to be amongst dedicated professional academicians and permitting me to be part of. I am not attached to any academic institute, but still we see in our daily life there are lots of problems. So it was a very good opportunity to listen to the young minds, that what kind of problem, whatever problems are being faced by our nephrology community, they were discussed, how solutions were taken out. So otherwise I have nothing more to add, and I wish that this conference motivates all of us to learn something, and when we go back we change our pattern of practice so that the society can be benefited. Thank you, sir.
Thank you, Dr. Alhans, for your kind words, and it really makes a lot of difference. Why I'm saying this, because one very important pertinent point he has raised, that there are many problems which have remained unanswered for many decades. Now with young minds, young surgeons, young vascular surgeons, young interventional radiologists, urologists coming into picture and solving the problem of our vascular access is really it's going to play a very important role in prolonging the life of CKD stage 5 patients, and quality of life also can be improved in these patients. And now with these words, I now invite Professor Sharma. He is a known figure in the field of nephrology and national as well as international level. And the most important thing, he has been teacher of teachers, and he has been my teacher also in SGPGI, Lucknow. And I always feel honored in listening Professor Sharma, because he is not only a nephrologist, best nephrologist, he is a good orator, and he has a keen interest in the research, and he is a very innovative researcher. publishing research from the data is very common practice. But if you have to take out something new from the patients and something which is pertinent for the patient population, that thing we learned from Professor Sharma, and he has really done a lot of good things in the field of transplant immunology. And now as a chief guest, I invite you, sir, to say your few nice words and your blessings for the country. Please, welcome.
Thank you for the kind words, and it is my pleasure. I am actually not the chief guest, but I am one of the delegates who looks forward to these meetings. I attended this meeting in Varanasi and in Delhi also. It is very interesting. I was actually just going through the list of Nobel laureates in last 3 years. This year, as you know, that the Nobel Prize has gone to researchers for artificial intelligence and for machine learning. And we had one presentation that how it is relevant to us in nephrology also, and in looking after the vascular axis. It is also interesting to understand that if you look at the Nobel Prize of 2022 and 2023, one year the Nobel Prize has gone to physics and another time for chemistry in a related field of what we call as the quantum theory, which Albert Einstein proposed to contradict. He was not a believer of the theory of quantum entanglement. You must be knowing a little bit about it. And he actually called it as a spooky phenomena. Something he said cannot occur because it was contradicting his theory of relativity to some extent. And especially it was trying to say that things can move faster than light, which was not acceptable to him. He was one of the earliest who talked about it to say that this is a spooky phenomena of some spooky particles whose existence cannot be proved. The Nobel Prizes of last 2 years, 22 and 23, in physics and chemistry has gone to label these particles and also to identify them and to prove that such a small particles actually really exist. How it is relevant to us is basically, it is also trying to, in a scientific way, tell us that what the Vedic philosophy has talked about, connectivity and entanglement, is now also being proved scientifically. The same type of particles have been shown to exist. And essentially, if you look at the theory of quantum entanglement, it only means that two particles which are so small, very difficult to identify, do exist. They can be far away from each other, billions of light years, but they are still connected. Something which is very difficult to understand, and now we have come to the stage that it is being accepted and proved scientifically. It shows that one of the particles, if it spins like this, the other particle, which is billion of light years away, would also spin. And from this spin, you would be able to tell what is the nature of the other particle. Basically, it means that something which is there on this planet and something which is there on some other planet billions of light year away, they are still connected to each other. I will give you an analogy that when we manage patients, we are not so many billion of years, light years away. We are very close by, but we have to understand that we are connected. And this is very relevant for the vascular access management. In the vascular access management, the team which works can change their roles. I, as a nephrologist, I will tell you how I have changed. When I started nephrology training, when I was in All India Institute, as I was mentioning, we started creating vascular access because the vascular access was failing in the patients. And the most experienced surgeon has failed. So we had an opportunity to really learn and create vascular access. No Doppler, no ultrasound, no venous or arterial mapping. And our chief of surgery, some of you might have heard Professor Dhawan, he got so impressed and he was so happy that he allowed us to make fistula on our own. And then when we came to SCPGI, we had an opportunity to continue in the same area, to create a facility of interventional nephrology, which was basically mainly looked after by the nephrologists. This is how we had experienced when we were in All India Institute. And this is, we thought, is the way go about. Better training for the students, also helping the patient management, and also understanding the problems of the patients whom we are looking after. Now I have come to a corporate sector. Now you see, it's a 360-degree change. I don't make any fistulae. When I came and joined the corporate sector, I started doing the same thing which I was doing in SCPGI, putting the permacath, making fistula, putting PD catheters. But slowly the circumstances and the situation demanded that there are more people who can do it. Some of them may be better, like the interventional radiologists, like the surgeons, the vascular surgeons, the urologists who can put the PD catheters. So all that responsibility of doing those things have been passed over. It has made my life much simpler. And also the patient management is going on as a teamwork. So why I'm giving you the example of those small quantum physics particles is basically to give an example that all our human beings, it is also proved, the behavior of human beings, how it can change based on these small particles and the entanglement phenomena. So we should always be prepared as we evolve to change depending on the circumstances. Even now, probably majority of young nephrologists, they do all these procedures themselves because of same reason. But if you have a situation, and even if you feel that the management will be better, there is no harm in having a team of radiologists, surgeons, interventional radiologists, vascular surgeons, urologists to come together and manage these patients. The ground reality is we have to understand that we are all connected. There is no antagonism, and feeling an antagonism towards anything is something which makes the universe unstable itself. This is also the result of the thinking of quantum mechanics, and quantum physics, and quantum chemistry, for which in 22 and 23 the Nobel Prizes have gone. So once again, I am very happy that the Varanasi Nephrology Society has taken up this job, and we have to congratulate and thank Dr. Pradeep Rai, that we are going every year updating our knowledge, simplifying and training the whole manpower of not only doctors but also the paramedics in this area. So thank you very much for organizing these meetings, and I wish you and all the organizers all the best and best of luck. Thank you very much.
Thank you, Professor Sharma, for such a nice and enlightening speech on this occasion. Whenever we hear Professor Sharma, we get message from his talk, and the message is that we should work as a team and we should complement and supplement each other so that the vascular access society in our country grows, and the patients of CKD stage 5 who are on dialysis are supposed to be on dialysis. They should survive for a long time. With these words, I will like to invite Professor Amit Gupta sir to give his thanks for this occasion speech, and then we will switch over to the other program which was rescheduled. That was Professor P.K. Srivastava Memorial Oration. And subsequently, maybe Dr. Himanshu requested that you can also, thereafter, will you like to give your 5 minutes message to all the delegates and faculty members? Professor Amit Gupta sir, please.
Good evening to all the distinguished guests on the dais and to all my friends off the dais. And it is indeed a great honor and a privilege and a pleasure for me to propose the vote of thanks. Firstly, I would like to thank Dr. Pradeep Rai and his entire team of Varanasi Nephrology Society and Veincon to have the meeting this year at Lucknow. And we are really privileged indeed that you agreed to our suggestion and you came here to the city of Lucknow. I'm indeed also grateful to our chief guest, Professor R.K. Sharma. Professor Sharma and I go back a long time. We both joined SGPGI together way back in 1987 as faculty. For the first 6 months, we had no work to do, and then gradually the department grew, and we have ultimately both retired from that institution, and it's great to see that SGPGI is, of course, flourishing in the years to come and will continue to grow. So Dr. Sharma, your speech was really illuminating, and as always, you tell us something new. And this connection that you made between quantum physics and medicine, and particularly vascular access care, is indeed very, very good. I'm also grateful to our guests of honor, Professor Rai, for having extremely busy person as the Vice Chancellor of the University of Lucknow. You have already too many things to attend to, but you still came and made time for us, and indeed told us about how important it is to connect with, say, a university and, say, medical science. We can sort of go forwards. Ravi Ellens, our other guest of honor, Ravi had been our first resident at SGPGI, so it's indeed always great to see you, Ravi, and you're like a younger brother to all of us. And I remember he was the only resident at that time when he first joined, and he had to bear the brunt of the of the work. But Ravi has flourished into an excellent physician, excellent nephrologist, and a very, very kind-hearted, very noble person. And thank you, Ravi, for coming here. To Professor Mitra, who is the senior-most nephrologist of this city, a doyen of his kind, a teacher, as Pradeep mentioned, a teacher of teachers, and he is an excellent clinician, and all of you who have come in touch with him, he has a very good knowledge of the entire subject of medicine, leave alone nephrologies. And so Professor Mitra was very kind to grace this occasion, and I am indeed grateful to him. Professor Jayaprakash Ojha, of course, is a dear friend of mine, and Professor Ojha and I, we worked together for a few months at IGIMS in Patna. We both did our graduation. We have same batch, 1972 MBBS. We joined together. So Jayaprakash, it's indeed a pleasure that you came here to Lucknow and for this meeting. This meeting, vascular access, such an important thing, as all you've heard throughout the entire day, and also we'll have this meeting tomorrow, the importance of vascular access in the management of our patients. And we, in the initial days, as Professor Sharma mentioned, there were not too many people who were interested in this area. But now, as time has elapsed, people have realized the importance of how to maintain it. And not only our nephrologists, we have vascular surgeons, we have the urology colleagues, and intervention radiologists who are all part of this to look after or create vascular access. And we need to work as a team in order to sort of keep the vascular access of our patients going, because that is, after all, their lifeline for future. I thank all the delegates who have come here, all the esteemed speakers, all the people who have participated in the meeting, and all the pharmaceutical companies who have supported us in this endeavor. And I wish Veincon the very best, and I'm sure we'll go from strength to strength under the able leadership of Dr. Pradeep Rai. Thank you very much indeed. We now have the next part of the program, we have an oration by none other than Professor Narayan Prasad, and he'll be speaking about a very important and very interesting topic. So I'd request you all to stay back and listen to this oration, because we'll gather something from it. Okay, thank you.
joining to Professor P.K. Srivastava memorial oration. Only one thing about the Professor P.K. Srivastava, he never taught us disease-based medicine. He taught us fine arts of medicine, approach to patient. And he used to say, medicine is learned bedside, not in classroom. I think that this oration is given by Dr. Narayan Prasad. Narayan Prasad is an introduction. His topic of oration is research, innovation, and intervention. His experience, SGPJ experience of 2 decades. So I am honored to invite Professor Narayan Prasad for his oration. Dr. Narayan Prasad, please.
Thank you very much, sir, for this kind introduction to our two of my teachers, Professor Hemant Kumar and Professor Jayaprakash Ojha sir. Both are having my teachers, seniors, and 2 of our great mentors, seniors, Professor Amit Gupta and Professor R.K. Sharma sir, and then definitely the senior most nephrologist in the city, Dr. Mitra sir. So today I'm really very much feeling nostalgic today in Lucknow, having this oration, P.K. Srivastava orations, and I'm very thankful to Veincon, particularly Dr. Rai, for giving this opportunity to speak such a great oration. We all understand, first of all, gratitude from Veincon, SGPJIMS from my side to Professor P.K. Srivastava sir. And you can see on the background the 2 photographs. Who can imagine that this is a photograph of Dr. P.K. Rai and his wife, Dr. Neelam Rai, behind P.K. Srivastava. So, and my gratitude and my salute to Professor P.K. Srivastava, and thanks to Dr. P.K. Rai for this opportunity. So this is the milestone in the development of nephrology at SGPJIMS. The first great teacher was Dr. Vijay Khire and Professor Sharma, both have joined simultaneously, and then Professor Amit Gupta. And that has been driven, you can see, there are several milestones over this 3 decades of nephrology at SGPJIMS. And in 2022, our Department of Nephrology has been shifted to the new building, Emergency and Renal Transplant Center, and the department become one of the largest department of nephrology probably in the country, and you may think of 107 clinical nephrology beds, 125 of the dialysis stations, 14 beds of the critical care nephrology, 2 dialysis OTs, intervention suites. So there are 2 of my mentors, Professor Amit Gupta and R.K. Sharma sir is here. And as usual, when I have started my career, I have evolved through the peritoneal dialysis, transplantation, hemodialysis, clinical intervention, basic science, life science, everywhere I have worked around. So I was evolving in the early phases of my life. Now I am a little stable and focusing on towards the leadership of the nephrology, academic leadership, not that leadership. So first 5 years, from 2005 to 10, my major area of the research was peritoneal dialysis. Now this is the area of the focus across the world to increase the home hemodialysis and home dialysis, we call the popular peritoneal dialysis. Next 10 years, I thought that there is not too much of the enjoyment in doing this clinical research, doing only things. So I started my basic science research, got some funding, initial funding from ICMR, set up an independent lab, lost time and money, both doing this basic science research. Some gain, some loss, initial academic leadership experience. That came during the next...
Good morning, everyone from New York City.
Onwards, some diversity, leadership, and new researches. I really thought that it might be useful, and then I always feel that if I have spent more time in epidemiological research, I could have done better than spending money on the basic science research, really. But that has given me some name, fame, definitely, but it was not of that much recognition as we could have spent on the epidemiological research. So first of all, I will show how we evolved this peritoneal dialysis program. Professor Amit Gupta sir was one of the pioneers that we all understand in the field of the peritoneal dialysis. He was there with us to support, and many questions were answered as a postgraduate students. I was there, and always the culture was coming negative culture, negative peritonitis. Patient was coming with the peritonitis, reading catheter removals, and that kind of things were always coming in the mind. Why this is so much culture negative? Then I have learned many techniques from Gupta, Professor Ken Prasad, who was there, how to go about the culture, and you can see. This is one of the video of Veincon catheter insertions, which we have demonstrated during this PD Science meeting, which we have done first time probably, but it will be longer, so I will escape out this video. But what we have got that, initially our urologists used to take the deep cup persisting sutures. I have left doing that, and I have not found any difference, no leak, nothing else. So what we have seen, really that was not required a step. Everything heals by fibrosis, and it will heal automatically. And gradually, that process is adopted across many centers. No one is doing the deep cup suturing now. They are just inserting, leaving this over this lining, going through the linea alba and leaving at above the peritoneum, and leave it as such and make your tunnel and leave it as such. It will heal by fibrosis. So then we came out of how our patient, many of the patients were dying very early, and many of the patients are doing very well on peritoneal dialysis. So what was the reason? Here we can see, this is the data of the multiple 5-6 studies, and mean 5-year survival was 35%. So I have tried to see whether diabetic patients were mainly included for the peritoneal dialysis. Then we thought that what is the real survival? But data was there, patients were there, but there was no real analysis that what was the 5-year survival of the peritoneal dialysis patient. I came to know that non-diabetic patients were really doing better at 5 years, 42%, and diabetic patient 39, average survival was 39%. That survival was equitable to any survival of peritoneal dialysis patient in the world. So that was the beauty of that PD program, and our PD program was the largest in South Asia at that point of the time. And when we have adjusted comorbidities, whether this was the diabetic or non-diabetic, survival was equally good. So then we thought that why this is happening like this. So was there any effect of the, because more than 50% patients were the diabetics, so multiple comorbidities, malnourished patient. So there was impact of any comorbidities on the survival of these patients. What we have defined based on the Khan's index, we have defined the patients into the low risk, medium risk, and high risk groups. What we have seen, the patients having the high risk groups, those who are associated with the comorbidities, had 3 times, rather you can say 5 times, 3 to 5 times higher risk than the low risk group of the patient who do not have comorbidities. And you can see 5-year survival in the high risk group was only 30%. And really you can see this Kaplan-Meier survival curves. Patients with the comorbidity were not doing that well. Then we have tried to, but whether there is confounding effect of comorbidities and malnutrition. And here we can see those patients who were malnourished with comorbidities, 5-year survival, none of the patients was surviving for 5 years. Those who do not have malnutrition, normal nutritional characteristics, no comorbidities, these patients were really doing well. You can think of 70% of the patients were surviving for 5 years. So probably we are putting the patients with the comorbidities and malnourished patient on peritoneal dialysis, and that might be the reason of the poor survival of this group of the patients in our PD programs. Then we have also thought of whether this peritonitis rate was very high when I was doing my residency. And was there any impact of nutritional parameters on peritonitis? So we have defined the patient based on the normal nutrition and malnutrition group of the patient. Malnourished patient had 80% of the patients on dialysis had some episodes of the peritonitis. That was significantly high. What we can see, as the SGA value was increasing, the peritonitis-free survival was decreasing. So more malnourished patient, lesser peritonitis-free survival. So, and that was very obvious in our data finding. This was one of the randomized control trial that we have done at that point of the time, published in PDI. So now coming to the intervention. Someone was putting some, what is this intervention? This is not the part of intervention. So when you go to the Oxford Dictionary, you will see the definition of the intervention. Intervention is something which alters the course of any disease, any intervention. So this was a dietary intervention. Then we thought of why not to do the counseling periodically by the trained dietitians. Archana Sinha is here today. She used to follow each and every patient for 6 months and collecting the data. And what we have seen, this nutritional intervention improved the patient's survival, improved the patient's nutritional status. So 6 monthly follow-up was very good intervention at that point of time that we have collected the data and published in Journal of Renal Nutrition at that point of that time. Other important complications was about the culture negative peritonitis. This is the data from the all peritonitis study in India. What we can see with the increasing month, almost were 40, 60, 70% patients were the culture negative across all centers, across India. And that was positioned in our centers also. Our 39% of the patients were culture negative peritonitis. 39% of the episodes were, 36.9% was culture negative peritonitis. So, and definitely what was different was the culture negative peritonitis was coming more. Gram negative peritonitis episodes were more than the gram positive peritonitis, which was atypical for any PD programs across the world. And the first time when we have reported, we have several comments from the different centers, and they have started reporting now. Their centers are also experiencing increasing incidence of the gram-negative peritonitis, and that becomes subsequently that has been proven that probably many of the centers are experiencing gram-negative peritonitis is more, probably because of the improved technique of the connectology. Gram-positive peritonitis episodes went down. That might be the one reason. Then we thought of how to get off this, what is the organism behind this culture negative peritonitis. And that was the one molecular intervention we can see that we have developed in our own lab. We have started using the primers, PCR techniques for the gram-positive and gram-negative peritonitis detection. And we have collected DNA, bacterial DNA from the PD fluid, from the culture negative episodes. And for your imagination, you can think of many of the bacteria which has been isolated from this culture negative peritonitis group by molecular technique was really unheard of. And some of the bacteria was found in the feces of snakes. Some of the bacteria was used for sinking of, some of cabbage fermentation in China's populations. So that kind of the bacteria was isolated by this from this culture negative peritonitis episodes from this peritoneal dialysis fluid. And they are really the slow growers. Probably they cannot grow in the usual culture media. And so that was another important intervention that we have found. Third important things, what else we can do to see, even when you do not have these techniques. There was NMR center was there at SCPJ was set up. Here we can see. Then we have thought of, many times we have fungal peritonitis also. Fungal peritonitis episode was very high at our centers. So we thought of how to differentiate from the fungal peritonitis episode. Quickly we can diagnose. You can see one is the ethanol amine is replaced by phosphocholine in eukaryotes. Fungus are eukaryotes and bacteria are prokaryotes. So there we can see this is the peak on the NMR that has been seen in patients with the bacterial peritonitis episodes not in the fungal peritonitis episode. And that given us the very quick suggestion that probably by putting this into the NMR metabolomics, we can get probably differentiate from gram-positive to gram-negative peritonitis. Then we have also studied effect of the metabolic syndrome on clinical outcomes of the non-diabetic peritoneal dialysis patient. Diabetic was obviously a lot of metabolic complications. Then even in non-diabetic patients, what we have seen, metabolic syndrome was an independent predictor of the mortality, 2 to 14 times, 5 times higher risk of developing mortality as compared to those patients who do not have the metabolic syndromes. Effect of the body mass index on outcomes of peritoneal dialysis patients in India that we have studied, and what categorically we have seen, the patients who are underweight, malnourished, and diabetics, they have the highest and significant risk factors for mortality in peritoneal dialysis. So underweight and diabetics. So that we have published in Peritoneal Dialysis International. Then peritoneal fibrosis was another important factor, so where how these patients sometimes ultrafiltration failure was happening on long time on dialysis, and then we have thought that what we can do to prevent this fibrosis. Here we have taken some of the peritoneum part from the patient who are going for the catheter removal, and then we have cultured and isolated in our lab, and we have seen that the sildenafil and one of the other drugs, which was our drugs for the experiment, both have very significant effect on decreasing the markers of fibrosis from the peritoneal dialysis fluid and cultures that we have in vitro, we have studied. And we are planning to develop some of this trial. We are trying to go on to the trial basis if this some kind of this sildenafil or our experimental drugs, 5-HT2 inhibitors, can be used to reduce the fibrosis in peritoneal dialysis fluid. So this was our PDA story of SGISS. Next step I have told you, then we have thought of about the drug resistance, what intervention can be done. So nephrotic syndrome patient, there were no pediatric nephrologist. Dr. Gulati has already left SGPGI. So by that time we have a lot of pediatric patients, particularly nephrotic syndrome. And there we can see many of the patients were the late non-responder, and many of the patients becomes initial non-responders, subsequently non-responder, steroid-dependent course that we all understand and face in day-to-day life. So first study which we have tried to do, see a lot of patients was oral cyclophosphamide was coming with leukopenia and other complication, infective complication. Dr. Gulati was very fond of giving IV cyclophosphamide as a resident. During that period of the time, I thought that we should give the pulse cyclophosphamide and we can see how this behaves. You can wonder that remission rate, peritonitis free days was similar in the both groups at the lesser cost of the infection, leukopenia particularly, and other infections on IV cyclophosphamide as compared to. This was the randomized control trial, and that has been published in Pediatric Nephrology in 2004 at that point of time. Then we also thought of many things we have learned from Professor Gulati. He is here, that how you can see and which topics you can take, and that would have the good publication and impact value. So tacrolimus has been launched, and we both decided that why we have a lot of patients of the steroid-assisted nephrotic syndrome, why you are not trying to give this tacrolimus to these patients. So this was only 22 patients where we have given tacrolimus used the first time in nephrotic syndrome patients, and then you can see complete remission was seen in 84% of the children, and 10% of the patients attained partial remission. And that paper of the only 22 patients has been published at that point of the time in NDT. Then we subsequently thought of, many times we are dealing with this very refractory patient, not responding to the cyclosporine for 6 months, 1 year, then changing over to tacrolimus, from tacrolimus to the cyclosporine. Why this is happening? Definitely one thing was very clear from our data, that 5-year survival on the tacrolimus was 79% as compared to the cyclosporine, that is renal remission, that in terms of the renal remission. So we thought that why this is happening. approximately oral cyclophosphamide and prednisolone, only 25 to 30% of the patients was going into the remissions. Cyclosporine and prednisolone, 50 to 80% was going. Why there is so much of the differences? But many of the patients were not responding. They are becoming late non-responder. So we thought that why everyone might be knowing about the Salhoff's hypothesis that minimal change disease in children is basically happening because of the T cell activity. And this because they have the hypothesis that this disease disappears when the patients have the measles, when your T cell immunity go down. And there are certain evidences based on that probably they have given that probably this is a T cell disorders. And what we have seen that many patients during the upper respiratory tract infections, they relapse. When you treat upper respiratory tract infection, they go into remission. So why this was happening? So we thought that why we should not take up this step to see why this is happening. Here you can see those patients who have any infections, those patients who are having the active disease, have the proteinuria and a higher degree of the pro-inflammatory cytokines, but those who do not have higher degree of the regulatory cytokines suppresses T cells activity, they were in the remissions. That we have observed. And from that experiment, that was a Veincon side experiment of peripheral blood mononuclear cell screening cytokines from the different T cells, what we can see during the relapse and resistant patients, all T cell activity, inflammatory T cell activity like interferon gamma, IL-4 and IL-17 used to go high, but IL-10 was moving in the reverse directions. Those patients in remission had higher level of interleukin-10. So then we have some idea that probably it is happening that during the infection, probably inflammatory cytokines is going up, and that is causing this relapse of the disease. So there was one thing always coming in that why some patient initially responds and later on becoming the steroid dependent or becomes non-responder. So there I thought that this could be the three possibilities. One is the histological transformation from MCD to messenger proliferative or FSGS, that everyone know relatively more steroid resistance than MCD, genetic causes of SRNS or pharmacogenomic aspect of the SRNS. This could be the three possibilities. So I thought that whether there is really a pharmacogenomic aspect that we should take up. And in the lab, one of our friend, Dr. Veincon who was working in immunology, we both have sat together and planned that probably we should study this P glycoprotein and MRP1 gene and see this, what is the effect of this gene on the steroid responsiveness. We all understand PGP is the one glycoprotein appears on the surface of the membrane, and that it flux takes out the drugs or any xenobiotic or any toxins from inside cells to the outside the cells. So they do not allow the drugs to go at the site of the axon. And so probably this is the reason, probably the drug is not reaching to the site of the axon, probably steroid is not reaching to the site of the axon at nuclear level, and probably this might be the reason of steroid resistance. So then we thought of probably why this MRP gene or the PGP gene, what is the gene which is regulating this PGP expression. Then we have taken one first our PhD students. He is Tabriz, he is at present assistant professor there in Ira Medical College. We have taken this MDR1 gene, and then we have studied that some of the mutants like G2677TA, this is the gene always are associated with the resistance. And this experiment we have done several times, several studies where we have done, and this was the gene which was associated with the steroid resistance. And this paper at that point of the time published again in NDT, large number of the patients, 216 cases of the nephrotic syndrome patients, 137 steroid sensitive and 79 steroid resistant nephrotic syndrome. Then we have longitudinally followed these patients also. What we have seen, when you are following these patients, whenever you have some degree of the relapse, from the baseline during the relapse, the inflammatory cytokines were going up. Interferon gamma, T regulatory cells levels was going up, Th1 cells was going up, Th2 cells was going up during the relapse. When there was remission, T regulatory cells were going up, but their cytokines of the other inflammatory cytokines were going up during the relapse and going down during the remission. So this was the one, and then we have followed this patient on the tacrolimus also. And then we have seen, even on the tacrolimus, whenever there was a relapse, the relapse inflammatory cytokines were going up and regulatory cytokines were going down. So this was another pharmacogenomic journals study. The same things has been demonstrated in patients with a digoxin toxicity. Those patients who have higher level of the PGP, they have intestinal digoxin uptake is low, and probably the level would be high. So they have also seen this gene, MDR1 gene, C3435 T genotypes, was affecting this digoxins level. So we have taken another PhD students to work on this. This overexpression of P-glycoprotein and MRP1 are pharmacogenomic biomarkers to determine steroid-assisted nephrotic syndrome in children. This bedside study again revealed the same thing, 2677TA MDR1 gene was associated with the steroid assistance. And here we have a study, this was the one study which has given me some concrete value. If your PGP expression on the peripheral blood mononuclear cells was more than 7.13%, more than 7%, probably you are likely to get the steroid assistance. And if the MRP1 is a similar kind of the gene, proteins of the same family of the genes, ABCD genes, which is regulating these different drugs activity, again 9.6%, if more than 9.6%, that determines the steroid assistance. So that, and this, when we have published in these pharmacogenomic journals, that journal was very difficult to publish because the nature groups of the journal, but they have accepted our this publication, this paper, and then we have got the invitations why you are not getting it patented, because the first time we have seen this kind of, then we have got the patent, innovation patent from the Australian grant. Other important thing then, we thought of the many patients. When we have the patients, we all understand the atopy is associated with MCD relapse or allergic manifestations. So other genes which was affecting this regulation of the steroid assistant was HDAC2. Here we can see histone acetyl transferase. This was the enzymes which opens up the chains of the DNA, and DNA becomes active. When you have HDAC, it closes the genes. So any formation of the cytokines will be blocked. So we thought that why not to do the experiment, taking the patient of the SRNS and SSNS and see that what is the effect of a stimulation of this HDAC2, like theophylline. What you can see here, PGP and MRP expression, when we are giving this theophylline, that was going down, and HDAC2 was going up. So theophylline has very good effect, and these were very cheaper medicines. So we thought that, and at the same time, trichostatin, which is the opposite effect with theophylline, they have shown probably again in the reverse way. PGP and MRP was going up and HDAC2 was going down. And what we have seen, probably the theophylline is through this activating the, activating about HDAC2 is blocking the chains, blocking the active DNA parts, chains, and then probably reducing the formation of the cytokines. So then recently, in 2 months before, we have another publications coming. Probably this was a pharmacogenomic aspects, whether really we are dealing with something, the genetic, because many of the patients are getting steroid, getting tacrolimus, cyclosporine for many months, years, a lot of toxicity, avascular necrosis of the hip in the children's, pneumonia. So we thought that why we are giving so much of the longer antibiotic if you have this novel mutations. And we can see, for the wonderful experience, we can see When we have, this is one of the largest study from this part. This has been recently published in the clinical kidney journals, novel mutation pattern in children with steroid-assisted nephrotic syndrome. What we can see for the surprise, most of these patients in the younger age who are presenting as a nephrotic syndrome has basically the mutation in COL4A4 or COL4A5 genes, which is responsible for Alport syndromes. And it's possible that these children in future, if you will follow, will have the full-blown Alport syndromes. And this was the reason why many wonderful mutations we have seen that has never been reported. We have not seen the classical mutation of the podosine mutation or nephrin mutations in this group of the children, only 2 cases out of these cases. So probably we should, rather than testing drugs and again producing toxicity in these children, we should have this testing, because no testing, which initially when we have started getting it done, it was in 17,000 cost. Now you can get it tested in 6,000 rupees. It is available in 6,000 or 8,000 rupees, and you can get tested. If there is any mutations, why to expose this kind of the children to so many of these immunosuppressions? Then in transplantation, we have seen again the melding effect of the MDR1 gene and cytochrome P450. We all understand both have effect on the drug levels. Through this study we have tried to find out, was there any independent effect of the MDR1 gene other than cytochrome P450 on the level of this tacrolimus, therapeutic level or 8 to 10. What we have seen, when you have the fast metabolizer and this mutant genes of the TTA, that is 267 TTA, these genes, then you have the requirement of 0.15 milligram per kilogram body weight initially to achieve the drug level of 8 to 12. And when you have this GG33, you can only get 0.1 milligram per kilogram body weight of the tacrolimus. We all understand that drugs level fluctuates like anything. And you cannot say this patient we are giving this much of the drug and patient will achieve this level. And sometimes it is better. But this practice we have started at our centers now, and we are getting the good result and guiding you in getting your tacrolimus level. So now recently, just a few months before, we have published work on the VEGF polymorphism in several papers on the recipient's VEGF polymorphism, short-term survival, long-term survival. Then one time I have got one comment that why you are testing recipients VEGF if you are taking the kidney from the donor. So why you are not testing the donors? Is there any independence of the donors VEGF polymorphism on this? Then definitely that turned out to be a very good results, that some of the genotypes of the VEGF polymorphism was associated with increased risk of the rejection, and this study has came last month in clinical transplantation. Coming to the original of this intervention suits, initially when I was the resident, first time I started going to the OT and making AV fistula. There was a lot of obstruction from probably urologists are not here, probably it might be sometimes a lot of obstruction that why you are making AV fistula, Dr. Nair? If there would be any complications, I will not come out to help you. Then I have told him one day that, oh, Professor, probably some vascular intervention is there, so they will take care. So that kind of argument went on. We have continued making AV fistula, simple AV fistulas in OT in the residence days, and subsequently when I became the faculty, this was the norm. Our every residents was passing out making some fistula, AV fistulas, 10, 15, now they are making 50, 100 kind of the AV fistula are made. So, and now recently we have the world-class intervention suites, that 2 operation theater dedicated to the nephrologist, one with the only CRs, one with the proper DSA, digital subtraction angiography suites, and a lot of procedures are done. You might have seen. This was the one intervention which we have started doing this guide, using this guide, probe. Guide was very much helpful in making going to tracking the needle and making this particularly. It was very easy to study when you are entering through this guide probes. you are going to hit where. That was the guiding, and this was the large study which has been published at that point of the time in CKJ, and there we can see major and minor complications when we are doing with ultra pro guide was significantly less as compared to doing without ultra pro guide. And so that becomes this now the norms. We do all kidney biopsy with ultra pro guides. Sometimes we have difficulty in doing the biopsy when you are doing the conventional biopsy. Putting the patients, when you are putting your ultrasound probes, patient is obese, not able to hold breath. They used to leave this breath in between and you are producing some injury on the kidney. So what we thought that why not to randomize the study, we are putting in the reverse way the probe and go craniocaudal. And here we can see when you are going craniocaudal approach, your needle is coming like this. When you have caudocranial, the needle is coming like this. So what we have seen, without just you ask him to hold the breath, not to take the deep inspiration, not you have to do anything, the needle will directly fall on the kidney and you can get the piece of the tissue. And that particularly was very helpful in obese patient lying on the belly and not able to hold breath. So that was very helpful techniques, and we have done this randomized study in the 80 patients subsequently, and we can see the number of passes required for obtaining the tissue, adequacy of the tissue, and complications. All are almost similar. This has been published in Journal of Vascular Access. Our outcome of the radiocephalic fistula created by nephrologists, this was the experience of the 500, more than 500 fistula. Here we can see our success rate, you can imagine how good it was. 76% of the success, primary failure was very few. Probably it might be because a little bit biased, because we are selecting only those patients whose veins and arteries were good. And but that was our initial experience, and that has given significant satisfaction that even it was better than any reports at that point of the coming from the USA. So I have got the comment that why your success rate is so good. So then I have replied them, this is the all done by nephrologists, and particularly when those training nephrologists are doing, and we are selecting the patient. Our patient, ESRD patients are younger than the patients who are in USA. Probably this might be the better vessels and giving this more success. Recently, one of our fellows, we have one postdoctoral fellows coming from our institute, another is coming from the International Society of Nephrology. This year one fellow is coming from the Mexico. Here one of the fellow has come and said, sir, can I try transradial? So I have told him go for. And what we can see in juxtaanastomotic stenosis for all this, what transradial versus transvenous approach, what you can see the result. You can see the result, technical success in patients having the thrombosis, then clinical success, all was very good in transradial approach as compared to your transvenous approach. And because we all understand now, most of the cardiologists are going through the transradial approach. So we have given this name of this study as TEP-ABBF. This is in submission and probably will be published in next year. Then recently, probably you might have seen these photographs in the morning. Dr. Santosh Vijay, another our PDF, postdoctoral fellow in intervention. Here we can see one of the big pseudoaneurysms here. And what we can see here, pseudoaneurysm has been removed and there was no outflow. And one of the important development what we can see, hybrid procedures. Endovascular balloon angioplasty of the brachiocephalic vein with the surgical correction of the mid-arm stenosis segment in the same setting and success. Suppose one patient has stenosis in the brachial, and then you can go for intervention, and another a very big segment where you cannot do intervention in forearms. So I have told him why we cannot go for, and there were very big collaterals. So he has removed these collaterals done anastomosis, bypassed this long segment in the forearm, and done this central venous stenosis corrections, angioplasty, and we can see the growth was phenomenal. This was a very good result. You can see, and this post-procedure angio with a good flow in the graft. So that kind of the permutation and combinations we can do, and we can get success. So this is one of the video that's showing that after this making this correction, forearm corrections, very good autologous graft working. So take home message, intervention is important. That means any procedure or drugs that change the course of the disease, not limited to IJV, tunneling, avigraphy or aviplasty. So any intervention is important, particularly in clinical practice. A spectrum of intervention should be broadened. Nephrologists need to invest time in research and innovations to intervene with the disease with equipment of intervention. So these are the few photographs. This is one clinical fellow from International Society of Nephrology from Myanmar. He has went back, and this is our intervention suites where our fellows, two fellows, one was going, Hemant, and other Santosh was coming in, and Dr. Manas Patel is here. He is basically learned intervention nephrology from Korea. Today he is somewhere busy in Odisha. So these are the residents who have came to my house. What you can see, when Manas has came from Korea to develop this intervention nephrology at our place. These are few photographs. So this is our renal and transplant immunogenetics lab that is totally dedicated to Department of Nephrology. We all used to look after this lab, now doing HLA, whether this is single antigen VDSA, whether this is any cross match, flow cytometric cross match, fully equipped. Any test you can think of in transplantation that are done at our labs. So this is my parents, and audition is dedicated to my parents whose attitude towards education made me eligible for this audition. And definitely Dr. Vijay Prakash, who is our medicine teacher, taught me ABC of medicines. Two of my mentors, Professor Amit Gupta and Professor Sharma, taught me ABCD of nephrology. Professor Sanjeev Gulati, who taught me how to write the paper. So thanks to all these colleagues, particularly this is our colleagues, all residents and faculties at SGPJMS. And now we are learning remaining S to Z from all my colleagues and all my residents also. Something learns every day. So these are the fellows, PhD fellows, and our collaborator, Dr. Vikas Agarwal and Dr. Vinita Agarwal from pathology. And on the below there are few PhD students working right now in our lab. So these are the few patients, important patients who have the very full faith in me, shown faith in me, thanks to millions of the patients who showed confidence and faith in me. And this is my family photographs. We have, because of that, we have got the Bansal audition in 2006, Fuller audition in 2013, V.N. Acharya audition in 2023 at Kolkata. And this time, P.K. Srivastava auditions. I am very thankful to the Veincon for this, giving me this opportunity to speak this audition. And he is my son, Ashwini, at FMC Pune. He is in final year. Dr. Sudeep Prakash is behind sitting, and he is guiding him. And in the first time in the history, World Congress of Nephrology is happening at New Delhi. So, being the co-chair of the local organizing committee, I will invite you all to be registered here and make it a grand success. Thank you, ladies and gentlemen. Thank you for your kind attention.
I congratulate Professor Narayan Prasad, who has been very close to my heart. And now I think there is a felicitation program. We will not invite any question or comment as it was an erosion.
If anybody has, then I can take.
Thank you, Professor Narayan, for giving such a nice deliberation in Professor P.K. Srivastava Memorial Oration. And we really feel privileged and honored to hear your lecture, because from our time till date, you have summarized each and every achievement of the institution where we studied, and it is a really matter of great pride for me and for many SGPGI alumni who are sitting here, Dr. Gulati and Dr. Singhal and many more. Dr. Lens is there. And with these words, I think I will invite all the involved in the organizing of this conference. I invite Dr. D.K. Sinha, Professor Sivan Singh, please come on the dais so that Dr. Eman Singh, Dr. Himanshu, and we are going to honor Professor Narayan Prasad in the Professor Amit Gupta, Professor Ojha and Professor Hemant Kumar, and we would like to honor you with the medal.
So I know everybody's hungry. I'm sure this last 6 or 7 minutes are not going to make you sleep. There's something, when I was designing, I was thinking about the, this theme of, surviving beyond 10 years. I saw what is the ultimate thing, and what came as the artificial kidney. So then I actually Googled where it's being made. So the kidney project. And then actually I found out the person who is doing it. So Dr. Shiva Roy, he's the director of the kidney project. So when I went and I met him, we actually thought of having his talk in here, but because of some legal issues, he cannot have his talk outside certain, the limited meetings. So he's given one video message, which I'll be playing first, followed by there'll be a small video. It's about an AVF care workshop, what we do, what we believe is right for the patient. So that's it, and I'm going to play it now.
Thank you, Dr. Rama. I'm Shiva Roy, I'm the director of the kidney project. We've been working on developing an implantable artificial kidney. I want to tell you about the kidney project. It's an effort to build an implantable artificial kidney. It will work like a transplant and will be made available to anybody who needs one. It will not require immune suppression drugs. We have built a fundamental technology to show that we can construct the device and put it into animals and create good. Our next steps will be to make it larger for humans, do additional testing for the regulatory agencies like the FDA, and do the first clinical studies. I anticipate it will be the next 3 to 5 years when we get to the first in-human patients. After that, we'll partner with manufacturers and physician partners in different parts of the world, including India, to make it available to all those who need it.
So,
The dietitian, she has given us, different kinds of diets for different things like phosphorus, potassium, which we were not aware of. The doctor has given us a stethoscope to check on the quality of the fistula, whether it is, working good, you're having a good throb.
So thank you everyone, that's the end of today. The website AVF Care Workshop is live. I won't take time, you can actually go and explore. It's just the beginning. There are multiple resources. We intend to put more resources for doctors, the access surgeons, but this is specifically meant for patients, and a subset will be later on built for the dialysis technicians. There are ways to contact us. And this is a workshop which can be organized across platforms. It's not for Fortis Hospital, it's not for Max Hospital. It can be done, it can be initiated online, it can be initiated offline. Any group of patients, say some group of patient, group of dialysis technician, group of access surgeon can actually ask for it, and we can tailor it as per the need of them. So thank you, good evening, have a good dinner, and see you tomorrow morning.
कहाँ पे